Good morning and welcome. I think it's a good opportunity to interact because I remember 80s and 90s and it was difficult. But today things are made simple because we don't struggle for anything in life. Don't have to do carotid angiogram. I was talking to carotid angiogram, ventriculogram, pneumoencephalogram, myelogram. So life has become simpler. But it has faster and death has also become easier because lot of people those who die in accident is cut down the life despite of I don't know how many of you know NP Singh, professor of anesthesia at RML hospital. He started in 1978, saved the life in 180 seconds. That is a CPR course, but he did not say CPR, he said save a life in 180 seconds. He was meaning that 3 seconds is all, that 3 minutes is all that you have to revive with good CPR. That was meant for ambulance driver, traffic police and PCR van. Because they are the people, if you do not react at the time, it is too late. Coming with a person with no pulse, the casualty, and I was a casualty medical officer in 78. I know how difficult when the patient is brought by the relative with expectation that you are going to miracle. And they never felt a pulse. The ambulance they came in had no facility. I think now the things are different. You have ATLS ambulance and ambulance has some technician I suppose. So today things are better, but still then large number of people die because they don't have pre-hospital care. So they come in different stages and ultimately go to brain death. And when we start first case 4th August 1994, Dr. Boxy was our resident and we had a subarachnoid hemorrhage lady, and that lady aneurysm was cleft and she did not make it, and the relative were very cooperative in the sense, I remember that day, and they agreed that they will give cardiac transplant on all this. And next one is VN Singh. VN Singh was a BSF sub-inspector who came with an accident, not of course bullet injury, blunt injury, road traffic accident, and they agreed to give donations. So this is how a humble beginning started in 1994 in the month of August. It's a long journey. We didn't have organ transplant law. So Dr. Banerjee called me and said, there is a lot of legality and it's good that we do in good faith, save life, help to humanity, but tomorrow somebody can put you in a legal problem telling you have not followed the rule, followed the principles. I said there is no principle. It is better, you are in a better state that you don't have law. So lawlessness is better than sometimes law, because in law if you do not follow 100% law, you can be criminally punished. So this is how we started. Today of course, I remember Dr. Venugopal was very much activated in 1995 and we had 3 or 4 times brain death certification. Just before that, I think 89, Dr. Nandi wrote a book, Brain Death and Organ Transplant, small book. And he used to do a workshop 1989-90. And I don't know how many of us have seen a book written by Dr. Nandi. Anybody has seen? It was 89. I was in general surgery, I was in neurosurgery, and Dr. Nandi was my teacher. We used to talk about liver transplant. And I had a very good, because when I joined here in 1975, that is the year he came from Harvard Medical School. He had done FRCS and MRCP. So he was a physician having surgical background and he was trained in Rangoon. His father was a professor orthopedic at Rangoon. So he was not adjusted to Indian environment. He was not able to talk in Hindi and we are not able to understand his English because he has spent whole life outside India. Very difficult situation, but he was the man who maximally motivated me. With all the surgery I assisted in mid and late 70s before I joined neurosurgery. He used to do the liver linear shunt, portocaval shunt, large splenic resection or partial hepatectomy. I remember one day a case of hemophilia, bleeding from the gallbladder, and we do not have the test to know where from the bile is blood stained, and he was a professor in Allahabad University, Dr. Lal, K. Lal. And I was a resident in GI surgery. We could see the T-tube bleed and stop after for 24 hours. And we have to push blood so that otherwise the blood vessel will collapse. This is the situation in mid-70s. I had gone through a maybe good training, 7-year residency, 4 years of general surgery and 3 years of neurosurgery. I do not look back, regret that I had a wastage of my time, because Dr. Nandi used to tell me that we have to work 26 hours. Why God has made the day 24 hours? If it would have been 26 hours, we could have been doing much better for the human service. And he used to say, if a surgeon can survive 3 days without eating, only survive with water, he can prove to be a good surgeon. This is the type of training we had in mid-70s. But I think I am grateful to my teachers. What I am today, they never thought of earning money. Dr. Nandi could have earned a lot of money. He was in the Harvard Medical School. He spent a lot of time in Britain. He was the editorial board of British Journal of Surgery, British Journal of BMJ, and he had 3 or 4 times BM how to write a good paper. In 1985 to 88, he had 3 workshops when the BMJ editor and Lancet editor came to AIIMS and gave a course how to write good paper. Actually, I have tremendous respect, regards, and I learned many things from my teachers, Dr. Banerjee, Dr. Tondon. I think if people know Dr. Banerjee and Dr. Tondon, they are like a Brahma and Vishnu to like us. Because Dr. Tondon was so respected. At 95 years of age, he writes book. Can you believe? He still spends 6 to 8 hours in reading. Can you believe? Anytime I talk to him, I don't speak to my teacher. Once a week, he will say, what is wrong with you? Are you okay? I feel so upset that in spite of me ringing to my teacher, they ring me back telling, are you okay? This is the bondage, respect, understanding, love, affection we have for teachers. I hope in the birth to come, in my every birth, I saw a teacher like that. Thank you very much.
Thank you, sir. We'll begin the session of addressing knowledge gaps in brain death certification and organ donation from brain dead. I request Dr. Chavi and Dr. Ashish to chair this session. Yes, yes.
Morning. So I think I'm audible like this also. So we will begin. I thought just for lectures. Good morning everyone, and welcome to this interesting session. So we begin the talk with no other than Professor Matthew Joseph, and the top will be practical issues in brain death certification, troubleshooting, absent spontaneous respiration issues.
Good morning. I was looking at the topics and actually regretting the fact that I wouldn't be here for the latter half of this session because I have another session to chair at 10 a.m. in Hall A. So my job is basically setting the table. I'm going to give you the basics the normal stuff that everybody does, and then the people will come in and do the more interesting stuff, the more unusual stuff. So, very briefly, going through the whole process of brain death declaration. Okay, you must know the cause. For him, I wouldn't have a problem declaring brain death. Here, I would be a little suspicious. I would spend some time trying to make out if there was any other cause for the patient to be unresponsive. This is all standard stuff. I'm just going to go through it very fast. You must make sure that you haven't given drugs that make the patient brain dead. There are no other metabolic problems. There's no hypoxia, hypotension, hypothermia. All these things can cause the brain to temporarily be non-functional. And we should never declare somebody because of temporary dysfunction as having permanent brainstem dysfunction. Once you've finished that, you made sure that all the prerequisites are met, you go to a clinical evaluation for brainstem death. I'm going basically by Indian law, so the Indian process. So no motor response to pain. I mean, this is the entire list of things. I'll go through them one by one. I've always felt supraorbital pain. Pushing there to create pain is a pretty useless, not a very useful kind of pain, because it's not very painful. But the only time I use it is when I'm checking brain death. I use that as well, in case the patient has cervical spine trauma but the brain is still intact, you get something from here. Otherwise, I don't use that system. A lot of people expect pupils dilated. You don't need dilated.
Where do you give the pain? Sorry to interrupt.
I give sternum and this. Both. Okay? Otherwise, I never use this.
How about platysma and trapezius pain? What Glasgow has, what Dr. Teasdale has recommended, you pinch it with the thumb and the pulp of your index finger on the trapezius. It's very, very strong, painful stimuli.
Yeah, I'm generally not in favor of doing soft tissue pain. I prefer this and this in normal clinical circumstances. I don't really like causing soft tissue things because especially in our fairer patients, you tend to leave marks. So you can come tomorrow and say, hey, Matthew Joseph was there. See that big blue mark? That's Matthew Joseph. Yeah, I don't want.
You may have those spinal reflexes if you pinch the.
Yes.
What is the way of you recommend?
It's not consistent. Spinal reflex comes once. It doesn't come every time you give pain. Okay. And personally speaking, I've seen only 5 times spinal reflexes in about 200 patients. So anyway, so pupils don't have to be dilated. Alright, as long as they're non-reacting. You don't want pinpoint, but even mid-size non-reacting is fine. You don't need dilated. When you're checking oculocephalic, please hold on to the ET tube. I've done that myself. I have personally taken a head and done a flip this way, and the ET tube went that way, and the patient went this way, and I had an apneic, non-intubated patient. Corneal reflex, I use a swab stick, which I just use to tickle the thing, and then I take the same swab stick and I do a gag. So, 2 things at one. Caloric, make sure you do this. Make sure you do this to maximize the caloric stimulus. I'm not going into details of lateral semicircular anatomy, but make sure you've got your head flexed when you do your cold caloric test, because that maximizes your stimulus to the brainstem. Cough reflex, don't disconnect, break PEEP and do an ET tube suction. Just jerk the tube up and down, and that's a very strong stimulus to the trachea. You don't really need to do a thing. Apnea tests, what we tend to do is when we are going to start the brainstem, other brainstem testing, we bring down the respiratory rate by 2 or 3 and take the FiO2 to 100. Primarily sort of pre-raising your carbon dioxide. If you're at 35, getting to 40 or 45 before you start the apnea test, it's, in a way, I guess it's cheating, but it makes your brainstem death testing much easier. We measure the length of the oxygen catheter. We found this makes a difference. Basically, you want your catheter to be just at the carina. It's in the ET tube, most of the oxygen goes back up. If you go too far down, it goes into one lung. Don't overdo the flow. People, in their attempt to keep the oxygen high, put the oxygen at 15 liters. That actually ventilates. So that prevents your carbon dioxide from going up. That jet of oxygen actually removes carbon dioxide. Keep your carbon dioxide levels low, with your oxygen flow quite low. For people who have bad lungs, on whom when you disconnect they start getting hypoxic very fast. Those patients now what we tend to do is either use a Baines and keep the PEEP up, or we put on a ventilator at a very slow rate. We put a ventilator at 4 or 3 and allow the carbon dioxide, then you have your end-tidal carbon dioxide. And you let the ventilator rate go, the carbon dioxide climb up and see if the patient generates any spontaneous breaths. Again, I don't know if it would be recommended in any textbook, but this is what we do as means of, otherwise all the patients with bad lungs we cannot test. And we cheat as the carbon dioxide levels go up and as the patient vasodilates, you tend to have dropping BPs. To keep the pressures up, we sometimes do little purges of pressors so that we maintain our systolic above 90. Okay, there is a learning curve to this. Okay, and it's for the ICU, for your neuro ICU, there is no perceived benefit. So you need people in your team to be enthusiastic about it without any real reward, okay, which is hard sometimes. Most essential is have a protocol, okay, for everything, from how do you identify, how do you treat, how do you maintain, everything, have a protocol right up to the time the patient leaves your ICU for the OR for organ harvesting. Okay, this basically, I don't know what your experience is, but our ICU, we have a fairly rapid turnover of both doctors and nursing staff. Very few stay there long term. And a protocol basically immunizes you from changes of personnel, as long as your protocol is fairly detailed, explicit, and easy to understand. The protocol we have is, the Mohan Foundation, the multi-organ harvesting runs south a lot of India. So our protocol is on their website if anybody is interested. Okay, remember that there is always a shortage of organs, always. Okay? And we can lose a liver or a kidney or whatever. It has many points along the entire process. And I've written them there. Before you test, after you test, there's many points. We have lost patients. I mean, if you look at our protocol has lots of simple things like make sure unfortunately our old hospital, not right now, but where we were working until last year, our trauma ICU was on one floor, the OR was on another floor. You had to go in an elevator. All right? And our protocol has things like make sure the oxygen cylinder is full, make sure your syringe pump is charged. We have lost patients to all these things. You're in the elevator and halfway through your oxygen runs out and donor's gone. Okay? We've reached the OR, we're at the entrance to the OR, they're not ready inside. They make us wait for 10 minutes. 10 minutes for a patient who's unstable outside an ICU is an eternity. We've lost patients there. So our protocol covers all these eventualities, all the little things which are hospital specific. You understand? You have to have your own protocol which works for your hospital. Okay? So I'll stop here. My point is very clear. Make sure, it's a huge service, make sure that you do get every potential donor does become an actual donor. Should never have this situation. All right? Thank you.
Sometimes there is a discrepancy on the monitor and the set rate of the ventilator. There are no definite waveforms you see, but then we tend to prolong those cases, like probably the patient has got some spontaneous activity on the ventilator, not the real on the patient. How much importance and value you give, and do you wait? Because my understanding is if you wait for another 6 hours, 12 hours, probably by this time the organs may worsen.
Yeah.
So how do you actually, what actually is the time point when you say on the monitor? Because there is a lot of confusion and discussions amongst our colleagues also regarding this, what is getting on the monitor.
Yeah, so meaning my judgment of patient breathing or not is looking at the patient.
Not at the monitor?
Not at the monitor does weird things sometimes. I mean, I really don't, I'm not a great fan. Look at the patient chest is moving means there is something going on. If patient chest is not moving, There's nothing. Again, our protocol, we have a thing when you're doing the apnea test saying keep your hand on the patient's chest.
Yes.
Because there have been times, there was a time when we were looking, the BP was unstable. So everybody was staring at the monitor with their fingers on the pressers, pumps, trying to purge things. Patient was breathing away. That nobody noticed. Everybody's looking at the monitor. Patients, huh? Yeah, everybody looking at the monitor, patients breathing.
No, because
so
the reason I asked you, Dr. Matthew, was because so many times, my colleague will vouch for that, so many times we have dragged on this patient, even waited for a day to do the first apnea test, because the set rate on the ventilator is 12 and what you are getting on the monitor is 16. Yeah, and
Yeah.
sometimes you get those occasional respiratory pattern which is being shown.
Yeah.
And it is being told that it is spontaneous. It is a patient is breathing while clinically there is nothing. Brain is completely dead. Pupil fixed dilated. Everything is in favor of brain death, and we know this person is brain dead.
Yeah.
And if I do the apnea test, I will get the positive result. I am also very sure about that. But still, that mismatch is a very conflicting thing which we see.
Yeah. So what we do when we think this is happening is we decrease the sensitivity of the ventilator. You normally set at 2 liters flow, we make it 4 or 5. That has to be a definite breath. That won't be accidental, slight movement of the bed and the patient triggers and the ventilator gets triggered. Make it 4 is still quite low. It's still a very easy threshold to meet to breathe. So we tend to raise make the ventilator less sensitive.
Please.
Thank you.
Yeah, that's what.
If I understand correctly, there is no specific requirement for the EEG registration for that assessment. In which condition it is required to exclude the presence of brain blood flow?
So the best part of the Indian regulations is it is only clinical. No confirmatory test required. The terrible thing about the Indian regulations is it's only clinical. If you've got a patient with a smashed face and you can't see the pupils, you can't see the eye movements, you can't check, you can't declare brain death. But meaning there is no legal backing for doing a MRI, MRA, angiogram, TCD, whatever.
Because every center doesn't have the facility. Brain death can be declared at district level.
Yes.
And the organ has to be from to that center. If they cannot diagnose that, they would be doing injustice.
Absolutely.
But second thing, somewhere the caloric response is very important. There are 2 or 3 theses was written. Caloric response, that is a very, very good response.
Yeah.
So I don't think in Indian context we will be taking EEG or evoked potential, all this, because that won't be available each and every time. That's why when you make a protocol, it is not this ralo. It has to see from the.
So 22 nations are actually doing ancillary test, and even in India, I'm sure you know about it, that ancillary test.
We have ancillary test man there, chief ancillary test man over there. Yeah.
Sir, 2 things. Yes.
You can't assess the future response. Go for the ancillary test. And the best ancillary test of all is CTN.
Sir, we also do the same thing, sir. And about the other one, most of the ventilators, the sensors don't work on many occasions and they just sometimes fail. Even a small trigger in movement triggers a respiratory, the ventilator pushes air in that. So, as you said, we don't rely on the monitors completely. 2, whenever we have a patient for whom we are not able to examine the eye, not examining the eye rules out the 2, 3, 4, 5,
Everything.
6, 7,
Yeah.
all cranial nerves. That is almost, we test only 9 cranial nerves among the 12, and that is 2/3 of all cranial nerves. So in these situations and situations where there is a persistent metabolic imbalance or a persistent dyselectrolemia, we do CT angio. We follow the 7-point scoring system, and based on that we have certified patients as brain dead. In situations where there is a lung injury, persistent dyselectrolemia, or we wait for 24 hours, if you are unable to correct these things, then we go to an ancillary test. That's what we do, and that is legalized by the government of Tamil Nadu. Of course, we both belong to the same state. The GO number 75 in October 2008 clearly states that there are occasions where you are permitted to do an ancillary testing and if that is positive, you can go ahead and certify.
Can we have some take from the critical care on the anesthesia people?
But,
How much importance?
Is it available at district and sub-region level?
Yes, sir.
No.
Even tier 3
So
cities
even I have a
already do,
question.
yeah.
No,
Yeah.
just 1 minute.
Yes, sir.
Your law, will it hold good for Tahsil level, let us say CSC, community center,
Yes.
or sub-division headquarters? Do they have city angio?
Yes, sir. Almost all district hospitals in Tamil Nadu, they have a CT angio. CT angio is available, and
How
we.
often you do city angio?
Very often, sir, we are doing it. That is why even I have a question.
I got the mobile city almost 15 years back. We are not doing city angio.
No,
Yeah.
that is true, sir.
That
With
is all
changing
India
times,
and
with
you are telling district and sub-division headquarters.
no, sir, that's okay, sir. Maybe
No, that is
at
all right.
different levels we have to see that what facilities we have and how optimally we can use.
For the people across India.
No.
Yes, sir, we have for ourselves
We
also.
have-
Many doubts.
Thank you. 1 second.
Yep.
We have people from the TPM, we have critical care, neuroanesthesia, anesthesia, everybody here in this hall. I just want to be really doubly sure once again. I want a word of mouth from you. Mismatch in the, because I'm asking this question again and again because this is being discussed again and again. Respiratory rate mismatch in the monitor and the ventilator. Some trigger seen on the ventilator in a person who is actually brain dead, we know about it from the clinical, radiological, everything. How much importance do we give, or should we go ahead with the testing, with the apnea test?
Can I
Anybody
put it in a,
comment?
sir, can I put it in a different way?
No, let me ask you, the question is not right. Mismatch means you are seeing 5, that is also.
It's okay, it's okay,
You are
it's okay.
against seeing 3, na? The question is
That,
that. no
so I'll,
respiration
may I
or-
put it in a different way?
Ma'am,
So
actually,
this is,
as
yeah.
One second.
Deepak has
Let
said,
Ashish say, no?
it is just a mismatch, which means the
No,
patient
no,
is
no,
definitely
what
not
is-
breathing.
Let me ask you a question.
But
What
there are
is-
lot of settings in the ventilator and the monitors,
No, we
and the
have done
patient's patient.
We change the mode also, from the pressure triggered to the flow triggered. We change the sensitivity also.
Yes,
Still
sir.
there is some
In
mismatch.
such situations, what we do is, you are clear the patient is clinically brain dead. You are subjecting the patient to apnea test. If the patient, the mismatch is really a breathing attempt from the patient, he should breathe during the apnea test.
Take it out, ventilator.
Exactly. Yes.
That's exactly.
Now you caught me right.
So
Yes.
that means
So if
that.
the problem is you are prevented from doing the first apnea test.
Exactly.
Saying that there is some mismatch, patient is having a spontaneous respiration. So I want the thing to be extremely clear.
Clear.
That
See, if
cannot
that
be discussed
patient
here.
is subjected to an apnea test, he is definitely going to breathe. That is where we should look
So
at.
you can do the apnea test.
Yes, we have to do the apnea test.
As
do the apnea test, but then also respect that if he's breathing or not. Maybe the efforts are not very adequate to maintain the airway to clear the gases,
Ma'am,
but if he's
during
breathing,
apnea test, if you have seen a patient breathe, it is a huge sigh.
that-
you
that
will
is what-
never miss it for a breathing. I have seen it. If you see it once,
if
it's
even if
not
you
a
see it
faint
once,
attempt or just trigger and other things, it will be a huge sigh of breathing. That cannot be
I
missed.
think presence of respiration cannot be taken as that. You have to be very sure the respiration
the
not.
question we are discussing currently is that if you see some mismatch in ventilation and the
What is,
actual
I have not
respiration.
understood mismatch.
Sir, the
I don't-
thing
no,
is-
no,
Okay,
no, no, no.
okay, can
I
I-
am not clear your question.
Dr.
Mismatch,
So let me
mismatch means
clear it, sir.
your ventilator and the monitor are mismatch.
No, no,
Not that
No.
the patient breathing and the monitor.
No,
Your
doc-
question is wrong
Quest-
to me.
No, Dr.
You have already
Mahapatra-
premises
Dr.
that patient has
Mahapatra,
stopped
the
breathing.
question is, you've set the rate at 12. The ventilator is showing the patient breathing at 16.
That means you have not known what is the brain death.
No,
Patient are breathing.
no,
put
no,
in the
but very often that is a fallacy.
So,
It's
so
not really
that's
patient breathing.
let us put it in another way that my question is like if one or two parameters are not meeting as the criteria of brain death, like some sodium is high or there is some hyperthermia, there is some electrolyte or metabolic imbalance or endocrinal imbalance, should we proceed? Rest of the things are there which fulfill the criteria of brain death. So can we ignore these 1-2 things and proceed with apnea and formal testing of the brain? Because this happens many a time. That
you-
we,
Legally will not be allowed.
You
For the
have
sodium,
to meet
sodium
the-
160 is the cutoff. Below 160 you can pursue. So all those set guidelines which are.
so sometimes we have little higher,
No,
sometimes we have
never,
hypothermia.
we We never.
No, the people tend to be very hurriedly taking the decision. This is the one single parameter, just 4 breaths on the monitor. It's nothing, it's fake. So that because we are desperate in thinking that we may lose a brain dead, so that is why these things always come in mind and in clinical practice also. Do you tend to?
I have a point.
Yes.
Above 160 sodium is an independent factor when everything else is normal that can mimic brain death.
Yes.
That is the one reason we have it as a cutoff. But the other thing I want to tell you is, if you are not able to bring that patient within that criteria, you can wait for a period of 24 hours. If not, you should go to an ancillary testing. That is
So
what we
ancillary
do.
tests are becoming important, and you are
Important,
saying that
important.
CT angio is should be the thing to go about.
Hey, one sec, here. Yeah, come.
I can speak from here. Okay, the only thing I can do here is share my experience with you. I work in a hospital with around 50 donors per year, and I've been working in the ICU since 2005. So do the math, a lot of donors all these years. From my experience, from what I've seen so far, I have never testified a single case of mismatch if you program accordingly the ventilator. Usually what we do is we set the trigger to pressure trigger to -2, because the only problem we may face is the pulse. As you know, when the apnea test goes on, the pulse is very, very strong and might induce self-trigger. So if we set it to -2, I have never seen a single case of a false result. And those, as you said before, those that are still breathing, somewhere in the middle of the apnea test, they will breathe. I mentioned the case I had a few months ago of a woman. After 5 minutes of apnea test, she started breathing, and she wasn't breathing before. So if they have to breathe, they will. And if you set properly the ventilator, you won't have any problem. That's my experience.
Yeah, so this is exactly what I'm saying. It's not about desperation to do the apnea test. What I'm saying is, in case there is any doubt, that will be picked up during the apnea test. And then you've got one more apnea test to be done after 6 hours. So what I'm trying to say is, do the first test of test in a timely fashion. Now what commonly happens, is my personal experience, is because of the respiratory rate, I'm again and again using the word respiratory mismatch. Having said everything, including changing the ventilator from the pressure control to the flow control mode, decreasing the trigger from -3 to +3 to -3, doing everything. 12 on the ventilator you have set, 16 or 18 you see on the monitor, and sometimes the occasional spikes of the respiratory waves which you see on the monitor. And because I'm not a critical care person, I'm not an intensivist or anesthetist who can actually say with authority. I can say with authority on the CT scan, on the neurosurgical things. Ventilator, monitor is their domain. So I want it to be very crystal clear in those cases why the hell we cannot pursue with the first apnea test. Of course, if the person is going to be positive, there will be some spontaneous respiration. Now what commonly happens is, you do this in the morning, and it is being told during the rounds of the consultant that this person is having spontaneous respiration on the ventilator. So the next time it comes, if you're not vigilant, you go to the theater, somebody else goes, it's 12 hours later, or maybe next day morning. And
So
by
if
this time-
constantly
by
during
this
that
the
time it
person
is
not
16,
there.
then
Okay,
what should
I
be the-
understand, but once again, if I don't care about the monitor, truly, I don't care.
Period.
I look at the patient.
Period.
If I see anything, my own eyes will testify. I don't care, because monitors can lie to us.
I think clinical judgment overtakes.
And you are totally correct. If something has to happen, it will happen during the apnea test. But I look at the patient.
Thank you so much.
the patient and the monitor and the anesthetic and the surgeon. That's the take. So we go to the next talk. We go to the next talk by Madam Nuria. It's Nuria. Intensive care oriented to organ donation. We welcome Nuria once again.
Thank you. Good morning, everybody. Thank you for giving us the opportunity to join us. And I will talk from a very different perspective. We have been discussing now how to determine brain death. And my talk is about how to detect more donors in our centers. So ICOD practices is one thing that we started to do in Spain in 2008. And we have the same discussion that we have been having here. We won't be, we don't want to deal with this thing as intensive care doctors, as neurologists, as neurosurgeons, but finally we do, and we have had great results. So what means ICOD? ICOD means to admit someone in the ICU only for the proposal to become a donor. That means someone with a devastating brain injury who is detected in a stroke unit or emergency department, who the doctor in charge decide all the treatment will be futile, and explain to the family the situation is irreversible. If they understand that, then a transplant coordinator approached the family, and the patient was admitted in the ICU only with this purpose, to become an organ donor. So the admission is just to wait until all the reflexes were lost, and finally brain death determination is done. So it's a very different perspective that you have been discussing now. You have a patient, you admit him because you think you can treat him and improve and discharge, and things go wrong, and then we have brain death. So just listen me. Don't think you cannot do that. In the future, you will do. If you remember, we talk about that because we need to have all the same language. And as I tell the other day, the important thing is to be proactive. We know we don't have organs for our patients. We all pursue self-sufficiency as a country to get to someone the opportunity to continue her life. So we have to be proactive as doctors. Then instead to start the process in the potential that we have in the ICU, we have to move outside and to start the process in the possible donor. And that means go outside. For that we need shoes. You remember yesterday what the coordinator needs? Shoes. We have to go outside of the ICU, outside of our box. That is our natural place where we feel comfortable, but we need to move. The important thing is you have to establish a protocol in the center, because all people has to be confident with that and comfortable, and that's very difficult. It's not one thing that you could decide, write in a paper, and it's done. There you need a lot of discussion, like you have been here with brain death determination, just to make that all people accept that we can do this kind of things, because a lot of things are in discussion. There are different perspectives, there are cultural situations that you have to have in mind and include in the protocol. The other important thing is the careful selection. You cannot admit every patient. You have to select. And the problem is sometimes you are not sure that this lesion will evolve to brain death. When we start in 2008, we have this problem. And the problem is, at that moment in our country, DCD was not allowed. So we have a problem, because we have to convince the family to allow us to admit the patient, to wait until brain death occurs, and then to start the donation procedure. But if this doesn't occur, if the patient doesn't fulfill brain death criteria, then we have a problem. So what we have to learn at this moment is, if we don't have this criteria, we have to withdraw all the treatment, because we have created a situation that if we don't have a start, the treatment doesn't occur. So again, we have to relearn how to treat these things. It's important for us, probably our culture is different, and the autonomy of the person is very important for us, what I want to decide. In other cultures could be different, is more social or more familiar, whatever. But in our country, it's very important that someone has living will. It's not around 10% of the population has done their living will, but they help us to start the conversation about organ donation if they have made a decision previously. And what about the family approach? It's completely different that we have done these previous days, because as I told you, the patient is not dead. So we suppose the evolution will be to brain dead and then become dead. When we make the first approach, the situation is very bad, so the prognosis is very poor. But we are not, we don't have the certainty that he will die in brain death. And that, for us, was a concern and was difficult to deal with that situation, because we have the perception that we are building something very, very tricky, very difficult, no? And well, you need to be convinced that you are doing the best for the patient. The other thing is we have to convince our colleagues in the ICU that this is a good practice. ICU doctors want to save life, and to admit someone who will die is controversial for them. So it's another thing that we have to work together to understand that we are doing the best for the patient and for the future recipients. We plan to define what we call an end-of-life pathway regarding the one we have with the different types of organ donors. And what we explain to our colleagues is that a transplant coordinator could intervene in every part of the end-of-life process. In the very beginning, when the injury is done and someone decides that all treatment is futile, or in the middle of the process when they change the objective of the treatment, it is not more curative treatment, it becomes palliative treatment, or when the die is very, very close. So they have to have in mind that we are there and we can counsel them and we can counsel with the family to arrange this end-of-life care. So my proposition is to go to be different, let's say, okay? And you have to rethink. I know it's quite soon maybe for you to listen this, but well, you have to have that in mind, and in the future, you can rescue this talk. I know you have doubts about what I say, and one is how appropriate it is to do that. We have been dealing with that because I don't know in your culture, but in mine, the most important thing for us is the dignity when someone dies. And the dignity is very personal. What for me it's important could not be important for you or for you. So it's very difficult. And if we don't ask about what are the values of this person, it's very difficult to know if we are doing good or bad. So that's one point. And the other is futility. If we are saying that we don't do certain treatment because it's futile, why we start another thing? We have to think about cost, about effectiveness, about justice. But at the end, if you have a donor, the cost efficiency exists, and you are trying to save other lives. So there are some articles about qualities, and you can say that this is efficient in that sense. Okay. You know that we have a scarcity, so we have to maximize these opportunities, and this is a line to increase it. We see yesterday that we have another one, is DCD, but well, first of all, we are dealing with brain death, so we have to improve all the possibilities regarding brain death. Much controversies that you can think about these days after that. You have to decide with your family what is appropriate and acceptable for them in end-of-life care, because you will be surprised. We have a lot of prejudices as professionals, and we say, no, for sure they don't want to accept it. Ask them and leave them to take the responsibility. That's very difficult, I know, because it's not a very good situation for us. We feel uncomfortable. We deal with uncertainty, but we have to do that because it's our option. And I list you different things that could make some difficulties to us to implement these kind of things. You know, some of our colleagues write, do not resuscitate orders. That means the family knows about that, and then it's very difficult to offer the option of organ donation if someone has write that. Someone doesn't want to be treated in intensive manner, so that's an option. We have to respect that. And the major concern were about the professionals. They are reluctant to new things. They don't want to hear that they have to change their way of working, and you have to counsel a lot with your colleagues. That's your job from now to the future. So it's an option, ICOT, to increase the donor pool. It's not sure that you use a lot of resources. By ACORD study, we learned that medium stage stay is 3, so it's not a long stay. And what is important is that your institution agree with this type of way of work, because if not, you will be very alone and you have to fight with all the system, and that's very exhausting for you. Many ideas, many things, but I hope you can think about that, you can organize your ideas, and finally you can deal with this kind of approximation to organ donation. Thank you.
I have. Is it on?
Yes.
Okay. I can't hear myself. Anyway, my question is, when you put a patient in like this,
Mm-hmm.
do you do any treatment or do you stop treatment? Suppose the patient is breathing but otherwise is practically brain dead. Do you continue, say, sedation, ventilation, etc., active treatment because the patient is not brain dead yet?
No, what we do when we admit someone as a potential donor, we start what we used to do when someone is brain dead. So that is, we make the lab test, we make the exploration, the imaging test, and so on, just to be sure that it's a suitable organ donor. Because if not, we have to stop the treatment, talk to the family, first talk to the family, saying that we have found, I don't know, a neoplastic thing, or something else, and then stop the treatment. Because as I said, we start ICU treatment in a patient that we know that he will die. So if he doesn't die in the condition that we pursue, we have to stop.
So once you've identified a patient is probably a donor, you don't, and treatment is futile, you do not continue treatment until declaration. I'm talking about treatment for the primary disease.
The thing is, one thing is the treatment to make the patient survive. That's not the point.
It's not.
No.
Okay.
But the problem is when you have someone in brain death or evolving to brain death, you have some physiological changes. And you know it. What we do with the treatment is minimize the effect of these changes. So we control the temperature, we control the pressure, we put antibiotic, we make ventilation in the proper condition just to the lung to preserve them. So we do active treatment, if you mean.
But not for the primary disease.
No. No. We are focused on the future.
Do you need to get permission from the family or notify them that you're doing abdominal imaging and others, because they know that other things are being done besides what Dr. Joseph was asking, that this is not the primary disease management?
No, they know. No, the fact is they know the cause of admission to the ICU is to become a donor. The problem is when to approach in the emergency department, when to approach this family regarding organ donation option. Not always is feasible, because some people doesn't want to listen about that, and then we lose the option. But when then want to listen us, maybe we can build a process.
Many countries have set up registry for the declaration of the end-of-life treatments. I think that also in Spain you have such. Do you commonly consult this registry to see what were the decision of the patient in life about end-of-life procedures or not?
We don't have a register properly. What we have is, for example, from the transplant coordination, we follow up all the patients with Glasgow Commander 8, and we don't decide about that. But if the doctor in charge talk about limitation, then we said, hey, do you think this guy could be a donor? Then can we plan an approach to the family? But it's not a register. Every center has their own solution. No, we do before. That's the point.
Before.
Yes.
It's not brain dead.
No.
But potential has the potential to become brain dead.
Yes.
And can be a prospective donor.
Yes.
At that stage, you don't treat the primary disease, but you try to maintain the graftability of the organs.
Yes.
That's what you say.
Before we start this kind of working, what happens is the patient arrives to the hospital, the emergency department decide nothing is possible to do, and they remove the tube. So instead of removing the tube, we offer the option to wait until brain death is
So
achieved.
instead of DNR, you give an option of going ahead with being a potential donor and going ahead with the organ.
Mm-hmm.
Okay.
Spain has an opt-out system, isn't it? Everybody is a potential donor, deemed as a donor.
Yes,
But if there is no, is it a soft opt-out or is it a hard opt-out?
it's a soft. Yes.
So if there is no family member, where do you take the consent for?
If there is no family member, we have a problem. We don't used to, because we are Latins and we have families normally, and someone appears. But I remember maybe 4 cases in no one appear. There is no option, because the problem is we not only need the family to have the family consent, we need them to to talk about how is this guy, what he used to do, what kind of diseases he has before. So if we cannot do that, we cannot use someone because we don't know nothing about him. Yes.
My name is Ajay Sharma. I'm in minority over here, being one of the few transplant surgeons here. So if we have such kind of a potential donor whose relatives are not traceable, and we are very well aware of that person's history and the reason for death, if we are very clear, if there is slightest doubt, the coroner will be informed. So in that case, if there is no next of the kin available, then the owner of the body is the hospital administrator, the CEO of that. It is for him or her to really determine that. So on one hand, we would not really like to go for the organs to go waste. At the same time, we would not really, none of the transplant surgeons or the organ donation team will be in a position that the organ donation system comes to a disrepute. But yeah, by the time lots of information has already been really taken about the antecedents of that patient and the events leading to the death.
Thank you. We asked sometimes the coroner to help us in the decision, but he said it's not their field and they don't want to, so then we don't proceed.
Thank you.
For that informative talk. And next, I would like to call Dr. Eduardo for quality systems in donation and transplantation. Dr. Eduardo.
Okay, once again, good morning to everybody. It's a pleasure to be here once again. I've repeated this in the past 2 days, but it's true. Really a pleasure to be here with you again. Okay, so let's talk a little bit about quality. Quality is something that everybody is looking for. If you buy a car, you try to check if that car has a quality. Even if you buy a toaster, you want to know if that toaster has quality. So quality is in our lives every day. So that's one thing that we don't really feel the presence of quality around us, but it's really around us every day. So medicine and organ donation and transplantation, they are not different. So in order to put all this together, we need, of course, quality. But in order to know if we have quality or not, we need tools. We need to know what we are doing. We need to know what we need to do, what is missing around that, why some things are not going the way we wanted them to go. So that's the need for quality that we have also in these situations. A lot of protocols all over the world, but we have a few time. I will address to some of the European protocols that we are still using. So everybody is used to a lot of tools to measure quality in healthcare situations. Everybody is aware of this listing here. And as I said, when we engage such a program, we look for quality, as I said, safety. All the procedures that we are performing, they must be safe, not only for ourselves, for our patients, and in the case of donation and transplantation, for the receptors. Everything must be ethical and legal. The idea is to have everything documented and very transparent. We don't want the wrong word to go outside. We don't want anybody to have a suspicious or to be suspicious about what we are doing. And of course, we seek for continuous improvement. So these are fundamental rules for our daily basis work and for the image we want to pass outside for the general population in order for them to have a good idea of what we are doing. And for that, we invented the so-called quality indicators or the key performance indicators, the known KPIs. And of course, any quality system, it should periodically measure and evaluate all relevant aspects of the healthcare that we provide. So this is the key rule of any activity in this particular case that we are talking about, the donation and transplantation. So, a good system should gather all these characteristics. We should look at the structure. So, what resources do we have? Are they organized? Do we have protocols? Do we have circuits well established? We should look also at the process, which means in which way are we providing the care, the necessary care. Those protocols, we may have the protocols, but are people following those protocols? Do we have efficacy on those protocols? And finally, of course, the results. If we think a little bit, we will conclude that generally people look at results. Results is what matters. So everybody wants results. But in order to have results, we need a good structure and we need an effective process. Otherwise, we won't get the results. Or we will get them, but not the results that we wanted, not the results we aimed for. These are two examples of quality systems, of protocols that came up in Europe. I will focus and address to the ODECOS project. It's a project that I particularly like because this project has some virtues and gives us a lot of tools that we can choose. Of course, we don't have to use all of them, but we can choose several tools from this protocol and we can establish a good quality system on having that as a base. And the methodology followed here is the usual: plan, do, study, and act. And if we follow this methodology, I'm quite sure anything won't be left behind. And the ODECOS has the virtue of gathering regular monitoring of the quality indicators and gathers this, joins this with the commitments to take action, to discuss the results, analyze the causes, why things are not going so well, and define a plan in order to improve what has not been going so well. So, and another great virtue of this quality system, it focuses or it addresses living donation, DBD, and DCD. So you have tools within this system that you can evaluate all the types of donation. And it also uses quality indicators to evaluate structure, process, and outcomes. And then gathering all this together, making the soup with all these ingredients, you can have an effective approach to the healthcare system in which you are working, and you can in fact improve processes and outcomes with this as a base. This is an example, a huge list. I underlined a few of them that I think for start it would be important. As you can see, you have everything around that. If you take a look, and this is public, so you can see this on the internet, but you have indicators for everything, and depending on your needs, depending on what type of program you are trying to establish, you can pick up all types of indicators that will suit your needs. And you see that they will address both, in this case, in this list, both DBD and DCD, and also structure, process, and outcomes. So, summarizing, because I only had 10 minutes and I don't want to extend too much, summarizing, the great virtue of this quality system, there are others of course, and this is only one example, we don't have time to go through all of them, but the great virtue of this ODECOS system is in fact that it's very complete, addresses to every problem that we may face in our systems, and we can adapt it to our own realities. So thank you very much for your attention. If you have any question, I'm available.
I am fully convinced that applying quality system in healthcare is a matter of changing mindset, because quality system are a lot of papers, documents, and indicators. But if you remain on the papers, you will have no quality. Probably the most difficult thing, I think, in my experience, surely, is to make people change the way of considering this aspect, and to think of the fact that the quality system is a way of approaching problems despite all the documents and indicators. So it is also a matter of education. My question is, in your experience, what do you think about that also education can be included in the process of assessing and promoting a quality system in healthcare?
Education is included in this huge list, and it's of course very important. In fact, these quality systems in practice are a pain to everybody who works on a daily basis. This is a real pain. What's the virtue of this? In my opinion, is to identify what's wrong and to educate also to educate people. Because if you show your partners, we are doing this in a good way, but that thing we are not doing so well, and what shall we do to improve this or to overcome this problem? And this is also a tool of education, even though it's a pain. I agree with you.
Of the hour, and probably with growing centers taking up organ transplantation, that should be actually dealt with, and especially making a protocol and improvising is the need of the hour. Thank you very much for this elaboration.
Just to finish, I would give you a simple example. Imagine you have 50 donors, 50 actual donors. Of those, you have 48 effective utilized donors. But what happened then? What happened to the recipients? Did those transplants go well? You don't know if you don't have tools to measure that. You may be very happy with what you've done so far, but did that result in something good for the population that you are serving? So I think the great virtue of these systems is to evaluate what you are doing and the quality of what we are doing. Thank you.
So next we invite Dr. Thomas Nakagawa for telling us something about pediatric brain death. So the topic is determination of neurological death in children, challenges and considerations.
Well, good morning, everyone. It's a pleasure to be here amongst esteemed colleagues, wonderful talks, and of course our neurosurgical colleagues. This morning I was asked to talk about challenges in the determination of neurologic death in children. And so I'm going to spend the next 10 minutes or so going over specific areas. I come to you with going on now 35 years in critical care medicine, close to 35 years, and a lot of my focus has been on neurologic injury. And I've probably participated in more than 325 brain death examinations throughout my career. I've also consulted on many of the high-profile U.S. cases that you've probably read about in the news as well. So what I want to do is provide you with our experience in the United States, understanding that brain death, whether you're in the U.S., whether you're in India, whether you're in Japan, wherever you are, is the same thing. It's a clinical diagnosis, and it rests upon loss of neurologic function. So with that, my disclosures are listed here. I do not have any financial disclosures directly related to this presentation. I will let you know that I do serve as a medical director for an organ procurement organization in North Carolina as well. So I want to talk about important factors that can impact the determination of neurologic death in infants and children, and then we'll examine specific issues related to those challenges. So for some of you who are in the Transplant Institute meetings, prior to this, you've heard me say this, and this is our mantra in pediatrics: kids aren't small adults. Adults may be big kids, but kids are not small adults. And kids are different. And the management of adult patients cannot always be generalized to children, because we have a wide spectrum of age that we deal with. We deal with everything from the newborn period up to 18 years of age. We have differences in disease and mechanisms of injury, and the response and also the outcomes, including mortality, differ in children based upon those diseases and the mechanism of injury. And there are anatomic and physiologic differences that exist in children based upon the age of the child. So a 1-month-old is different from a 1-year-old, which is different from a 10-year-old. The 4 areas that I want to concentrate on for the rest of my talk will be apnea testing, neurodiagnostic studies, age-related issues, and metabolic disturbances. So the first thing that we're going to talk about is apnea testing. And Dr. Joseph, we had a nice discussion about apnea testing. We're going to talk about some of these challenges that we see in pediatrics, which is patients that are supported with extracorporeal membranous oxygenation, ECMO, advanced modes of ventilation that we utilize in pediatrics and also probably in adult medicine, complex congenital cyanotic heart lesions that we see in children. We'll talk about blood gas analysis, because we do have to get blood gases, and then we'll talk about what we do with high-dose sedative therapy. So let's start out with apnea testing in children. Apnea testing in general is basically testing for brainstem reflex. And there's a lot of different ways that you can do this. Now, in adults, they may use T-pieces, they may use CPAP. We typically don't use those in kids. The problem with the T-piece is that you lose all your end expiratory pressure. If you don't have end expiratory pressure on there, kids de-recruit very quickly. So will patients with bad lung disease. Tracheal insufflation is not recommended because of the risk of barotrauma. So we have a smaller endotracheal tube with a catheter going down the endotracheal tube in flows of 6 to 8 liters of oxygen. Dr. Joseph mentioned this already. You get CO2 washout, so it takes longer for that CO2 to rise, and it takes longer to do the apnea test. That's not necessarily such a good thing. If you don't have good excursion, then you just trap all that air, and the lung gets bigger and bigger and bigger, and you run the risk of barotrauma. That's a danger in kids, so we don't use T-pieces or tracheal insufflation in kids. We do use typically a flow inflating bag valve system, and we titrate PEEP. And in this particular picture here, you can see the flow inflating bag system here, which is a typical anesthesia bag, and you have a manometer on there, and if we zoom in a little bit closer, you can see that pressure manometer, and it's titrated to a PEEP of 6, and we control our flow through this flow valve here, which is the amount of oxygen coming into the system. We maintain end-tidal CO2 monitoring in there, and the combination of looking at the patient and looking at the monitor, okay, and that's why the monitor is stuck up here, up in the corner, which you can't see, but we're looking for that, because if there's any respiratory effort, you're going to see that bag collapse. If there's any respiratory effort, you're going to see a blip on end-tidal CO2, and if there's any respiratory effort, you should see chest rise. Now, it doesn't make any difference whether it's a small breath or a big breath. A breath is a breath. We don't make the distinction between that. If the patient shows any signs of respiratory activity, they do not meet criteria for neurologic death. That's just the end of the story. We do use advanced modes of ventilation in the ICU, high-frequency oscillation ventilation. And these kids are typically placed on an oscillator, which gives you very, very fast, rapid breaths, very much like how a dog breathes when they're panting. And what this does is it increases the functional residual capacity and helps with CO2 excursion. Now, the problem with this is that you're using very high mean airway pressures. And when you use high mean airway pressures, the minute you take them off the circuit, they de-recruit very quickly. So when we're dealing with high mean airway pressures, whether either through high-frequency ventilation, jet ventilation, or conventional ventilation, the thing that we do is we take a vascular clamp that in a tracheal tube, disconnect the patient from the circuit, put the anesthesia bag on there, release that clamp, and then titrate our PEEP. That way we don't lose our functional residual capacity, and it allows us to maintain at least a longer duration for that apnea test. Patients supported on extracorporeal support, ECMO. We're seeing more and more of these patients. And the question is, how do you test for apnea on those patients? Well, basically what you do is you basically turn the sweep gas down, let the CO2 rise. Now, that rise in CO2 takes longer because our oxygen membranes and the exchange of gas is much more efficient on ECMO. The nice thing about this is, even if it takes 45 minutes, you can still support the patient because you can just increase the flow or vasopressors in an effort to support the hemodynamics. So anytime you can't complete any examination, whether you're on extracorporeal support or whether you're on just conventional support, if you can't complete the examination or the apnea test, then you're going to have to do an ancillary study. We actually wrote about our experience in 2014 in pediatric critical care medicine. There were 4 patients from 2 institutions that we looked at who were supported with ECMO, and we came up with a standardized protocol which was decreasing the sweep gas to allow the CO2 to rise and increasing your FiO2 sweep to make sure that they maintained adequate oxygen saturations. They would be taken off ventilator support and they would put on a flow inflating anesthesia bag like I showed you before, and we'd monitor for apnea. This is also exemplified in the 2020 World Brain Death Project guidelines, which is also in the pediatric section, and a whole section on extracorporeal support. Now, in pediatrics, we also deal with children that have congenital cyanotic heart disease. It's something that you're not seeing, or you may see more frequently because many of these children are living into the adulthood now, but they're typically cared for at specialized cardiac centers. The thing about cyanotic heart disease is most of these kids live with oxygen saturations between 75 and 80%, 75, 85%. They're not normally saturated like you and I are. And so our guidelines state that if the patient desaturates to 85%, then we should terminate the apnea test. Okay, for safety reasons, obviously. But here lies a problem. There are no published reports on how to approach a patient who is cyanotic. So the patient with cyanotic heart disease is in a desaturated state, and that's different from actively desaturating. This is where they live, and no patient that has been in a desaturated state has been studied to determine how low you're going to allow those oxygen saturations to drop before you terminate the apnea test, because the threshold for hypoxia is much narrower than you and I. So in this instance, you can't really do an apnea test. You have to do an ancillary study. We have to get blood gases throughout the apnea test to see if we meet the threshold. And there have been times when you can't get an arterial line in patients. People say, well, just get a capillary blood gas or a venous blood gas. The question is, does that suffice? There is very little in the literature about venous or capillary blood gas sampling. And the problem with that is we don't know how that necessarily compares with arterial blood gas sampling. We do know that for most of us right now, there's about a 4 to 6 torr difference between the arterial and venous CO2 tension when we look at a blood gas. But the importance of the blood gas, we know and have validated that CO2s on an arterial sample are accurate. The importance of the arterial line isn't just for the blood gas, though. It's also to maintain and monitor hemodynamics. And you can't do that if you don't have an arterial line, and you can't be cycling the blood pressure every minute to figure out what that arterial pressure or your mean pressure is. And so from that standpoint, we run into problems, because if the patient becomes hemodynamically unstable, you have to terminate the apnea test. We actually use transcutaneous CO2 monitoring to give us an idea of where that CO2 level is and when we should get the blood gas, because people say, well, I get it at 3 minutes, 4 minutes, 6 minutes, 8 minutes, 10 minutes, whatever. What we found is that if you use transcutaneous CO2 monitoring, it has a high correlation of accuracy with minimum bias compared to your arterial CO2 monitoring. So if you have this available to you, you can actually shorten the duration of the apnea period because you know when to get a blood gas instead of guessing. Now remember, the CO2 rises about 4 torr for every minute on a brain dead patient. What about those patients on high sedative therapy? Well, we know that barbiturates and high-dose sedative therapy suppress CNS activity, and they can affect EEG monitoring and respiratory drive. Well, in situations where we have high-dose therapy, you can allow for natural drug metabolism. You can follow drug levels if you can get them. Pentabarb levels may take days for us. Or you could do a cerebral blood flow study. Bottom line is, cerebral blood flow studies are not affected by high sedative levels. They're not affected by high barbiturate levels either. Now, people will tell you that. They affect metabolic rate, but barbiturates do not arrest cerebral blood flow. Because if barbiturates arrest cerebral blood flow, we probably shouldn't be using them in clinical practice. EEG, radionuclide cerebral blood flow studies are the two most common tests that we use in kids. EEG is falling out of favor, and both of these studies are less sensitive and reliable in infants. Neurodiagnostic studies, as we said, in the infant are different because they have an open cranium. This is like a decompression craniotomy or open craniocerebral trauma. They don't generate those high pressures. They don't develop that rostrocaudal herniation. So we have to be careful with our ancillary studies. These studies that are sometimes used in adults have not been validated in children, so we can't use those. I will tell you that cerebral blood flow is probably the primary study that's being used. Loss of neurologic function with neonates can be very difficult. And in neonates in the United States, those are children greater than 37 weeks gestational age. In Europe, it's 36 weeks. We have no guidance on premature infants. So those infants have to grow to a point where they're 36 or 37 weeks gestational age. If we don't reach that point, then you can withdraw medical therapies and then they can die a circulatory death. Metabolism or metabolic diseases, hypernatremia is common because we use 3% saline. Again, that serum sodium threshold isn't known. We see kids that come in with serum sodiums of 190 because they're dehydrated in the early phases of life because they're not getting enough breast milk. They breathe, they open their eyes, they function. So we don't know what that threshold is, but we try and correct those electrolytes to a normal balance. And then also in children, we have to think about inborn errors in metabolism that can affect the liver, like urea cycle defects, because hyperammonemia clearly can cause CNS depression. So in conclusion, children are not small adults. We have challenges when attempting to determine neurologic death in children. Anatomic and physiologic differences really can complicate testing for neurologic death in children, so you need to understand those nuances. Neurodiagnostic studies are limited as far as their reliability, especially in smaller infants and children, and therefore we take more caution in trying to determine death in the neonate or the small infant. And that's why it's okay to prolong that, but if you prolong that determination, you still have to support the patient because they haven't been declared yet. That is our responsibility. They are still a living individual, and we have an obligation to support them. So I'll stop there and entertain any questions that you might have, or if we're short on time, we can entertain questions afterwards.
Thank you. My question is time intervals between testing based on age.
Yes.
What is the current things that you follow?
So in the United States, currently for children greater than 30 days of age, it's 12 hours between the two tests. For children less than 30 days of age, it's 24 hours. Now, those are arbitrary time periods. Why do we do that? We've been highly criticized for that. The reason we did that is because you have to standardize brain death testing. That's the most important thing. There are certain things that are standardized and you have to meet that criteria. But you know as well as I do that some people don't do an apnea test. They don't necessarily let the CO2 get to 58 is okay, it's close enough. No, it's not close enough. It's got to be 60 or greater. We have guidelines, and that's important. To standardize something, you have to maintain that you've got kind of barriers there, right? And so we said minimum of 12 hours or minimum of 24 hours. And the reason we did that is because if you decide in your unit that this is a 4-year-old and, gee, I'm going to just do testing at 6 hours, and in this unit over here, we're going to do testing 1 hour later, and in this unit over here, we're going to do 15 hours, then you're all over the place. So you could be dead in California, but still alive in Florida. The reason that we standardize that is because everybody does it the same way. And that way, there's no ifs, ands, or buts about it. Okay? When you just say you have to wait a minimum period or an observation period, that's like saying drive whatever speed you want on the freeway that you think is safe. Now, you might think 55 kilometers is safe. I might think 90 kilometers is safe. Okay? There's no boundaries. So that's why we set that up as far as time limits. They are arbitrary, but they're there for a reason too. And what we found is that when we standardize testing like that in children, the biggest diagnostic errors that are occurring today, okay, are not with the examination. They're actually with our ancillary studies, because we have neuroradiologists that are interpreting studies with some flow, no flow, or a neurologist that says, I'm not convinced that there's complete electrocerebral silence, when in fact there was electrical activity or no electrical activity. So we have to rely on our subspecialists for those tests. Good question.
Thank you. Thank you for an excellent talk. Just a very quick comment for the neurosurgery people from India. In India, the ancillary tests are not included for brain death certification. Okay, sorry. We've had 2 requests from parents from anencephaly for organ donation in our...
For anencephaly?
Yes.
Yes, so that really falls in a different category. Anencephalic patients cannot be declared dead by neurologic criteria. They can die via circulatory criteria, and we have recovered organs from anencephalic infants. They will get intubated. We will support them. We will extubate them either in the ICU or the OR. We'll allow circulatory death to occur, and then we'll recover organs.
Specific question in the case of the newborn. Is it required a minimum period of time from the delivery for cerebral death determination or not?
Excellent question. So the U.S. guidelines specifically state that following a catastrophic neurologic event or following cardiac arrest, any type of neurologic event or cardiac arrest, you need to wait at least 24 hours, and you need to maintain normothermia in that patient for at least 24 hours. Yeah, good question. Anna.
Thank you so much for your wonderful presentation. My question is this. So you said that kids are not small adults, and of course also intensivists that care for kids are not the same of intensivists that take care of adults. So while we do the diagnosis of brain death, is there any international regulation that says, because I think that in Italy it does not exist, this, that the person who has to certificate brain death for kids should be at least one specialist in pediatrics, intensivist, or I don't know.
The World Brain Death Guidelines address some of that, and again, that patients should have specific training in critical care. They should have training in neurocritical care. Now, we don't define what that training is, but again, even in the United States, it varies from jurisdiction to jurisdiction. States will require 2 people to certify brain death. Some states will say one has to be somebody who's trained in the neurosciences. Well, I was trained in the neurosciences because we do neurocritical care in the ICU. Some others say it has to be a neurologist or somebody with neurologic training. Well, I have neurologic training as well, right? So it's very vague from that standpoint. If you take that down to the hospital level, then your credentialing to determine brain death is going to be determined by your hospital. Now, they may follow state guidelines, but there's no, quote, national guidelines per se. But people do have to have, we're pushing for certification, but there's nothing that says that in the United States, for instance, a family practitioner can't declare brain death, because we do have family practitioners treating critically ill patients in community hospitals. Okay, and that's why it's been difficult in adults, is because it's not in a tertiary care center where you have neurologists and neurocritical care specialists. You're out in a small community hospital and you have to certify brain death. You don't have a neurologist, you don't have a neurocritical care specialist, so you're relying on maybe a family practitioner, and they may not be up to date on the current guidelines. So that's where we're trying to push for standardization. Okay, thank you.
Thank you, Dr. Nakagawa. And now I request Chloe to give a talk on educational programs in organ donation.
Thank you very much. So, yes, I'm not going to talk about science after that. but it has to do with it. Why? Because if you look at the disease donation rates all over the world, you can see that Spain and the US, that's before COVID, just to have the picture clean from any kind of virus, that's what's happening. And what you see here, it's quite interesting, because you can see that high developed countries as Germany or Japan are really at the end of the figure. So why do we have these big differences? And basically the secret of the Spanish model is that we have professionalized the activity. And what does that mean? It means that doctors are specially trained on donation, and they are the responsibles of the organ donation in their hospital. And how do you do that? By training. By training in different levels, so you can do professional training, and our national competent authority is not the one doing that by themselves. They let every hospital or every institution to create courses, and in this way there are several courses every year. On the other hand, in the university, I am an associate professor of the University of Barcelona, we train the graduates and the postgraduates, doctors and now nurses too. But this, I think, makes the difference. Of course, there are other factors, but we are going to be focused on this training. So as I was saying, these doctors, as you can see, those are the people that are working in these intra-hospital organ donation units. Most of them are doctors coming from where? From the departments in where we have potential donors, ICUs and emergency areas. And the same happens with nurses. So the people dealing with intensive care patients are the ones that inside this community you should find people that are wanting and that are enjoying working on that. And how do you enjoy working on something when you know about it? When you know that you have a pathway in front of you, when you know that you can do education, that you can do research, that you can do things to improve what it's going on. So it is feasible, of course, and it makes sense. So those intensive care doctors, you have met some of them in the TPM course, have this responsibility. They can be working full-time or part-time, but they need to have time to dedicate on these quality systems that Eduardo was mentioning, or to create new ways, to have new strategies, as Nuria was mentioning before. If you don't have people dedicated to that, it's not going to work. It's not going to come from anywhere. So that's why it is so important to focus on these profiles. So the disease donation process has clear, specific phases or clinical process, and each of these processes have to be learned. It is not because you are an ICU doctor that you know how to maintain a dead body. So that's why it is important to maintain this training. And from the DTN Foundation, who's a non-for-profit foundation based in Barcelona, we do several things, and one of it is the education. And nowadays we have very different ways to train, no? And COVID has pushed us to a more online, which has made things possible that before were not possible. And what's that? Online, of course, but in online you have many ways: micro learning capsules, self-study courses, live streaming, tutorials courses. Then you have the face-to-face. The face-to-face is the way really to transmit, no? And we were so happy to do a face-to-face here. And then you have the internships. How do you learn? You learn by doing it by yourself, by being there and seeing by yourself. And that's also super important, to have the possibility to be trained outside, to see what the others are doing in their hospitals. And then the blended, that I think is the most efficient way. And then you have levels of training, as I was saying. When you train people and you already have someone in the hospital that is able to lead this activity, it cannot become a unique case. this culture has to be spread all over the hospital. And when you have a deceased organ donation system in place, you need to make sure that any nurse in the hospital, or at least in the ICU, and then your colleagues in the hospital understands what you are doing. Because if not, you're not going to be trustable. And you need everyone to have the same language, the same way to see it. If not, families might be really confused. So you have this elementary, intermediate, what we did here, advanced for the ones that are already working and want to really improve their practices, and finally there is this master degree, which is in an academic level already, and then the PhD. So we are very happy because in DTI, through the TPM management program, whose at least this TPM is older than DTI itself. We started in 1991, and we have trained over almost 19,000 people from more than 113 countries. And this is really enriching, because from each course you do, you gain, and our experts gain on those trainings, and you learn how the others are doing. So the idea is to create experts for organ, tissues, and cell donation for transplantation by giving competencies and knowledge. And these people have to be exactly the kind of professionals that we had here the last days. People working in the critical care, in neurological units, in emergency department, and I should add, in management too. So does that has an impact? Well, of course, it is not a unique factor, the education, but if you look at this, you have in the bars are the students, let's say the participants, and the line is the donor per million population. Of course, the more people you have trained on that, the more dedicated they will be. So we have seen the same with Italy, in where we have also had the opportunity to train every year ICU doctors, the same in Portugal, the same in Slovenia, in Croatia. Those countries are not well known in Europe for other medical challenges or activities, but they are the best on donation. And what happens in other places in the world? Well, here you can see Thailand. When we started training people, as you can see, it is the way how you change the mentality. Many times we blame the population. No, our population is not ready to do that. Are we ready to deal with donation in the hospital? That should be the question. And when we are ready, then things happen. The same happens with Iran. Nowadays, Iran has more deceased donors than Germany. And how do they do it? I've seen it. They do it through international standards. And why did it change? Because in every hospital in Iran, there is someone responsible of deceased donation. And that person is a doctor. And China, well, China is another amazing situation. They had nothing, not even the brain death concept, because they didn't need it before. But when the things changed, they had to do it. And when the green light from the ministry was there, then they started training people. And you can see that the efforts really have been tremendous. Well, this is about the master. As you can see, the master now, it's, we have 3 modules: donation, transplantation, and then you can choose in between tissue banking or leadership, quality management, and innovation. And then there is an internship. And this internship, I think, is really important. For the people that, as you can see, we have people from all over, from all the continents in the master degree too. And everything has been set to be online. And then even when COVID started, we tried really to make this hands-on somehow transmitted from an online point of view. And we have even been able to switch even the internships, because at that moment we couldn't do it. We have created a virtual reality tour for the people to have the possibility to visit a hospital in Spain and to have the possibility to interact with the different professionals. So once you are in this hospital, you can talk with the professionals, you can ask them things, and they have answers for you. Well, it has been a very interesting journey for us. And what has happened in India? Well, in India, Since 2002, we have trained 321 students. But I would like to highlight what has happened in those days. Now, as you can see, in 2002, we started in New Delhi, and then we have been in several different places. But always, our focus has been doctors. But the best group we have had till now, maybe, is this one, because we had the ones taking care of those people with brain injury. And those are the ones that will make the difference. So we are very optimistic, and we really hope that we will have the opportunity to continue that. Just some pictures in where you can see that time pass, but the smiles and the faces are always the same. So I'm lacking the picture from this course, and I really want to have it. This is during COVID. I think I can recognize someone from the audience in the online. And other things that we have done, no? And I think it's important to be everywhere, to be in the congresses, to push the people, to shake the tree, and to make everybody think that donation is part of our responsibility nowadays all over the world. So thank you very much. Please.
Thanks very much, Chloe, for sharing Spanish experience. I work in Liverpool, and I must say that when I was registrar there, the European Donor Hospital Education Program was going on. I was one of the participants in that, how to really break the bad news, and formal training in breaking the bad news. And that had some impact all over. It was a European program. So then 15 years ago, UK adopted the Spanish model, and that really transformed the way people work, the way people use these nurses in ITUs, and it changed the organ donation rate to an extent that until 2008, the gap between demand and supply had always been increasing. Then it really started narrowing down. So it had a very important impact. Rather than 4 levels of training you mentioned, there are 2 levels there. One is CLOD and another is SNOD. Name may not be very appealing, but specialist nurse for organ donation, and each hospital has to have that. And every year we are supposed to show the audit of the organ donation performance, and that has really transformed the whole scenario.
Yes.
Thank you very much for
Thank you.
influencing so much.
Yeah, this is the point, not to integrate the activity inside every ITU, ICU, and to count that as a quality indicator, no? Not having donors in an ICU in Europe, and I would say all over the world, should be an indicator that things are not done in the proper way. And this is the change that we have to do all. Thank you very much.
And may the team grows and the knowledge spreads. Yeah. It's on, sir. Oh, okay. So let the knowledge spread, and be everyone a participant in this noble cause, a kind of which spreads more and more. In this part of the country also, I think in South they are doing little better than the northern India. And Dr. Deepak is like after our lives, after so we see him and we are scared, okay, not this one. So I think with more better protocols and more minds changing and accepting the facts, we'll surely do better. Thank you so much for this enriching session, and with this we conclude this first session of the morning. Have a nice day. Thank you so much. I'm informed that this last speaker, Dr. Rahul Pandit, is not there. Yeah. Oh, that's why we closed the session. Yeah. Thank
you. Now we have ANTC Distinguished Lecture by Dr. Thomas Nagakawa. It is on the gift of life, organ donation and donor management.
good morning. I'm back again. I want to spend a little time with you this morning. I was asked to talk about organ donation, donor management. And in thinking about this, I really want to kind of expand on things. And the session this morning, our previous speakers did a very nice job really setting the stage for my talk today, because I'm going to build on a lot of those things. And this is really about quality end-of-life care. And what I will say is that we have a role, all of us have a role in this. And it's really turning the tragedies, the tears of tragedies into the miracle of life. My disclosures are listed here, and again, I speak to you this morning as a pediatric intensive care specialist, but also as a medical director for an organ procurement organization. So I'm bringing a lot of different perspectives to the table. Now, our mission as healthcare providers is to preserve and restore health. It's to heal the sick and the injured. But what happens when we can no longer restore health? And what happens when we can no longer heal the sick or the injured? What happens when we are no longer preserving life, but we're prolonging death? So the ICU has been called the pinnacle between life and death. And the ICU used to be a place where people came to get better, but today the ICU is a place where unfortunately people come to die. And in the majority of ICUs across the world, death occurs following the withdrawal of life-sustaining medical therapies, following circulatory arrest. Brain death occurs, but that's a very small portion of the patients that we see dying every day in our ICUs across the world. Now, there's some important considerations that I want to lay on the table as we get started. And some of this came from one of my mentors years ago, who really was my inspiration to go into critical care medicine. And he taught me about the golden rules. And rule number 1 is all people die, and rule number 2 is you can't change rule number 1. Death is not failure. And I think we realize that. We have really expanded in our role. Death is a natural part of life, and we have come to accept that because all people will die. Death can be anticipated. It can be also unanticipated. It's important for us to understand, though, that dying is a process, and it's a process that occurs over time. And it can be a very short period of time, or it can be a very prolonged period of time. Death is a specific point in time during that dying process. And it's important for us to remember that when we make a determination of death, it doesn't rely upon the loss of function of every cell, tissue, or organ in the body. Cells die at different rates. Death is just a point in time where we declare somebody legally dead. The dying process still continues. End of life is a process. End-of-life care is a process, and we need to be thinking about that. It just doesn't happen. It evolves. And it's a process that begins when we have a critically ill or injured patient that's identified by us as the critical care team that they are likely to not have a favorable or a good outcome. And we know that when we see these patients, or their condition begins to deteriorate despite our best treatment available. Medical management for that dying patient requires continued care to relieve pain and provide comfort, and it relies on the collaboration between the critical care team and all the other specialists that we utilize to help families during that difficult time in their lives. And we have to work to improve how we prepare families for the loss of their child or their loved one. This is our responsibility, everyone in this room. You can't neglect that responsibility. We have to have those open and honest conversations with patients and families. They don't just happen one day. Sometimes we do have acute events that do happen, but many times this is an evolving process. These conversations are difficult. They require time for families to understand what has happened to their child or their loved one. And if you're uncomfortable with that conversation, then find somebody who can have that conversation. That's where our palliative care specialists become very important. And the process really starts when patients are first admitted to the intensive care unit or when their condition begins to deteriorate. Donation is a process as well, and it begins when a critically ill or injured patient may die, and we make a timely referral to the organ procurement organization. And that process relies on the collaboration between the critical care team, the OPO, and all our specialists to really optimize organs so that we recover them for transplantation. And that medical knowledge and management of the potential organ donor requires specific people to care for that patient. And who best to care for that patient are the people in the critical care units. Now, optimizing donation isn't just about physicians, and you heard that from Chloe. She talked about this whole process, and we heard about this in the morning session. It's nurses, respiratory therapists, social workers, chaplains, translators, child life specialists, transplant coordinators, donation coordinators, and administrators, top down, bottom up. Especially in pediatrics, we have child life specialists. You know, who wants to go and talk to a sibling and let them know that their brother or sister is not going to come home? I'm not the best person for that. So we need to have these open communications with the family. They're difficult, they're hard. They're hard not only for us, but they're hard for the family to hear. Donation isn't a question, it's a conversation, it's ongoing, and we need to think about that, and we need to think about that in the process. And as we begin to think about that, this process is identifying a potential donor, declaring death in a timely manner, assessing the donor, managing the donor, allocation of organs, and then the recovery of organs. This is a huge process when you begin to think about it. That continuum of care has to be maintained throughout the entire process to ensure that we provide optimal end-of-life care and also manage the donor so that we can recover good quality organs for transplantation. Early referral to the OPO. We need to let them know early. We need to have those conversations early. You say, well, that's not really necessary. Well, that's like saying, I got a kid or an adult with a subarachnoid hemorrhage. It may evolve into a bigger subarachnoid or subdural hemorrhage, but I can wait 24, 36 hours before I contact the neurosurgeon. Now, because you're neurosurgeons in this room and neurointensivists, the first thing you say is, no, I would rather know sooner than later, because if I need to get my team together, we need to be prepared for this. Early referral is really just a consultation. It lets another party know that you may have a potential complication coming down the road and you may need their assistance. That's what early referral is, and it's actually a best practice to maximize organ donation potential. We have to determine neurologic death in a timely manner. Why is this important? We can't delay this process, but again, we can't rush it. It's important because it allows families to begin the grieving process as they prepare for the loss of their loved one. It allows redistribution of ICU resources, which are scarce, so that we can care for other critically ill and injured patients. We just can't sit there and take care of corpses in our ICU. We also know that more than 25% of our potential donors are lost due to hemodynamic and respiratory instability following neurologic death, and therefore, the sooner we make the determination of death and determine that donation is going to occur, the sooner we can begin to manage that patient. And early and aggressive donor management and the use of hormonal replacement therapy enhances organ recovery and results in improved graft function. And it actually gives us more organs so that we can transplant and save the lives of more patients. In the United States, we have two brain death protocols. We have the adult protocol, which was published in 2010, and we also have the pediatric protocols that were published in 2011. And these guidelines have served us very, very well. We have worked to really standardize this process throughout the United States. The important thing to remember about our brain death guidelines, though, is they are minimum criteria. They're not the maximum criteria. If you can't meet the minimum criteria, you've got a problem. We miss opportunities for donation, and this is bad. And how does it happen? Well, we don't make a timely referral to the OPO. Families of potential donors may not be given the opportunity to donate. Why? Because we think the patient's too sick. We make the decision. That's not up to us. That's up to the families. Families deny donation. Why? Because they haven't come to the realization that their loved one has died. Options for donation can be denied in cases of homicide, so medical examiner coroner denials block our ability to recover organs, and patients may not be aggressively managed following an injury or illness. And when we miss opportunities for donation, people die. A single organ donor can save more than 8 lives. We used to say 8 lives, but we can split a liver now, so that's 9. And if we recover vascularized composite allograft, like hands or abdomen, we have 10, 11, 12, and tissue donation can save hundreds of lives. preserving that option of donation is our responsibility. It's every one of our responsibilities, and we have a responsibility to continue to treat patients until we make a determination that we can no longer treat the patient and we're going to withdraw or decelerate medical therapies, or we declare the patient dead. We can't just say we're not going to do anything and not have those conversations with the family. The family needs to know that we did everything possible to save the life of their loved one. Because if they walk away with any doubts about that, that affects us as the medical team. The importance of appropriately managing that donor. If we don't manage them, we have organs that are unsuitable for transplantation. This can occur before death, it can occur after death, or we can have situations where patients just rapidly decline very quickly. And this is where we do rush recovery. We recover kidneys. Classic example is the gunshot wound to the head, right? They have massive DIC. You're trying to stabilize them. We can still recover kidneys, and we do that. The patient's condition also, if we maximize that donation potential and manage those donors appropriately, the patient may actually survive and not even become a donor. They may get better and they may go home. There's a continuum of care that exists, and donor management needs to be viewed as a continuum of care throughout that dying process, through the determination of death, and until we recover organs. And the intensivists and the ICU team are involved in all of those processes. Who we bring in during that process varies. Okay, because at end of life we have chaplains, spiritual support, we have palliative care specialists. Preconceived notions about donor eligibility may not be current or accurate, and the thresholds for acceptable organ function can vary according to the time of the evaluation. We don't want to get an echo right after the patient herniates because we already know that there's going to be myocardial ischemia. That organ has been stressed because of the big catecholamine storm. But if we wait 12 or 24 hours and get an echo, that function recovers. It gets better. We are able to wean inotropic therapy. So serial ultrasounds, cardiac echoes are important. Positive blood cultures and sepsis don't rule out a patient. If we treat them with antibiotics, we can recover organs. In the United States, we have recovered organs from HIV positive patients and transplanted those into HIV positive patients. Hepatitis and B and C. We can treat those disease processes now. They're not fatal. So the suitability of donor organs is best assessed by the OPO, not by the medical team, but by the OPO, their medical director, and also the transplant surgeon. And that's important because what we deem as unacceptable may be completely acceptable to the transplant surgeon. There's a paradigm shift that occurs with our goals of therapy from life-saving to organ preservation when donation occurs. So our efforts to treat craniocerebral trauma shift because death has occurred, and now what we're doing is preserving organ function. And we have to be focused on providing adequate circulation and respiration, oxygen delivery to the tissues to maximize those tissues. Our management goals are resuscitation, oxygen delivery, hydration, perfusion, restoration of normal ventilation, thermal regulation, regulation of endoneuric function, and continued support for the family. The important point here is what is good patient care is good donor care. And so what's good for the patient is also good for the donor. We would never allow a patient to become hypoglycemic or hypotensive. We don't do that to the donor either. Good donor management makes a difference. Preserving the option of donation when authorization has occurred allows us to recover more organs. It results in better organs, better graft quality, and organ donation helps the family heal. They know that the death of their loved one wasn't in vain. They know that the legacy of their loved one lives on. The greatest fear that people have when their loved one dies is that no one will remember them. The legacy lives on with organ donation. Treatment of hemodynamic instability, we have to restore normal cardiac function. We have to balance our approach with fluids and vasoactive and inotropic agents. Serial echocardiograms, hormonal replacement therapy becomes important. The use of thyroid hormone is important because what it does is it reverses that anaerobic metabolism that occurs following brain death. It shifts it back to aerobic metabolism at the cellular level. We have to restore normal respiratory function, preserve lung function. You're going to have a bronchoscopy to look at the airways. You're going to do oxygen challenges. You're going to do routine pulmonary care. Fluid and electrolyte balances, we have to restore euvolemia. We have to make sure that we're replacing output so that we don't get behind. Hypernatremia is a problem. We have to treat that. We can treat it with free water administration through an NG tube. We don't care if the sodium goes from 170 to 150 over an hour because it's not going to hurt the brain. The patient's dead. We need to maintain normal urine output. If it's on the low side, we need to force diuresis, give more fluids. If it's because of DI, then we need to pharmacologically manage that. Now, following the identification, following those aggressive strategies to manage the donor, now we have to allocate those organs, and now we have to take the donor to the OR and recover the organs. And that means that we need to be working with our OR staff, because that continuum of care continues into the OR, so that they understand the importance of continuing to manage that patient until we actually recover those organs. We have future technologies, future considerations in emerging technologies that are helping us in the world of donation right now. And some of those are actually ex vivo machine perfusion devices for heart, liver, and lung. And the first ex vivo perfusion from a DCD candidate, from a DCD donor, occurred in Duke. This was in a 14-year-old, and she received a DCD heart using machine perfusion. The machine perfusion allows us to travel further distances. We can look at the function of the organ. We can condition the organ and determine if it's a marginal organ, if it's suitable, because it gets better with machine perfusion. We're doing partial heart transplants now, which is really cool. This is something new. This is coming from a DCD donor. Okay, immediately following death, they're recovering the valve. They're implanting those valves in patients with congenital heart disease. And what happens, instead of using a cadaveric graft, this is a live graft, and it continues to grow with the patient. The cadaveric graft doesn't grow, so these kids that have complex congenital heart disease may have to have 4, 6, 8, 10 surgeries down the line. But if that valve conduit continues to grow, they don't need another surgery. So we're really expanding the areas of transplantation medicine. In the U.S., we're transplanting HIV positive organs, as we've talked about, because we have antiretroviral therapy. Now, there's specific criteria that has to be met, but prior to the HOPE Act, this was illegal in the United States. We've done vascularized composite allografts in children and adults, face transplants, extremity transplants. A lot of this came from the Department of Defense and injury to a lot of our veterans. The first double hand transplant was performed more than 10 years ago in Philadelphia. Fascinating, because now this child has function, but he also has sensation. So you have nerve regeneration in the periphery. We have expanded this penile transplants and now uterus transplants. And the first baby was born in the United States to a woman who had a uterus transplant. So this is an expanding world that we're seeing now. In the United States, last year we celebrated our 1 millionth transplant. And that's a huge milestone for us in the United States. Last year we did almost 43,000 organ transplants from over 21,000 donors. And if we look at those numbers, there were 14,000, almost 15,000 deceased donors in 2022. We had 947 deceased pediatric donors, of which 226 were DCD donors. We also did 1,777 pediatric transplants. So in the world that I live in pediatrics, we are expanding that. Okay, we're trying to keep up with that, because that gap between those patients waiting for an organ and waiting for a needed organ and our actual donors, that gap just continues to widen. And our goal is really to narrow that gap or eventually eliminate it. So what's our responsibility as healthcare providers? As a medical community, we have a responsibility to perform donation well. We have a responsibility to ensure that in each case the aspects related to donation are carried out ethically and within our established and accepted medical guidelines. We cannot deviate from that. If we deviate from that, we lose the trust of the public. The option of donation should be preserved for all families, and that option of donation is made by the family, not by the medical team. And we have a responsibility to provide the utmost respect for the patient and the family during that dying and donation process. In the United States, many ICUs across the nation have started what we call an honor walk. And the honor walk is, it's really beautiful when you have a chance to experience this. Staff line the hallways as that donor is wheeled out of the ICU into the OR. In the OR, many times there's a timeout that is performed to honor the donor before the recovery of organs begins. I'm going to close out everything today by telling you about one of the highlights of my career. We save a lot of lives every day, but I will tell you that the families that are most thankful are the families that have lost a child. They say thank you because they recognize that we've done everything possible. You know, how many families tell you thank you? It's not that we expect that, but how many families actually tell you thank you? And think back on that. Very early in my career when I was practicing in Virginia, I had the opportunity to lead a group of people to try and come up with a memorial for children who became organ donors. And this is the result of that. The hospital didn't want anything inside because they felt that promoting organ donation was a bad thing. It was a negative. In fact, it's very positive because we save lives. So we found a nice area outside and turned it into a garden. It's called the Butterfly Promise Garden. And it still exists, and I still get calls about it, and I still get photos. And this is the butterfly garden, and on that garden you can see the wall there, and there are copper butterflies on that wall, and every child who is a donor has their name engraved on that and goes up on the wall. And this has been a beautiful memorial for families to come back. They have a ceremony each year that honors those new donors and those families, and that's important because these families recognize that they're not alone in this journey. They also recognize that the legacy of their child continues to live on. We have an upcoming Pediatric Donation Transplantation Summit in the United States. It's May 24th and 25th in Houston, Texas. And I would invite all of you, if you have the opportunity to travel to the United States, to venture into this, because I think you can learn a lot from what we have done in pediatrics. We've worked very, very hard. Trust me, you learn a lot from kids. And if you're a parent, you really understand that. And it's not just being a parent, it's what we do in medicine. We have learned a lot from our adult colleagues too, because much of what we do in pediatric medicine comes from adult medicine. But it's a two-way street. We will be talking about a myriad of different topics, including donor management, brain death, circulatory death, ethical issues, transplantation issues, machine perfusion, how to work with families, how to collaborate with the OPO. So this promises to be a very robust and exciting two-day meeting. I'll leave you with a couple of thoughts. We can't always cure, but we can always care. And that should be the bottom line, because we can't always cure. We cannot always cure. That's not what our job is in healthcare. It's not always to cure, because there's new disease processes and people will always die. The success of intensive care is not to be measured by the stats of survival as though each death were a medical failure. It's to be measured by the quality of lives preserved or restored, and by the quality of the dying of those in whose interest it is to die, and the quality of human relationships involved in each death. And it's interesting, this was published in 1984, but it still holds true today in 2023. You know, death is not a medical failure. We talked about failure and success yesterday, but it's very true. We have successes even in the midst of failure. So all of us have the opportunity to turn those tears of tragedies into the miracle of life. And I hope in the short time that we spent together this morning that I've really helped enlighten you as this process of end-of-life care, which bridges everything between life and death, and the importance of donation as a part of end-of-life care, and the difference that donation can make for patients, family, also for each one of us in this room, and also for our staff, because they recognize that that person didn't die in vain, that something good came out of that patient's death. And I will tell you, after almost 35 years, the reason I still do this is because of the families who continue to give me the strength to carry on. They show me why our work is so important. And also to each one and every one of you, okay, who are here today as champions. So I thank each and every one of you for all the work that you do, and I hope that I've enlightened you, and I hope I've given you some information to take back to your respective units. Thank you.
Very inspiring. I wish the dear audience, I wish there were more people from urology, neurosurgery, critical care listening to you, because this is what we require in our country. A little bit of hope, a little bit of inspiration, and personal experience. Thank you, Thomas.
Thank you.
Excellent talk. And congratulations for being highest organ donation in last year. I think it was more than Spain.
Yes.
So Spanish model is having TPM in their hospitals. What is there in US? What type of team you have?
Good question. There's a lot of different initiatives. So the Organ Donation Transplantation Alliance, which I showed you, is the sponsor for the for the meeting in Houston. So that's one group. We also have the Association of Organ Procurement Associations in the United States, which also holds national meetings. And then we have the North American Transplant Coordinators organization, which really works with our donation coordinators. All three of those kind of come together. We're trying to get more cohesive there, but those are the organ procurement and organ donation related educational activities. That has actually spilled over into critical care. And so we're seeing more sessions at our critical care meetings. The American College of Chest Physicians meeting, CHEST, Society of Critical Care Medicine. We're seeing more of these talks about end-of-life care donation and our responsibility, because end-of-life care really has become important. There are numerous policy statements that have come out from various organizations talking about end-of-life care. American College of Emergency Physicians, American Academy of Pediatrics, Society of Critical Care Medicine. There are a lot of society guidelines out there because people now recognize the importance of that. 20, 30 years ago, end-of-life care wasn't that important. It was more about ARDS. It was more about, trauma. It was more about cardiovascular. It was more about neurologic. We've pulled all those things together today, but we also recognize that people die, and people die, unfortunately, badly. Nobody wants to die badly. Our job is to make sure that we create a good death for patients. And that's where palliative care and some of these other organizations have come in to help us in critical care medicine. So there's a lot of different initiatives. There's not just one particular group that services everybody, because it's such a diverse field, as I showed you. It's everything from physicians, nurses, all the way down to spiritual support, donation coordinators, even hospital administrators. So we're working with the American Hospital Association, we're working with the Healthcare Administrators Association in the United States. All those groups we're targeting to make sure that they understand the importance of end-of-life care and the importance that donation as a part of end-of-life care can save more lives. So
One
good
query,
question.
If brain death certified patient, can they, if they are having clinical evidence and other evidence of sepsis, you are doing organ
Yes.
retrieval in that?
So you have to think about this. Sepsis is an evolving process, right? The patient who comes in actively septic right now and is growing organisms in the bloodstream is going to get treated with antibiotics. And as you treat them and as the cytokine storm resolves and as the capillary leak syndrome goes away, they're still on antibiotics. You may have negative cultures, but you have an opportunity because those organs begin to recover those organs if the patient progresses to either circulatory death or neurologic death. If they're actively septic with positive blood cultures, if they have endocarditis and they're showering embolic, septic emboli, that's a different story. But each of those patients gets weighed on an individual basis based upon what's going on with that particular patient. So we can't say just as a general term that if you have somebody who is septic, you have to define what septic is, because if they were treated and you still have a diagnosis of septic on the chart, they're no longer septic. It's treated sepsis. So you have to determine where they are in that whole process of their disease process, right? Really, some of the only major rule-outs would be metastatic cancer. Okay, that's probably one of the primary rule-outs. Or if we're dealing with a viral encephalitis and we don't know what the cause of that encephalitis is, because those viruses can obviously be transmitted to the donor, to the recipient rather. Okay.
Yeah, one of the dilemmas that we face as
Yes.
we treat and then declare somebody is brain dead is at some point you are treating a person, and the next point you're declaring the person as brain dead. You're saving the life, you're trying to save the life, you're pulling the plug. How do you resolve this moral conflict?
Yeah, so it's not necessarily pulling the plug. Remember that your progression to death is a progression to death. If you are actively killing a patient, that's illegal in the United States. That's called euthanasia, and we can't do that. So you get to a point where you can no longer support the patient, and you are now moving from trying to save the patient into end-of-life care. This is a transition phase, and part of end-of-life care is engaging different specialists. Those specialists will include, for instance, palliative care, ongoing spiritual support, social work, and in this case, the OPO, because families are going to ask that question as we progress through this, what happens next? So there's a transition period. It's not like, oh, the patient isn't getting better, we're just going to yank the plug out and stop the ventilator. There's a transition period in there that occurs. Does that help answer your question? Good.
Mandatory asking for donation. We have to say we did do that in the chart, whether they accept or not.
Right.
We have to ask.
So one of the conversations that you eventually will have to have is a conversation about organ donation. And this goes back to when I talked about on the slide about trying to prepare families for the death of their loved one. This just doesn't happen. It happens, for instance, like a gunshot wound that comes in to the head. That's an acute event, and you know that patient is going to die, and they could die within a matter of minutes or hours. But if you have a patient that comes in with a stroke, and the stroke continues to evolve over the course of several days, and they don't get better, and they develop intracranial hypertension, and they gradually progress to brain death, that's a whole different story. But as that stroke evolves, you should be having those conversations with the family and saying, you know, this is not good. We're not in a good place here. These are the things that we need to do, but if these things don't help your loved one, then we don't have anything else to medically offer. Now, you don't want to say, now in that case, maybe you could donate organs. You don't want to do that because now you've got a conflict and the family says, well, you're just going to let my loved one die so you can recover organs. Okay? There's a time and a place for that. The point is, if you do your job well and you prepare families, many times, especially with children, families will come back and say, well, if my child's going to die, I want them to be an organ donor. Well, that signifies to me that they've heard that message and they know that their child is probably not going to have a favorable outcome. In adults, you already have advanced directives because you have a driver's license, you've already indicated your need or your want or your wishes to become a donor. And that's in the United States where we're an opt-in system. That's different from the opt-out system where people have to opt out. Otherwise, it's just assumed that you're going to be a donor, right? But the timing of asking that question becomes very important. If we do our jobs, many times, and we're seeing this more and more frequently, families are bringing up donation. Now the question is, do you discuss donation at that time? And the answer to that is no. But the OPO has already been called about that patient because I've notified them because I know that this patient may not have a good outcome. Doesn't mean that they need to get involved, they just need to know. Just like I'm consulting you as a neurosurgeon because I got a kid with a head bleed. And it may get worse, and you may have to do something about that. So the thing about this is that as we begin to work with these families, they're saying, well, I want my child to be an organ donor. My response to that family is, let's concentrate on trying to save the life of your child right now. And if we can't save the life of your child, then we'll have those discussions. That should be the conversation you have. So you push that off and allow parents and everybody in the medical team to focus on trying to save the life of the patient. And if you can't do that, that's the time to engage the OPO and your designated requesters or whoever else it may be to talk about donation. Good question.
So we can have further questions in the...
Okay, thank you.
We are running
Thank you very much, yes.
It was a great deliberation from Dr. Thomas. Moving on, I would request Dr. Matthew Joseph and Dr. Sunil Shroff to chair the... No? Dr. Ishwar, sorry. Dr. Ishwar hai? No. Okay, sir. Dr. Ishwar, sorry. Dr. Ishwar and Dr. chair the session. Now we have talk by Dr. Ajay Sharma.
Can we just connect it to?
Thank you. Ajay is one of the champions of organ donation from England. Great to have you, Ajay, here.
Thank you, sir. Thank you, sir.
Unfortunately, you're running very late today, more than an hour, so I don't know how we're going to catch up. Ajay, you have two talks. Are you going to do both together, or?
I could do both these together, actually.
May save some time.
Yeah, that would save time for changing, yeah. So how do I connect it to the system there, yeah? If you can just connect.
And do we have the other two speakers also here? Sorry? Yeah, do we have the...
So,
Yeah, you're here. Great. And then after that, we have Dr. Garg, is it?
Okay, is it connected? No?
Dr.
Yeah.
Garg is here? Yes or no? No?
Okay.
Yeah.
I'll start speaking anyway.
Yeah.
Thank you,
Yes,
Dr.
Ajay.
Sunil Shroff.
Thank you.
It's a real privilege and pleasure to keep coming here to my alma mater here, where I spent 8 years, long time ago, in 1980s. So I must keep it there. So what I'm going to really talk about, quite a lot has already been covered by the expert, Dr. Thomas, and it made my job much easier.
For this session for 4 speakers. It's 5 minutes each. And I'm going to keep
Oh yeah, that looks like mine. Yeah. Yeah, I do have quite a few roles there. For quite some time I have been involved in organ donation as well, even before I knew T of transplant, when I was working in endocrine surgery in my previous life. So I do have quite a lot of role in transplant related education. We run fellowships and master's courses, so we help our younger colleagues in 33 countries to learn, and actually we learn from them. It's both ways. So I'll speak about optimizing potential organ donor and evidence-based approach. I'm not going to say anything new here. It has already been summarized by Thomas there so well, and I have no authority, nor I have really that kind of expertise which he has, but I have some idea, and I'll bring in a UK perspective here. So I'll just quote. To begin with, I'll just mention that quite some time ago, in 90s, it was Donor Action. That was the program which was across Europe, some western countries of Europe as well as in the UK, which proved beyond doubt that Donor Action, proactive ITU-based nurses and doctors who are trained, it really improves the organ donation significantly. It is mentioned 30%, but in that study it was something like 33%. So Council of Europe Committee of Ministers, they declared that a system should be there, and I'm talking about at least 20 years ago, when there should be a complete information for the healthcare professionals and for the general public, has already been covered here half an hour ago, and that has really borne quite a lot of fruits all over Western Europe as well as in UK. And as I was discussing that since 2008, the difference between the organ supply and the demand has been really, until then it had been really ever growing, but it has narrowed down consistently since then, and that was because UK adopted Spanish system. So optimizing cadaveric organ procurement, again, I can't say better than what has already been said there, so I'll skip that. So very specific government mandated budgets there, and that really had transformed in Portugal and Spain the outcomes as well as the rates, and that model has been adopted world over. So this is just to mention that I'm very passionate about it, so I better make a mention here. Why evidence-based approach? Well, that applies to any aspect of medicine, and not just to medicine. Whatever we do in our day-to-day life should really be evidence-based, although may not always have evidence available, appropriate evidence available. But I can just say that 99% of the literature, or maybe more than that, which comes through the door. Now there are more than 7,000 journals there which publish all the time. 99% of the published literature would not make a change in my practice if I go through that. So I really need to have that skill as to what, on the basis of 0.1%, I can change my plan if I really learn something, if I really would like to adopt or extrapolate the lessons from there. So since 2008, we have been really conducting the workshops for how to analyze published papers. That's what I was doing for yesterday for last 5 hours, for last evening for 5 hours. And just coming to this particular specific topic as to how optimizing the donors would really have an impact on increased number of donors and increased number of organs per donor.
So that question I put it to the different search engines in different forms, and I had a huge really plethora of those articles. And this flow diagram shows, actually I don't want to go into details, the time doesn't allow. So ultimately I was left over with only 19 of those articles, so I'm going to really present a bit of concoction of those 19 articles. So optimizing outcomes of by preconditioning donors, this is animal based studies in the evidence based pyramid, it would really get number 0. But just to mention that quite a lot of animal studies which have really shown the utility of many of those pharmacological interventions or ischemic or pre or post conditioning measures, they have shown some benefits there, but they have not been translated into the clinical practice. So I'll just make a quick mention there, where it is the heart perfusion in a pediatric organ donation program, or the use of normothermic perfusion there for kidney donors, or I'm really mentioning here the perfusion of the heart. Has been, if it can be really used, machine can be used for perfusion of the heart allografts after it has been recovered from DCD, unit donation after cardiac death, or they have been shown to be of immense value, and the level of evidence of these articles has ranged from 2 to 3 only. Increased transplantation organs from the use of standardized donor management, it appeals and it really works. There is no doubt, and the evidence is really quite strong, and I'm not saying anything new over here, and there is plenty of data there. And this one I'm really quoting a paper which is almost 2 decades old, and this has been replicated again and again and validated again and again. So similar kind of approach has been really used and has been published there, so don't have time to go through that. It has been really cost effective. No doubt, it is not a surprise that cost effectiveness wise also it is much better, not just clinical efficacy wise, and so it is a win-win situation for healthcare planners, politicians, for the medics, and those who really plan how to deliver the healthcare. So I would just say that what actually it really involves, I'll just jump to this. This is the concoction of that particular paper, how these are 9 different parameters that one has, the treating team has to really make sure that their prospective donor gets the physiological parameters in this range. And just to clarify, that issue came up only 10 minutes ago. Only when the family members are really convinced that yes, it is either irretrievable situation, or the brain death test has been really confirmed, have been confirmed by a pair of 2 anesthetists there, as in UK, done independently at 2 different time slots. Only then one would really make a mention of the word organ donation. Until then, you don't really bring that. That is the real cutoff point. So just to mention, we have been doing some work in that direction as well. Also, so far we have conducted 63 acute critical care courses. I'm not a critical care physician in this lifetime, I cannot be, but based on the lessons which we direct the courses of ATLS or critical care course for ill surgical patient, similarly we have introduced it in India, and one important part of it is talking about organ donation and also how to optimize whether somebody is going to be a prospective recipient, donor, or someone else who is really following any in perioperative care. So the rules and principles using applied physiology principles are same, but somehow there is a lot of emphasis on theory, but it is the skill development we really emphasize and we try to achieve. And again, the data shows that these targets, once they are achieved, the outcomes are much better. So I would really, again, I'm really running short of time. So again, I'm not saying anything new here. Intensivist-led management of patients who are really not patients, who are brain dead donors, their management certainly improves number of donors and number of organs which can be retrieved per donor. So there's lots of data which has been really published, and some of it I have really depicted here, shown here. So in conclusion, I would say that implementation of an intensivist-led donor management program increase the organ donation, improve the organ donation program. So I will come to an end of this presentation.
Thank you very much. Yeah.
The second presentation because the connectivity is an issue.
Yeah. No, yeah, if it is all right, I would just continue. That way we'll save time as well.
So, small announcement, there is a running breakfast if someone wants to catch it in the cafeteria.
Okay, next topic is very much dear to me and perhaps to every one of us who is there. Otherwise, we won't be really coming to this. Just a minute. Yeah, public. Why is it not really getting projected? That is really beyond me. Could I have some help? Why is it not listening to me? Okay, that looks better. Okay, maybe we can come out and then start again.
Yes.
Okay. So that's what typically happens. It just doesn't behave when it is needed most. Anyway, no worries. Okay. Okay, now it seems to be more promising.
Any comment or
Any
from the presentation of Ajay? Anybody wants to say anything? Okay, Ajay, you're on.
Okay, the next topic is really very dear to all of us. When Thomas was mentioning about the donor organ coordinator from Spain was mentioning about the organ donation program, I would mention about again UK, the organ donation rates improved very significantly after a Spanish model was adopted throughout the UK. It has been compulsory for any death which is really happening. All those are audited, and people are questioned if somehow the family is not offered the possibility of organ donation. So that is there, but somehow the affirmation rate have not really improved since Sheila Gore published her data that only 70% of people who are approached would say yes. So that has not changed, but certainly since the denominator has improved, the kind of the way the families are being approached by the nurses based in ITUs, it has transformed the scene. So why I'm really mentioning about public trust in healthcare system is really crucial to the is key to the success of organ donation program. Again, I'm stating very obvious here. So in this hopefully 9 minutes presentation, I'm going to talk about few issues. One is public trust in the healthcare system is key. What works? What is the evidence in support of it? I would quickly highlight that. And what is the current evidence for evidence-based approach? If I follow evidence-based medicine approach here, I mean judicious, conscientious, and deliberate use of evidence. So again, I'm just quoting this slide which we have already seen, the directive from Council of European Committee of Ministers. So this is another similar kind of the data collection, the retrieval of those abstracts and the articles which I have really performed, different from the one which I presented 10 minutes ago, but the picture looks quite similar. So in this one I could really use almost 23 articles I could really study those properly. And since the data on this is there's hardly any quantitative data, I had to really perform qualitative analysis, which is called, in this instance I use thematic analysis. There are certain themes which evolved, which I'm going to share with you. So this picture is from one of the AJT, American Journal of Transplantation report, which actually mentioned about this incidents which happened in Germany, wherein some of their patients in a hospital were really prioritized a bit higher just by saying, oh, they are on dialysis. So that was a bit of cheating. So there are the hospital director, some surgeons and some medics are on trial and they are in jail actually, just because they prioritize their patients, but that was at the cost of very precious resource, which means many others who could not get it. and the models were run, according to the models, the mathematical models, it was realized that some of those who lost their lives could have been saved if those organs were not sort of wrongly directed there. So certainly I'm not saying anything new here. It appeals to all of us that if the trust is not there in the medical profession, well, we all, and certainly patients, will suffer. I'm from the same city where Alder Hay organ scandal was really brought bad name to the city, and that really dropped the organ donation rate in northwest of England. It used to be quite high in northwest, and again I'm not saying it is not surprising, and that was really quite traumatic to families. And this is one of those articles, one of the many articles on Alder Hay scandal. So I'm going to bring in the scenario in India. Many people say that I live in UK. I say my body lives in Liverpool, but my mind lives here. So by that logic, I live here. So, well, we are well aware of there are many markers you can see, and I don't have to really verbalize it. We all know that the doctor-patient relationship, or especially the violence against doctors, is a really big problem, which is something which is very unique, more so in North India, but I have heard it happens anywhere in India. And there are many reasons behind it, and I'm not an expert into this to tell any one of us what the reasons are, nor I've got any special advice. But certainly as a professional, medical professional, I would say that we keep working on improving our profession's image. Probably it would have certainly some good impact on that. There are many other plethora of reasons behind that. I don't have control over there, and there are many articles written on that, and so one could go into it. But all I'm saying is that our image is actually whether it really would have an impact on whatever we like to do when we need people's support, whether it is about organ donation or whether it is about donation of blood. If we are seen honestly by public, then we would get their support. I like to believe that. So there are some of those articles which really mention we have been criticized, and again we don't leave our hostel number 3 or 7 where I was there for almost 8 years. So to kill a patient, but it just happens just because we are not really, at times even at the topmost institute, we may be missing in some ways. So it is not the knowledge which saves these patients, it is a skill of saving these patients, which is really very crucial, and that really plays. And this whole plethora of different reasons this article shows, I can read some of those because this is in quite small font. I would be less likely to trust the organ donation process, or I am concerned that this process could cause donor families causing some stress, that maybe the certification of organ donation would be expedited, or maybe some rules might be, some corners would be cut. That's what public might think, and the answers have to come from public. And I can tell you that similar kind of answers we got when we did survey when I went with the Liverpool transplant team to Belfast, and we are doing a survey there, and we noted that of course disfigurement is one concern, and second is, doctors might be really doing organ donation, the death certification a bit earlier, just to accommodate, just to get organs. So that's what some people may have, even though I like to believe NHS has got NHS is really respected, because if there is really true socialism there, it is the NHS, I would say. So there are many factors there. I'm just highlighting some of those slides, like violence against doctors, and when I go to my hometown Ghaziabad, there I've seen some of the plays and dramas there portraying this problem. So there are many, the number of those reports in newspaper is endless actually. So I've highlighted few problems, but let's just see what good has been done. Transplant games inspire the public, and I do always, whether I was in Chandigarh as assistant professor or whether in Liverpool, I always participate in it. So that was a few years ago. This is a concerned surgeon from Manchester, and he is really being, he's meeting his patients. He is a pediatric surgeon there, pediatric transplant surgeon there, and I was really stunned to see that these little girls, they were lined up. They needed, many of them, they needed walker to walk, but their amazing enthusiasm to do long jump was really stunning. I was really stunned. So one of my patients on day 4, going up and down the stairs just after 4 days after transplant, and 5 weeks after the transplant, she meets me in the clinic, says, "Oh, Mr. Sharma, I got a problem." I said, "Tell me what?" She says, "Oh, I can't run more than 5 miles. How can I get it make it better?" So a few months after the transplant, it is I saw her on the Snowdon Mountain, highest mountain in England and Wales, where we take almost 150 transplant patients every year on first Sunday of September. And there is a reason for it, because it makes people believe, oh yeah, it really works. It's just not people who are very moribund or who are really looking very weak or frail, they get transplant. These are very people who are fighting for medals. And many pictures, one of the many pictures there, I don't want to bore you with those pictures. World Transplant Games started in 1978 in Portsmouth, and they're almost there in almost any country. Why I'm showing is that there's lots of data to show that organ donation rates, at least in 50 miles area, certainly I can say about UK, there have been for some studies, it is shown to improve after the transplant games are organized. And I'll just quickly, something which Tom showed about donor family network. They always come and participate in transplant games. More than 2,000 patients all over UK, they fight for medals, and with them donor family network people, they also join, and to really and they are honored there, and that's a way of really acknowledging their amazing gift. So I would say in India, again, I'm not trying to be an expert here, but if celebrities, those who are topmost cricketers, those who are in movies, or those who are really in top echelons of politics, if they start coming forward for organ donation, for blood donation, then people would really follow them, and that's what people do in India almost blindly. Some of those charity events organized by transplant patients, and there's no doubt there's enough data to show that TV advertisements have really known to really increase the donor card registration, and that hopefully gets translated into the organ donation, something which would be quite dear to Dr. Sunil Shroff. So I have got many slides, I don't want to bore you with that, but this one figure which I need to show you. These 2,100 athletes who participated in last year's Transplant UK Games, and the kind of coverage people do get, 3.3 billion is the total reach of the cover of those games. So when I attend, I never like to miss those, going with my team, and it's just like a community and like a big family, and it gives a very good impression to public. Oh yes, it is worthwhile donating organs. Why I'm showing this, again, the course which I was mentioning, the acute critical care course, a very simple applied physiology based course which helps our clinicians to really become have those skills. That was only 4 years ago when my daughter started her internship. I said, "Oh, Devina, good luck for her career." She said, "Oh no, I can't start it unless I show them the ALS and ACLS certificate." So you have to really demonstrate evidence of skills. You can't do that job. And that's what I can tell you many stories, but I learned it hard way. And then once I learned CRISP, which I direct at many places, or ATLS, I'm not a critical care doctor. In 2 days, nobody can become critical care specialist, but we do have enough confidence in managing wherever this patient is unwell. Yeah, we can deal with that if we have a sensible approach. And that's what we developed, and I can tell you 90% of the pictures are taken from the tribal area where I work in central India. And just to highlight that communication skills which are really lacking, and we know we develop that, are very important, and end of life care is another very important key aspect of this course. We've done lots of publication based on our experience. In conclusion, this is the last slide, the evidence to support that the image of medical profession is really very crucial in making sure that the organ donation program thrives and does well. We have got evidence, level of evidence is at the most 3, 4 or 5. There are many published reports which show that it is mainly qualitative data which I use here, some quantitative. Medical professionals do have duty to educate public and build trust, and minimize and mitigate bad publicity about organ donation, and transplant games enhance rehabilitation, whether it is mental, physical and social. Reports of successful transplantation encourages donor card registration, and I've heard Noto does fantastic job, but I'm sure there's always a scope for getting better and better, and we like to believe we have made some difference through the way more than 1,600 doctors in 63 courses in 19 teaching hospitals have gained some communication skills which are well tested, and they are well trained. We like to believe that. Thank you very much.
Thank you so much, Ajay. Just very quickly to inform you that the World Transplant Games is happening next month in Australia, and we have, I think, close to 25 transplant recipients and donors attending from India, which is the highest number. Ajay, you talk about mistrust in the healthcare system. Ishwa is sitting next to me, and he has witnessed how the mistrust which happened in Kerala literally killed the program. You guys work in the government sector. Most of the transplant in UK and Spain happens in the government sector. 90% of all transplants happen in private hospitals in India. So we do have some problem with that, and we've seen this very often when you have this happening, public lose trust, and some of them who have actually placed organs are now saying that we don't want the donor card. Please return it, or please take our name off the register. Now we are getting those requests when some scandals happen. So it does have a bad influence. Since we don't have time, I would request the next speaker to come and speak. And Ishwar, can you just introduce him?
We have Dr. Massimo Cardillo. I hope I got your name right. You will forgive me for
fine.
mispronunciation. And he's going to speak on collection of manifestation of willing from citizens, willingness from citizens. Okay, over to you, sir.
Yes. Okay. Let me do it. No, this is not the presentation. This one. Okay. Thank you very much. In this few minutes, I will show you how the system of collection of the willing from citizen is organized in Italy, and mostly to respect what is foreseen by our national law that 23 years ago stated that the decision to donate should be on every citizen and not left to the family at the moment of the death. In Italy, the system is organized with a central agency, the CNT, the organization that I represent, that is based in Rome, and has the task to set up guidelines and protocols to proceed with accreditation of transplant center. We coordinate every single donation in Italy with allocation of organs for the national programs, so urgent patient and pediatrics and high sensitized patient and so on. We are also responsible for transportation of organs and the keep. We have a registry, collect and analyze every data from donors and recipient, and we are also responsible for international cooperation and scientific activity. We have also competence not only in the field of organ and tissue transplantation, but we are also responsible for the medical assisted reproduction procedure. We in Italy have 99 transplant centers in 42 hospitals, as you can see, 39 kidneys, 22 livers, 16 hearts, 10 lungs and 12 pancreas. The most of them are located in the north of the country, but also in the other region there are transplant centers with significant activity. If we compare the donation activity in the last years in Italy with other European countries, you can see that we had a drop in 2020 corresponding with the COVID-19 pandemic, but we have now increased and we have returned to the pre-pandemic values. Most of the donors are from deceased person, and only a limited amount of transplant are performed from living donors. We are very far from Spain in the annual rate. You see 2021 we have 24.1 compared with 40 in Spain, and we are similar to France. We have a problem with opposition from the families in intensive care unit. We have about 30% of family that refuse to donate, and this rates are even higher in the south of the country, Sicily and Campania, Puglia, and Basilicata and Calabria. In the north of the country we have lower opposition rates, and so the situation is better. We have about 8,000 patients on the waiting list, and about half of the transplant performed every year. So the demands for organs is greater than the supply, just like in any other country in the world. In Italy, every citizen has the possibility to declare the will to donate organ and tissues after death at 18 years of age with the renewal and the first request for the identity card. And there is both possibilities, so people can say yes, or they can say no, or they cannot say anything. So there are three possibilities that are all registered. The registration happens in the municipalities when the identity card is released, but there is also the possibility to declare at the association. The IDO is the most important association of donors in Italy. The declaration can also be released in the local health authority, or more simply with an holographic card or an holographic will register in the specific card that is available on the website of the ministry. All these willings are registered in a system that is available 24 hours a day in every regional transplant coordinator centers, so doctors can verify when there is a death if the person had left an indication, had declared in life a willing about donating or not donating the organs. The system is the transplant information system that has different function, not only the registration of the declaration of will, but the registration of every donor, every transplant procedure, and collects also the data of follow-up patient to monitor the quality of transplant performed and the results obtained. We have opposition also in life. It is more or less the same that of those that we register in intensive care units. So about 30% of people in life refuse to be considered as a donor. And the distribution in the region is very similar to what happens in intensive care units. So you can imagine that there is a problem of awareness of population in a more general sense. Until now, we have collected more or less 50 million of declaration. That means that 1 out of 3 people in Italy have declared the will to donate organs. And this is very important because in Italy it is mandatory to respect the will in life. So if the patient that died had said yes in life, we proceed with donation despite of any decision of the family. The family, of course, is informed, is accompanied, is is scared about the process, but the family cannot oppose in this case. And even in the opposite case, if the patient had said no to donation, the family cannot donate. So the aim is to have 100% of people that declare the will in life, because we think that it is ethical that anyone can decide, avoiding to leave this decision upon the family. We have observed a very specific trend in refusal in citizens, because as you can see, the mean is 31%, but the opposition rate is really higher in older people, in people older than 70 years. There's a slight difference also in the gender, but it is not so significant. Women are more generous. But the fact that older people refuse donation is probably the cause of this fact is the fact that people probably consider not to be suitable for donation. And this is very strange, because the median of donor age in Italy is very high. We have very old donors. The median age of utilized donor in Italy is 60 years. We have older donor compared with the USA, as for instance. And this year probably we had the world record in donor utilized, because we had a very old woman, 100 years and 10 months of age, that donated the liver. So this means that there is the possibility for everyone to be a donor. We award the municipalities that are more generous in donation rate. We have performed a ranking of solidarity in communities. We always register all the opposition rate in every Italian municipality. And we have also organized public campaign to promote organ donation. We are active on the web and social channels. So we have a very large community that is contacted every day through the web and social channels. We have set a national campaign in April. We will have the 16th of April, the organ donation day in our country. The claim is that donating is a natural choice for everyone. We do not think that the organ and tissue donor is an hero. It should be part of the social responsibility for every one of us. We have also promoted a program that is named FAITH, Fostering and Improving Equity and Participation and Inclusion in Transplantation Healthcare, that has the purpose to address all the foreign communities that are present in Italy, to do a similar work compared with that has already been done in United Kingdom and in Spain, because we have higher opposition rate in those communities, and so we think that it is also our responsibility to inform them in their language, in their belief, in their principles, to make them aware of this possibility also in the donation and in the transplantation field. Thank you very much.
Thank you, sir. Just very quickly, just wanted to clarify, what is this holographic card and why? Is it any advantage to have a holographic?
Yes, this is a card that you can have from the website, from the ministry website. You can print it and have it with your documents.
Okay. Thank you. Ajay?
Decline rate, and that has not really changed even in UK, even after opt-out scheme has been introduced for many years now, and the rates are quite similar, as I had mentioned about 15 years ago about by Sheila Gore in 90s. She looked at that, the affirmation rate was something like 70%. I would admire the work of Australians, and I have seen some papers, and have been gone through their curriculum at the high school level. At high school level, every kid has to really learn not just the science but also the ethics of organ donation. Although it is an investment which will really be a fruit
I think,
years down the line,
yeah.
I think it is worth considering.
Absolutely, great. I mean, that's what we are thinking of doing in India. Thomas, very quick, short comment, please.
Yeah, no, very nice. So, you know, we face the same problem in the United States with the older population who opted out of donation because they just didn't feel that anybody would want their organs. This is on. So, what we did is really tried to focus on that older population with literature, working with family physicians, working with internists, the physicians who are seeing those people. The other thing is, in going back to AJ's presentation, how we get information to people has changed so much over the course of the last 15 years, and everybody goes to the internet. I mean, Dr. Google has more authority than any one of us in this room right now, right? And when you begin to Google these websites, they're not medical websites that come up. And so there's a lot of false information that's being propagated out there by people who are not medical professionals. I honestly don't know how to combat that because we go to different medical sites. We go to trusted medical sites. I'm not going to the Journal of an N of 1 to prove something that happened. We go to New England Journal. We go to those resources,
it's a
right?
big issue. And with social media, of course, you know, it's another issue.
Yes.
Thanks so much, Thomas. I think we should move on because we're so short on time.
Well,
Yeah.
probably the answer is for the institution to be present in Dr. Google. So,
We will move on to the next presenter, Dr. Kanwaljit Garg. Is that right?
Thank you, respected chairpersons. I would like to thank the organizers for giving me this opportunity to present the results of a survey which we did to understand the knowledge gaps in brain death certification in India. This survey was designed by Dr. Deepak Gupta and myself. The first clinical definition of brain death was published in 1968. We have come a long way since then, and now organ donation and organ transplantation has become the preferable treatment for many end-stage organ diseases, and lots of patients have been benefited out of these procedures. However, there is still huge gap between supply and demand in organ transplantation, resulting in long waiting list. Coming to Indian scenario, the Transplantation of Human Organs Act was enacted in 1994. But despite the hard work done by Government of India, many NGOs and other societies, the organ donation rates still remain dismal, and we are still lagging behind the developed world. The reason for low organ donation rates are multifactorial. They are multiple. The first is lack of awareness among general population. The second is inadequate knowledge among doctors for declaring brain death. And the purpose of doing this survey was to understand this knowledge gap. With this in mind, we designed a questionnaire on Google Forms, and the link was circulated using email and WhatsApp to the various specialists who are commonly involved in organ donation on brain death certification. Coming to results, we had 177 responses. More than 105 responses came from neurosurgeons. Other big group was the critical care specialists. Around 35% of the respondents were from 30 to 40 year age group. 1/4 of the respondents were from more than 50 years age group. And about half of the respondents worked in public sector teaching hospital. 58% of our respondents told that they did not receive any lessons on brain death diagnosis during their graduation. About half of the respondents worked in high volume centers which are catering to more than 200 patients of severe of traumatic brain injury per year. Similarly, around 45% of the respondents were working in centers who are catering to more than 20 pediatric acute brain injury per year. About 32% of the respondents had certified more than 20 brain death in their careers so far. While on the other hand, there were another 30% who have not certified even a single brain death in their career. about 54% of the respondents had declared less than 5 pediatric brain deaths. The number of respondents who had declared more than 20 brain deaths in children was minuscule. 24% of the respondents opined that in their centers there might be more than 50 silent deaths occurring per year. And when we asked about the reasons for low organ donation rates, the reasons were lack of awareness amongst the family, lack of confidence amongst the doctors, refusal by the family, indifferent attitude of the clinicians towards organ donation. 31% of the hospitals, they don't have any checklist for brainstem reflexes. 25% of the hospitals didn't have organ transplantation facility or transplant coordinators. Regarding who declares brain death in the center, apart from the neurologist, neurosurgeon, anesthetist, medical legal team members were involved in the process of brain death certification in 15% of the centers. 58% of our respondents opined that they need 2 to 3 doctors to declare a patient brain dead. 79% of the respondents, they don't practice video consent from family members when the patient dies in another city. Another 80% of the respondents, only 80% of the respondents practiced observation period, always practiced observation period, and 6 to 12 hours of observation period was the commonest time interval practiced. And about 50% of our respondents, they don't routinely screen the patients for any drugs, toxins or alcohol. About half of the respondents, they are okay with the temperature range of 36 to 37 degree before they go ahead and do the apnea test, while 60% of the patient respondent didn't consider raised temperature beyond 39 degree a contraindication for conducting apnea test. The minimum blood pressure was a MAP of 60 and the systolic blood pressure of 100 was considered to be adequate, optimal for conducting apnea test by 57% of the respondents. Majority of our respondents didn't practice atropine or oculocardiac test in the practice. 96% of the respondents were considered themselves to be well aware of the procedure of conducting apnea test. 35% of respondents believe that there is no need to conduct second apnea test, and they believe that the law of the country should be modified accordingly. 65% of the respondents took consent from the family members before conducting apnea test. 72% of the respondents conducted apnea test in the presence of one colleague from neurosurgery, anesthesia or intensive care, whosoever is available. 78% of the respondents, they video record the brainstem reflexes while they are testing the brainstem reflexes, including the apnea test. 45% of the respondents took the sodium range of from 135 to 150 to be optimal for conduction of apnea test. There were 9% of the respondents who opined, who responded that they don't perform pre-oxygenation before conducting apnea test, while about half of the respondents practice pre-oxygenation with 6 to 8 liters of oxygen per minute for about 10 minutes. Regarding the need of ancillary test, as has been discussed, about 40% of the respondents felt that there is need of conducting ancillary tests in all cases of brain death to avoid litigation later on. But when it comes to practice, only 18% of the respondents routinely perform ancillary tests. And CT angiogram, angio-CT was the commonest investigation ancillary test performed to check for cerebral blood flow. Only 13% of the respondents always did a EEG for brain death diagnosis. The respondents from age group more than 50 years were more likely to be associated with more than 20 organ donations, brain death certifications in the career. The teaching hospitals, whether public teaching hospital or private sector teaching hospital, they were more likely to have transplant facility as well as transplant coordinators. As has been discussed earlier, respondents from private sector hospitals were more likely to be involved with brain death certifications as compared to respondents from public sector hospitals. The hospitals with higher volume, the hospitals which were catering to more than severe TBI patients per year, were more likely to have organ transplant facility and transplant coordinators in their hospital. There were some specialty based differences on the practice or advice of observation period before declaring patient brain dead. And it was seen that the respondents who thought that ancillary tests must be done toward litigation were less likely to be involved with the brain death certifications. So based on these results, we found that the responses were very variable. They vary a lot from the standard guidelines, and partly this is because of inadequate training. The training during graduation was only 40% of respondents received any training during graduation. Forget about high school. So during graduation, and we think that the residents who are dealing with severe TBI patients should be trained further. So just to summarize, there are significant deviations from the standard guidelines. It's because of inadequate training, and this is partly responsible for low rates of organ donation in India. Thank you so much for your attention.
Thank you very much. It's an eye-opener of a survey for our country. This is first of its kind. Congratulations for running it. I must brutally prevent you from asking questions. Please ask those questions when you are having lunch with him. We are
Thanks so much.
woefully behind time.
No, sir. We'll be going to our next session. May I call upon Dr. Sushma Sagar and Dr. Sandeep Seth to chair the session.
So I have to be short because we have very short time. In a few minutes I will show you the Italian experience on organization of donation in the hospital in the COVID period. You know that Italy was the first Western country that was severely hit by COVID-19 pandemic in 2020, in February 2020. We had in this 3 years period more than 25 million cases with about 200,000 deaths. From the very start, we decided in Italy to maintain donation and transplantation activity despite the COVID, and we suddenly give indication to perform in every deceased donor the research of the virus by the bronchoalveolar lavage in the case of deceased donors, and with oropharyngeal or nasopharyngeal swab in the case of living donation. This was the first measure that we set to maintain the activity with safety. The second indication that we gave was to consider the donation and transplantation activity as essential level of assistance. So we gave indication to the region to avoid the downstaging of the local coordination units, because a lot of intensive care doctors were separated from donation activity to be devoted to the care of COVID-19 patients. That was another very important measure, and also to give new indication to address the families, because as you remember there was no possibility to have direct contact with the family during the COVID period, so it was very difficult to address them, to discuss the possibility to donate. It was a very difficult period. We set in the last month of 2020 the COVID positive patient registry, a register of every COVID-19 positive patient, and in the last month we gave also indication for the vaccination of the wait-listed patient. There was a lot of discussion at the start if to vaccinate or not the patient on the waiting list. We decided that it was very important to vaccinate them, even though we were not sure that really could respond in a production of antibodies, but in any case, that was the decision. In the following years, we gave new indication for the safe use of COVID-19 positive donors. I think that Italy was probably one of the first countries that started using COVID-19 positive donors. At first only for urgent patient, for heart and liver urgent patient, and subsequently also for kidneys. We had a drop of 10% activity in 2020. It was less when compared with France or Spain, even though I know that United States had very excellent result in the probably United States was the only country in the world that increased the donation activity also in the COVID-19 period. I really don't know how could you achieve this with very important result. And we have improved, we have already shown this slide, so now in 2022 we have returned to the pre-COVID pandemic period as regards the figures of utilized donation. This was the paper that was published in 2020 with the publication of the first 10 cases of liver transplantation from active COVID-19 donors. It was the first paper that was published with showing this possibility, and in the following month we also had 2 heart transplantation in patients that were negative, that had never had contact with the virus, one in an adult and the second in a pediatric patient, a 15 years old patient. In all of these cases, no transmission was observed. We gave indication for the safe use of the donors. In May 2020, we started using donors with previous history of COVID-19 infection, and this was the first indication that we gave, with possibility to utilize these donors if no permanent end organ damage resulted from COVID-19, and also with a very careful evaluation and a discussion with the patient of the risk-benefit of the procedure and the signing of a specific informed consent. Soon after, we started using the donors with active SARS-CoV-2 infection, and this was the possibility that enlarged the pool of potential utilizable donors in this setting. The condition was that the death was not directly correlated with the COVID-19 infection, and that was very important to exclude the cases with severe COVID-19 manifestations. And in the first series, we foresee this possibility only for specific patient categories. So in the case of heart and liver transplantation in severe clinical condition, the patient should be or asymptomatic with a SARS-CoV-2 infection, or with an history of resolved COVID-19, or if they were fully vaccinated with an mRNA vaccine with three doses of mRNA vaccine and documented seroconversion. For kidney transplantation, we included patients with asymptomatic SARS-CoV-2 infection or with an history of resolved COVID-19, or also if they were fully vaccinated with 3 doses of mRNA vaccine and documented seroconversion. We foreseen also a monitoring of the recipient status after transplantation with the molecular testing or nasopharyngeal swab for the virus or the BAL if the patient was intubated, the SARS-CoV-2 serology, and the molecular testing for the virus on other samples such as biopsies, organ biopsies and preservation fluid, the donor graft, and so on. We have used in these 2 years 124 COVID-19 positive donors and transplanted 236 total recipients for any kind of organs except for lungs. No cases of documented transmission was registered. In only one case, we had a kidney recipient that had a positive nasopharyngeal swab on day 7, but without any symptoms, and in any case, he became negative on day 14. So the results are very satisfactory under this point of view. We have organized a policy, as I said, for vaccinating every patient on the waiting list. Out of 43,000, about 43,000 patients transplanted. Also, we had organized a policy for transplantation in transplanted patient. And the majority of them were vaccinated with more than 1 dose. You see that about half of them are vaccinated with 4 doses, 45%, and 44% of them are vaccinated with 3 doses. So there was a very huge vaccination campaign both on the patient on the waiting list and on transplanted patient. These are the figures of vaccination correlated with patient age. Vaccination rates are higher in the case of older patients, as you can imagine. We set up a pilot protocol for lung transplantation in recipient with COVID-19 infection outcomes. They are not very high numbers because we received only 7 requests for this patient. 7 requests, 2 patients had ARDS syndrome and 5 with pulmonary fibrosis. 5 out of 7 patients were transplanted, only 1 patient died, so 4 are alive with a good function, and this experience demonstrates that lung transplantation during the COVID-19 pandemic was possible, and the lung transplantation in such patients with ARDS or fibrosis post-COVID-19 is possible. We also went on with the training activities in the COVID-19 period with a little change in the setting because we, in many cases, we passed from the on-site training activities to the remote programs, both for procurement with the TPM course and the Trade to Action course, so on the transplant setting with courses for the transplant nurse coordinators, courses for the surgeon on the donor surgeon on the laparoscopic kidney surgery, and so on. We performed many webinars on different topics, updating the national guidelines on the malignancy transmission, on COVID-19, on lung transplantation, and so on. We, in these last 3 years, have trained more than 14,000 health workers in these different training programs. In 2020, in August 2020, we had the first utero transplantation in Italy in the full COVID period. And this year, the first baby was born from this uterus transplant. So it was a very successful procedure in Sicily. There is a recent experience, mostly in the United States, that there is the possibility also to use the lungs from the COVID-19 donors. And this brief communication shows a very short series, 14 cases, but the preliminary results are quite satisfactory. And this study shows that hearts and lungs from donors that are tested positive for COVID-19 were eligible for transplantation, provided that the donor exhibit no evidence of hypercoagulability or COVID-19 induced hyperinflammatory state during terminal hospitalization. As regards lungs from donors tested positives, the indication is that in the case that the positivity is less than 20 days prior to death, the donor is ineligible for transplantation. In the all other cases, this possibility can be considered. All donors with the potential lung donation are obviously detected with the various research on the bronchoalveolar lavage. So, in conclusion, we can say that the COVID-19 pandemic was one of the major challenges in the history of transplantation, but we have demonstrated that transplanting organs from such donors is currently a reality. The risk of virus transmission is extremely low with non-lung transplantation if specific criteria are applied, both in the donor that in patient selection. And the antiviral prophylaxis to prevent transmission in non-lung transplant recipients is probably not necessary, but it may be prudent to be used in lung recipients. 3 days of this antiviral drug is probably, the remdesivir is probably the best option if the COVID-19 prophylaxis is part of the protocol specifically in the lung transplant recipients. Thank you very much.
How did you arrive at the 20 days for positive COVID?
Well, the reason is that if 20 days are passed from the first positivity, probably that donor has no more virus in the circulation. So if you detect, you know that molecular testing is very sensitive, can detect every little part of the virus. So probably in that case, it can be considered safe to use these donors. Yeah.
Thank you so much, Dr. Carlo. It was a wonderful talk and eye-opener for many of the people. When most of the elective surgeries were stopped in the whole of the nation globally, you continued with your transplant program. Thank you so much. And now I call upon Dr. Rajesh Chabra for his talk.
Good morning. It was quite interesting listening, quite informative and elaborative talks from different parts of the world, especially US, UK, Spain and Italy. But in India, the situation is different. If you see in India, the Transplantation Organ Act came in '94 only, and then NOTO was established in 2011. And what problems we really faced while working we are working in an institute, not a local hospital, but still there was any push from any side to work for this brain death declaration or work on the different side. In India, if you see in the past, there was quite a bad name to organ transplant because of some nexus of buying organs and things like that. And that's why every doctor started shying away from this organ donation part. So that was the basic thing when we started this program. What happened in around 13-14 when one hepatologist become director of PGI Institute. He was quite interested in liver transplantation by this organ donation thing. So he started coming to neurosurgery department and pushing us hard to do something about that. So how it started? So I was basically attached to this program from since beginning, and it was quite difficult to not only to convince the general public but to convince even the doctors, even fellows. Even my colleagues, they were not very keen in getting involved in this program, not because it was basically an extra burden. Why to unnecessarily involve yourself when you are already so much occupied? So it is quite easy to declare a patient there and then, rather than keeping and maintaining that patient on for this organ preservation. The other problem was in India, and especially I am talking about PGI. Not all the patient of severe head injury or moderate head injury gets ICU admission. So patient was lying without ICU, and suddenly you convince a patient, if you agree for organ donation, and if he agrees, then we shift that patient to ICU. So that gives a very paradox kind of information to the patient relative and the patients around them. Once the patient was lying there once you are supposed to save the patient and he was not getting ICU, but suddenly if you told the doctor that you are willing for organ donation, and immediately ICU was arranged and patient was shifting to ICU, and you are now working on organ preservations rather than saving the patient. So this was a quite paradox which really disturbed sometimes not only the attendants, sometimes to the doctors also. So these are the different problems which we faced, and the sensitization not only to the doctors, I am telling you, but the nursing staff, to the administration, to the health. There is a wide range which it's a really big team which requires to get the organs, to have to convince the attendants to maintain the organs, to retrieve the organs. There are so many things. So it can't be a one person. So I took the initiative. I told Dr. Chawla that if you want me from as a neurosurgeon, we'll create a single window kind of thing. So every problem related to neurosurgery, I will handle. So whatever the problem is you face, so I will be the representative of my department and I will handle that. So how it started, and yes, it really brought a change in the scenario of PGI. Even my son, who was in 10th, after seeing me working in this, he voluntarily asked me to participate in that. He used to give lectures at different audience. So that's how I attached to this program, and we really took to some extent in PGI. So now in PGI we are, although the number which I saw in the morning, they are quite enormous, but in PGI we are doing around 40 to 50 organ donation per year, which you can say one organ donation per week. So that is the achievement, and AIMS even started quite late, even after us. So let us see how they will proceed. So with this I will start. I will just skip few slides because it was basically I prepared my slides just for the audience, considering the fact that there must be residents and young neurosurgeon friends, but here everyone is quite go ahead of these slides. So I will just discuss only the PGI experience. That's what my understanding is. Okay. So death at all, once all settled, but persistently still unresolved. In India, what were the problems we faced, because we are mostly in India, they are aware of cardiopulmonary death rather than brain death. So which is still, I mean, when we started, it's a new concept for not only for our staff, but for they know, but they were not aware of the things, and for the patient, the attendants also. So this is the Uniform Determination of Death Act with either cardiopulmonary or irreversible cessation of all function of the entire brain. So brain death is death. So this is we have to explain every attendant, every surgeon, every nursing staff, every resident, every helping staff, every paramedical staff, administration. So this is how where we start. So these are the different terminology for brain death which have been used in different times. So these are the controversies because of more than one kind of death. It's always difficult to convince people that that is death, this is also death. So this is how you find difficulty. So has the whole brain died or has the human being died? So these are the few questions which are very relevant once you start explaining to the attendants, to the doctor, to the person who has a limited idea of brain death. Because in brain death, if you really see, we were, even if I see myself, during residency, I never declared any patient brain dead. So that is acceptance I have to take. And during my MCH residency, I'm telling you, which I completed in year 99-2000. So till 2000, we hardly declared any brain dead patient just for the sake of organ donation. I'm not taking the organ donation part here because as a neurosurgeon, I feel my first responsibility that I should declare brain death. So whatever happens that is beyond that my scope. So at least we should involve ourselves to the brain death declaration. So these are the different controversies. So brain death and organ donations are quite closely related, but should be addressed separately, what I feel. And neurosurgeon should try to just restrict himself to the brain death, which is quite possible and easy and safe and informative and helpful. And for this, we have to have a task force of this neurosurgeon, neurologist, critical care medicine and other person. So this is the teamwork where doctor breaks the bad news and nurses should promote awareness and positive attitude, and transplant coordinator should request for organ. So these are the different which we work as per this model, and so the patient should get convinced for this thing. Not only because if this is the most difficult part, every person playing here is very difficult role for their part, because breaking bad news is really difficult for doctor, because we are here to treat, not to declare that patient is not going to survive. Although it's a reality, as Dr. Thomas told, but the thing is, still it's very difficult to break a news like he's not going to survive. You have to do some, because suddenly then you ask starting this, if you can donate organs, then he said, so you sometimes you feel little, distraught or imbalance, and then similarly for nurse, it's transport coordination, convincing them. It's a explanation is different thing. Now you have to convince them to donate organs, so it's again difficult. But at the same time, you should respect each other's space. You should not cross each other's space, because once you start crossing each other's space, it will create problem. So a lack of boundaries invites a lack of respect. So that is my thing. So in India, as Dr. Kawaljit showed, that awareness about brain death is extremely low. So India follows the UK concept of brain stem death. So Transplantation THOA Act was passed in '94, and who should diagnose this already we discussed. Now with amendment, neurosurgeon and neurologist can be replaced. They are not available. They can be replaced by surgeon, physician, anesthetist or intensivist. So but now I will, this all things we know that how the brain death is, what are the pitfalls, why the problems are there. So first the inexperience of the performing physician. If he doesn't understand, if he doesn't aware, if he has not done, if he has not seen, then he will be always hesitant to go into that field. And again, the potential co-founders are like some hypothermia, drugs, alcohol, which you have to differentiate, which is the integral part of the declaration. And this inadequate consideration during apnea test. So, and false positive brain death determination in barbiturate, coma, baclofen toxicity. False negative, sometimes these spinal reflexes, automatism. And another difficulty. Okay. So Chandigarh experience basically, yes, this study we conducted among 244 nurses and 87 resident doctors, and we basically asked a few questionnaire regarding the knowledge about the this procedure, and then we sensitized them, and then again asked the questions. the positive impact of intervention was observed. And this is the graph when we started in 2014. The ratio was 4 to 7 patients per year. Now it touched around 44. It has gone down during the COVID period between 2022. So that is the thing which I can tell you. Thank you very much.
We have another talk from Chandigarh. Let's take that talk and then we take questions from both the speakers.
Where do I get my slide? Good afternoon, everyone. Today I am here on behalf of Dr. Vipin Kaushal to share our experience of gaps between certification to conversion in brain dead. As we all know, PGI has been a forerunner in the implementation of the deceased organ donation program, with starting with the kidney registration in 1995, exactly immediately after the implementation of the Transplantation of Human Organs Act 1994. We have done 565 kidney transplants since then. We are a leading center in pancreatic transplantations, and this slide has been already shown by Dr. Chabra, where we started slow, but we eventually gained, and now we are doing a drastic number of donations in the last few years, except for the COVID times. Looking into the milestones, we have saved 592 lives through 294 cadaveric organ donations, and the youngest organ donor being 68.5 hours only. We are a leading center in DCDs, where one of the centers where DCD is being done in India. In our journey, we have faced many challenges in our entire journey of deceased organ donation since its inception. There was a lack of dedicated staff. There was no coordination between the various transplant departments. There was no one to take care of the logistics if the organ was being shared. Talking to the next of kin, communicating to the grieving families, MLC cases where the police is involved. This all has been addressed by dedicated transplant coordinators, where now they take care of each and every aspect of deceased organ donation. Counseling and seeking consent from the next of kin has many challenges. The major challenge that we face in our institute is the non-availability of the next of kin in the hospital. Conflict and interferences of relatives. For a single donor, when we are counseling the families, almost 20 to 25 relatives are present in the hospital. And finally, the non-acceptance of brain death is one of the major challenges among the families as well as the hospital. Now, addressing these gaps, the way we addressed was like bringing clarity about brain death, not just to the staff, but also whenever there is a potential donor. We have dedicated spaces to counsel the families for awareness and motivation of next of kin. Even if the next of kin is not present in the hospital, we try to take the consent through telephonic, and this is done through the MS of the hospital. The format has been attached. As we all know, in India, the maximum cases of organ donation are medico-legal cases. So in these medico-legal cases, the awareness of the police is one of the challenges, their attitude, so that the timely body can be handed over to the family. To address these issues, again, the role of transplant coordinators is very important, where they not just talk to the investigating officer of the case or the coroner, but also we have to deal with, sometimes we have to liaison with the higher police authorities, because it is very difficult in MLC cases to get to the IO and explain to him about organ donation and handling, and as well as handle the whole process of organ donation side by side. We have even conducted many sensitization meets with the police to explain them their crucial role in the whole process. Cooperation and coordination with different departments in the hospital as well as outside the hospital. The main challenge is whenever there is a potential donor, it is a race against time. The family is very impatiently waiting to get the body. Patients many times become unstable. Cross-matching, logistics, everything is a challenge. The way we have addressed is we have a very good team. We have built a very proficient team for doing all this work. In case the sharing of organ is planned, the logistics are pre-planned and family is informed accordingly. Whenever there is a retrieval going on, simultaneously the forensic team is kept ready for all the formalities. And the police is also informed so as they reach on time for the inquest and the post-mortem formalities. The forensic department in our hospital plays a very important role in all the MLC cases. I think I'm not able to load some pictures here. But these are in MLC cases, we actually take many clearances first from our forensic department itself. We do not start any MLC case without the the permission of the forensic expert, because in any the NOC is obtained from the forensic department so that the retrieval process does not hinder the objectivity of the post-mortem. The police is informed well in time so that they reach on time and we can proceed with the retrieval as well as the body handling over formalities. These are the retrieval notes that our surgical teams actually fill in, not just for the retrieval of the organs, but the other organs as well. Intraoperatively, when they open up the body for retrieval, they fill all these details there so that in the end, during the postmortem, the time is saved and there is no issues or these notes are very clear and thorough. In PGI, we have a very clear mandate of not wasting any organs. Since 2015, we have shared almost more than 60 organs and created green corridors and almost 3 green corridors in a single day. Donor families are considered the main pillars of deceased organ donation, and to facilitate, to make their experience hassle-free, we have done a lot of things. Like the cost is borne, the whole cost is borne for donor maintenance by the institute. There is a donor stamp with all the investigations and requisitions are sent through these for priority and timely reporting. And with utmost respect, in the end we hand over the body with all compassion and respect. I think I'm not again, this is not being loaded. So we arrange many felicitation programs for the donor family so that they are being felt respected and the good they have done is eventually shown to the society. Thank you.
So any questions for Dr. Chhabra and Dr. Parul?
Big congratulations to your team in Chandigarh for doing some amazing work in the country. As far as your donation rate is concerned, you have the highest donation rate. As far as city donation is concerned, you have a donation rate of 30 per million population against 0.7 per million for the rest of the country.
Yes.
So if we could duplicate Chandigarh everywhere in the country, we would be somewhere else. But I just want to ask you one question. You do get a lot of feeding patients from different areas around Chandigarh, including Himachal and so on. Have you done a study to look at how many are actually local and how many patients come from adjoining areas away from Chandigarh? Thank you.
Sir, almost 95% patients are from outside Chandigarh.
I mean, you talk about public, not ready to give. And in many of these areas like Himachal, there's not even awareness of our donation. And despite that, they're willing to give, provided you support them on the ground in the decision to donate. Am I right?
Yes, sir.
So that's, I want some clinicians to understand, because we've been discussing about this public issue, not wanting to give. It's not true. You agree?
Totally, sir.
For this thing, I would say that first the doctor should be convinced, and then he can convince the attendants, the public, or the public.
Dr. Deepak.
I saw in the presentation in the consent form or from the family, there are almost 9 people who have signed. I mean, three from the family, 1 transplant coordinator, 1 duty officer. Is it the basic minimum?
No, sir. So this is the telephonic consent. It's not the physical consent.
So in the telephonic consent, do we need so many signatures? I think.
Yes, sir. We go ahead with this. We have a very stringent protocols for all these things. So we actually take signatures from the family present there, from the transplant coordinator, from an independent witness, and from the MS of the hospital.
Any? Yeah, I saw.
So that was the independent witness there.
2 ASOs, one transplant, 1 duty officer, son, brother, and medical superintendent. This is the form I am referring to.
Yes, sir. Yes, sir. Yes, sir.
I think we'll have rest of the discussion in the lunchtime. Thank you. So I'm calling upon Dr. R. Raghavendran for his talk now.
Good afternoon, everyone. Respected chairpersons, Deepak, I thank him for giving me this opportunity, and respected seniors and friends. So the topic says it all, that we have done at least something as far as brain death certification and organ donation has been concerned. So the challenges faced, I would rather say the challenges that we have overcome along with what we have faced. So this is what we have done over the years, 9,655 total from Tamil Nadu. And we have been the national award winner for the best state for 6 years in a row. And in July 2010, the WHO has established a blueprint and had advised many countries and other states to follow the Tamil Nadu model. And since then, many states in India had followed it. So what exactly was the triggering point for Tamil Nadu? It is the organ trade. So we had a small pocket of area which we call this as Villivakkam, has been turned out to be a kidney Vakkam. If you can Google, you will find that organs are available for anywhere between 25 to 40,000 rupees. And what most important was 90% of these donors were women. The man had donated his mother's kidney, wives, and sometimes the daughters also. And this women exploitation is what triggered the then Chief Minister to take it up, and the Transdan was formed under a robust brainstem death organization, and deceased death donor organization came into it. So we are the first in offering financial assistance to even private hospitals, poor patients going to private hospitals of up to 22 lakhs. It is in 13 government medical college hospitals, and today it is all 39 are empowered to go ahead with organ transplantation. So first in the country to streamline organ allocation, clarify medical legal procedures related to organ donation and multiple transplants. First to play an advisory role to many states and the Government of India. Even the GOI, Government of India, have replicated the GOs of Tamil Nadu. And first state to have an achieve among the awareness, Guinness World Record for organizing the massive awareness campaign, and also a walkathon, which is in the Limca Book of World Records. And we have a 10-year post-transplant data, which covers review at 3 months, 6 months, 1 year, and then yearly from across the transplant hospitals. So the first challenge we faced was consent factors. In the initial period of time, we thought the relatives are donating the organs. They're poor people. What if one of them needs an organ? Will they be affordable? That was the first challenge as a doctor we faced when we started. So we had multiple sessions of meetings with the government, and then the Chief Minister's health insurance scheme came forward with, formed a corpus fund, and anybody, whether it is a government hospital or private hospital, they will have 22 lakh, up to 22 lakh rupees were sanctioned if the people need not pay anything for that. That was one of the challenges, and this is how we solved it. So the success of the deceased donor program in Tamil Nadu is due to the immense support extended by the government. It gives up to 22 lakhs 588 end-stage organ transplant poor patients have benefited because of this 22 lakhs that is given from the corpus fund by the government. So next challenge we face, almost everywhere, everybody has spoken about that, is the sustainability of the certifying team. See, my chief was very passionate about doing this brainstem death certification. I have taken over, and what next I do not know. We should have a second in line. Whether this certifying team, it is always an individual who has the passion to certify brain death that is leading in that particular hospital. So, and at the same time, that individual person, you see on one side there are people who are over enthusiastic. Sir, I have a brain dead patient. They don't go through everything. On the other hand, there is a reluctance. People come and simply write pupils reacting. Patient is breathing, knowing fully well that is brain death. That is one other problem. So the sustainability of the certifying team and whether there is an acceptability in the system, that is more important. And time and again we have always felt the donors' relatives are easy to convince compared to the certifying team on many occasions. That is one challenge. So we again sat with the government and we put a GO, the last para. It is now made mandatory. It is mandatory that any medical officer who is coming across a brainstem death patient, he has to certify it. And the same GO also gave all the guidelines based on which the certification needs to be done. And we have the 7 times national average. And not only the second tier cities, the tier 3 cities, the names which you will not have heard at all, today they are doing organ brainstem death certification and organ transplantation, and almost all medical colleges in Tamil Nadu, that is 39 of them, have been converted into transplant centers. Previously, the potential brain dead patients were being transported to other centers. Now it is not being done. The recipients in the transplant team go there, go to that particular hospital. That saves a lot of organs. So again, still we have the issues, the high burden, lack of awareness, poor donation rate in spite of a robustly running program, in spite of poor people also being helped by this government that gives grants. And the most important aspect is, what about assault patients? When we have a patient who is assaulted and brain dead, how do we go about the legal issues? What is the time of death? Can we conform ourselves to the dead donor rule that says harvesting of organs should not have caused the death? That is one issue. And then we have another unknown patient criteria, where we do not have any relatives with the patients, how to proceed with them. That is a challenge which we have not still solved. This was another case recently. We had an 18-month-old child from Andhra admitted here. There was no problem about the certification and other things. But for organ harvesting, we needed a no objection certificate from the police department of Andhra. That was some 250 kilometers away. Fortunately, when we called up, the sub-inspector of that station was courteous enough. In 20 minutes time, TV had fallen over the head of that child. 20 minutes time, he sent a PDF to my WhatsApp. We do not have any objection. There are people like this who help us to solve these things. So success factors have been the government's support, capacity building, creating awareness, all government medical colleges, increase in number of trained transplant coordinators, involvement of NGOs like Mohan Foundation, Sunil sir is here, and brought up the cooperation between public and private hospitals that has helped us overcome these challenges. It is still a myth that people are generally unwilling to donate organs. That is not true. And if you see corporate government hospitals, economic class, level of literacy, all these things does not come into the picture of acceptance. And the other myth is there are not many patients who are brain dead. At any given time, every major city will have at least 8 to 10 patients who are brain dead in various ICUs across the city. It is we fail because of various other reasons. So we continue to have continuation medical education programs. We conduct almost 18 sessions of 3-day programs across every year. It's a continuous. And we hope to increase our brainstem death certification and organ harvesting rates. So this is another important slide which I want to show you. The maximum number of organ transplants is happening in Delhi. But the yellow is living donors and the green is the deceased donor that comes through. If you see even Andhra and Karnataka, they're all very close, almost 1/3 to 40% they come through the brain death. And look at Telangana, Maharashtra, Tamil Nadu. So if you take Maharashtra, Telangana, Tamil Nadu, Karnataka, Andhra, and to a certain extent Kerala, almost they are trying to come somewhere. But if you look at there, West Bengal, Delhi, Haryana, Uttar Pradesh, Punjab, it is almost not happening at all. So our aim is to bring this yellow to a nil and match with the demand with only the green. And at the same time, when we were formulating these policies, the government came up with an idea, why don't we reduce the green? So if we think of reducing the green, the transplants, then we should find a way to reduce need for organ transplant, because we feel most of them are preventable. Yes, I am not saying every organ transplant is preventable, but majority of them is preventable. So we should look at to reduce the need for organ transplant, and that is when the government came last year in August with this a robust screening for the non-communicable diseases. That's called the Makkali Tedi Maruthuvam, which means the doctor goes in search of the patient. What we do in this, every hospital, a patient comes along with at least 1 or 2 attenders come. The attenders are screened. The attenders are screened for presence of diabetes, hypertension, cervical cancer, breast, everything. So we pick them up at random, and then we start treating them. Drugs will go to their home. That's what Makkali Tedi Maruthuvam means. It is a robust program which has been started, and we are definitely able to get many number of patients who are hidden, who are not aware. It is only the attenders of the patients who come to the hospital. So based on this, that is what the challenges we have faced in Tamil Nadu over a period of years, and most of them we are able to find some solutions. We think we are going ahead, but even then the gap is still very wide. Thank you so much for the opportunity. This is a small poem which I have written. I tickle, I pinch, but not a bit do you flinch. Cold water in the ear, eyes sadly do not steer. You are being a sport, not wincing with the tube in the throat. Hypercapnia should trigger, but apnea seems more eager. I am afraid it appears we must say our prayers and hope that you will give time for another life to fill. And brain death is not a diagnosis today which we made with a stethoscope. It has become a decision where the physician sits with the family and decides what is happening. If I say I will not be permitted to die, if I will be permitted to die only if I am not on an ECMO, I am not on a ventilator. Who will take that decision? The process is very painful. So I gratefully acknowledge neuroconsultants, anesthesiologists, intensivists, transplant, administration, all the donors and the relatives. Thank you so much.
Only one small question. I know there will be too many questions. Only one small question, no comments.
Thank you, Dr. Raghavendra, for being a champion of the cause and keeping Tamil Nadu going. Without you and Dr. I don't think so, Devikan, we would have made this possible. The biggest advantage is the equity which you have kept between the government sector donations and the private sector donations, and that's what has kept us going. I just want to ask you, how many of the donations now are happening in the government sector compared to private sector? Do you have any idea?
Sir, in 2021 it was 36 versus in the government sector versus 158 in the private sector. Last year it has narrowed down. This year we have had 11 so far, and in the private sector it has been 9, 11 from the government side. Yes, sir.
Dr. H.V. Iswar.
Good afternoon. I know it's something stops us from having our lunch is all these delays. Well, I go straight into. Well, yeah, you have a flight to catch at 5. Well, I'm not going into the initial few slides because I'm sure it has been repeated several times. What is going on in our country? Well, I only look at the trials and tribulations that we went through in the last 11 years as Kerala started its deceased donor program of receiving organs from deceased donors.
The first criticism that was there in our state was that government was favoring private hospitals. So we made a change to tweak the rules and made sure that at least one kidney, because liver transplants were not happening in Kerala's government hospitals until about a year ago. So one kidney goes to the government medical college, and a transparent wait list of patients was available online. And then when listed patient failed to secure the fitness for receiving it, complaints were raised. So this was the first thing that we got it. The second was the legal challenge mounted by certain vested interests, which wanted the live donor program alive, because there were a lot of commercial donors being seduced into donation against lots of money with agents involved. So they filed a public interest litigation, and they questioned the validity of brain death certification. Fortunately, a deposition explaining the steps in brain death certification and how organs are donated was accepted by the Honorable High Court, and the public interest litigation against it was dismissed. And then there were the red herrings when you are doing transplantation, when you are doing brain death certification. That is, what do you do when there is hypothermia? What do you do when there is hyperthermia? What do you do when you have a third nerve palsy? Well, all these things needs to be addressed when we declare somebody as brain dead. Then the critical care diagnosis of metabolic encephalopathy, which can be due to a lot of reasons. Toxicology screening isn't mandatory for all. CNS depressants, well, what I do is we let 5 half-lives pass, and most difficult thing is having thiopentone in it. For neuromuscular blockade, is there a residual neuromuscular blockade there? We do a trial of 4 with the help of the anesthetist and clear that. We had one patient who had a Lazarus sign, which was actually a flinging movement of the hands when you declare when somebody is brain dead. Fortunately, the relatives and no one else watched it. We could explain it to the relatives afterwards that this was there, and they accepted it gracefully after explaining what it is. I'm not going to the story behind the Lazarus phenomenon. Well, pitfalls of ancillary tests. Well, we had to, there's a committee in which I was a member, which advised the certifying teams to go for ancillary tests when the clinical tests were difficult to perform or kind of ambiguous. So I usually depend on, being a neurosurgeon, my favorite ancillary test, of course, is the CT angiogram. You look for the column of blood, the column of contrast in the 2 middle cerebral arteries, 2 angiocerebral arteries, the internal cerebral vein, and the vein of Galen. The score of 7 is the easiest thing to practice in my ICU. Electroencephalography, well, I don't have anything against the neurologist, but EEG is not at all reliable in an ICU setting where a lot of artifacts do happen. Media criticism, relentless criticism in the media against the transplant program, which was inspired by one individual, Dr. Ganapathy. And there was a movie called Joseph where the villains did people off with road traffic accidents, and then their bodies were taken to the hospital from where organs were transplanted. So unfortunately, this did a lot of harm to the transplant program from deceased donors, and took a while for Kerala's transplant teams to recover from this blow. Police harassment, well, there was one instance when the police came in search of the certifying doctors when there was questions raised about the veracity of the certification process, and this created a scare, and doctors refused to come out and certify. Videography, well, this is one thing which I always depend on. When there is a question asked in the court later, videograph what you're doing so that the court gets convinced about what you're doing. Okay, and paperwork. There's one instance when the person who filed this public interest litigation went to a medical superintendent of a hospital, government hospital, and asked him, do you go and certify brain death in the middle of the night? His answer was very naive and true. He said, I send my residents to do that. This was recorded in a video pen camera and then reported to the government, the High Court. Well, the most important thing is, please be there when you certify and affix all your signatures. Paperwork is most important. In Kerala, audit is another phenomenon that is happening. In Kerala, at least the 2 medical private institutions who are doing transplants were subjected to audit by a team of neurologists, neurosurgeons, and forensic consultants. So very most important thing is get your paperwork right and get your video records. All this helped me because I was part of this hospital where a maximum number of certifications happens in Trivandrum, and that is a private hospital. Well, death threat, Well, Dr. Ganapathy is a vocal critic of not the Ganapathy neurosurgery, this is Ganapathy, a physician from Kerala, who's been a vocal critic of the deceased donor program. He believes that life does not end with death. So locked horns at the High Court, countered his media campaign. Innumerable right to information queries raised against us about our suitability, eligibility to certify brain death. And last year I received a mail which said, from him says, I am assured of hell in here as I do brain death certification. My children too have not been spared. Well, we have been trying to create awareness with training programs. We have been targeting the doctors at the primary health center because they are the first set of people who needs to be convinced about a deceased organ donation program. I got this award after a lot of midnight oil burnt, a lot of sleep lost, and a sulking wife at home because I go out to certify in the middle of the night after my work in Sri Chitra. The good thing is I received a testimonial from the health secretary for all the work. Well, to conclude, brainstem certification is simple and transparent, but be diligent on the certification efforts. But it should be open to medical audit, but should be protected by law from police. Organ transplantation from brain dead donors are game changers, and the most important game people who can do that difference in our country is neurologists, neurosurgeons, and critical care specialists. Thank you very much. Yes.
So just a quick announcement. We'll have sessions up to 1:30, and whatever talks we can accommodate. And because 2 o'clock we'll have a panel discussion because some of the speakers have to go out. So what we'll do is we'll have the panel discussion on deemed death cases because most of the people are here. So a couple of lectures may be missed, and this opt-in and opt-out debate we'll do it later. You guys are here. Thank you. So 1:30 we'll break for lunch then.
Nice talk.
Thank you, sir.
Enjoyed it. Good afternoon, friends. I'm Jogi Patisapu from Orlando, Florida, pediatric neurosurgery. Deepak came to help us with our head injury program when I was in Visakhapatnam. At that time, he asked me to get involved with this effort. I didn't like the 0.01% in India compared to 3740. Plus, I received an award from our transplant program for procuring the most pediatric organs as a neurosurgeon. Either I did something right or wrong, and my interest is still there, my passion is still there, and that's why I think I'm before you. Today, all of this has already been shown to you. There's nothing fancy. With Tom Nakagawa, who is one of the world's experts, we're able to go forward and tell you that the need of the hour is here. There are very few new things to be told. The guidelines written in 2011 by our dear friend Tom Nakagawa, who's the lead author in this, and this is still the standing, and there's still some talk about moving forward. Anybody can pull this article and see what needs to be done. For pediatrics, nothing special than adults. From America, some of the things we see apply, maybe not many, but you do everything else like we're trying to do, fast cars, big hotels, big houses. You know what, I think we can do more, especially for children, because they demand more. That 1 or 2 hours we spend, be it 10 o'clock at night or 4 o'clock in the morning or 2 o'clock in the afternoon, makes all the difference to the family. They will remember you and us and the effort we put into the family. We give them that gift. And by the way, we owe them that gift. For the neurosurgeon who spoke earlier, he said we don't know when to declare brain death because we're so used to training. My friends, we do know when to stop. When we cannot operate any further and we stop because of the bleeding, we control the bleeding and get out safely. So we know when to stop. That can be used here as well. And if you're prepared and you discuss with the team, you can go forward. That's my humble request. Many points were already alluded to by Tom, and I was going to mention that because he's already there and he's a leading author, there's not much I can add. A few points I will mention. The well-prepared team is important. Glad to see India is trying to develop pockets of expertise. Very impressed with the Chandigarh, the Tamil Nadu program. Deepak, congratulations, you're doing well. You all know some of these things. We do the cerebral blood flow studies. That's our gold standards. We do not use CT angiograms in children. I don't believe in them. I don't think they're good enough, especially the younger children. It's not only our radiologists will not certify, therefore it's difficult. Our neurologists are fairly comfortable with the criteria for EEGs. Hypothermia I'll mention in just a minute. Some of the things is most important for the basic understanding. Anything treatable, let's find it. Is what I'm seeing in front of me matches what I'm looking for. We cannot have a normal imaging for brain death. I'm sorry, it doesn't exist. It cannot be. The difference between cortical and complete brain death, in the U.S. we go for the complete. I think you all follow the UK model with the brainstem. You know that. Friends, a few things you should know about. There are things that you can prevent. There's some things that we need to take time. With children, more time, more assessments, more hand-holding, and more tears. If you cannot cry, maybe we're not the right person. In pediatrics, we bounce our babies on our laps, we hug them, we kiss them, and we cry with the parents. And the more we do, and I've seen Deepa cry, and yes, it does work, unless you feel the pain. Quote unquote, Mother Teresa. I had the luxury of meeting her when I was in medical school. She came to America. She was not a Mother Teresa then, but in her book, she states, real love hurts. If it's love, it will hurt. So it's okay to let yourself be hurt. A couple of fine points you should know. Take time to let the drugs for coma analysis, unless you're going to do a CBF study or something, where it may not matter. High C-spine injuries, your apnea tests obviously are going to be difficult. There are a few other things that are going to be messed up. I know in India you don't use too many arterial readings, etc., but blood pressure is important. A few seconds, think, friends, think. The baby that takes the first breath, how much physiological changes occur in that one breath? From the mother circulation to the lungs to the circulation. That changes you cannot quickly reassess within a 1 week, 2 week, 3 week old baby. Those physiological changes, we just don't know them. We don't know them. Main thing here, observation, especially in the neonates. I find it very difficult to do a brain death assessment in a baby that's barely a month old, 2 months old. Even up to 4 to 6, it takes a lot of work. Somehow for 1 to 2 years, we have a little more comfortable, and when they get to be 4 to 6, 8, 10, we know the situation. It works well. Get consultations. We have WhatsApps, we have video, we have this. We have friends that may or may not sign, but at least they can give you a warm shoulder, and they can lean on, and you can say, look, I may call Anna and say, Anna, what do you think? From Italy, and they may get friends. We heard a few minutes ago how friends do help from each other's states or whatever. We don't know all the difficulties. There is no CPP for neonates. We don't know what the cerebral perfusion pressure is. We cannot rely on it. A sad case from UK a couple of years ago. I don't know how many of you know this case. If you do, just raise your hand and I'll stop. Sad kid, 12 years old, found he's a wrestler, active, maybe depressed, we're not sure, found in some kind of a strangling issue. Brainstem injury. 2-3 days later, doctors in UK said, yes, certifiable brain death. The family said no. They waited and waited. That video I couldn't show, but the child had extremely strong grasp reflex. The mother's knuckles were white, and she would shake her hand. 45-second video on the news, which is why I couldn't put it down. That reflex prevented the family saying, he wants to live, he's in there. You cannot take my child. Look at the last line in yellow, my friends. The injury was on April 7th. After the Supreme Court of UK finally said, okay, 7 or 8 appeals later, August 6th. Subsequently, they wanted the European High Court, and the European High Court Commission said, no, we're not going to get involved. That's how long the child waited to be declared brain dead officially. We do have problems, especially when you involve the media. If you don't understand reflexes, as the previous speakers mentioned, the Lazarus reflex, etc., we have to know this and pre-warn the families. Just pre-warn them. That communication is important. There was a hypothermia trial for cool kids I participated in. We don't do it as well. Rewarming is very important. Some of these features don't matter, but normothermia has to be maintained if you're going to declare brain death. Let's not forget it. We have data from cardiac literature when they put them on bypasses and cooled them that the EEG is abnormal for a while. We should learn from that experience. Maybe we cannot rely on brain death exam after hypothermia as much. There are books, there are ways to do ancillary testing. In America, we do use EEGs. We're comfortable if you do a 6-hour, 12-hour later EEG, but we rely on the cerebral blood flow, and even that is somewhat difficult. I don't see a pointer, but even the radiologists and the nuclear physicists have difficulty calling that a positive. You see the scalp lit up beautifully and the brain is not. And I'm comfortable, but they have to be extremely comfortable counting those dots. And at 2 o'clock at night, 4 o'clock, where you're waiting for transplant, they may not clear it, so you have to repeat that test in a day, 24 hours later. Everybody has spoken. Be transparent. Cannot say it anymore. Document, document, document. Please, if you don't document, it didn't exist, and we're all fools for not doing it right. No way, I could be a doctor, but you're a damn fool if you didn't document. Because you're going to hurt somebody, institution, program, most importantly, the family with your confusion. Please, let's just document. It's not that hard. And then it gets rid of most of our troubles. We need to be transparent friends. The little interesting thing, this doesn't happen in children. We see it more. I refer you to this book and a movie, very well done. Here's a true story of, I think, the Vogue magazine editor, brainstem bleed as he was driving his fancy sports car. And he barely was able to blink. And with the number of his blinks, his caretaker understood, and he wrote this book. This is his book by blinking. His assistant, who later became his quote-unquote partner, was able to, he was otherwise completely locked in. And nothing to do but wrote a book with blinking of his eyes. Nothing like this and similar in pediatrics. But adults may hear this, and this often gets quoted up there because of these issues. These things we all know. Over-reliance on ancillary tests is a danger. Time, working together as a team, being patient, and documenting. The protocols are there. We know what to do. Let's just go out and do it. But many people have done it. Nice congratulations to Anna and Deepak. We got involved because Tom and I are involved in those 2 chapters, and this is all there. For the most part, my friends, it's a process. Just like we learn how to do an operation or manage a patient or do a dissection or do anything we do, we can do this process. And there are about 8 steps in the process that were mentioned earlier by excellent speakers. Thank you for letting me learn from it. Namaste and Jai Hind.
You can finish it off. So the topic is medical legal issues post retrieval. I'll be starting my presentation with a case, which is basically one great learning experience for all of us. This was basically a real case where one of the family donated organs from a 40-year-old male who was declared brain dead at a tertiary care hospital. Now after 2 years we received a notice from Registrar of High Court with a copy of complaint written by the spouse of the deceased alleging illegal removal of the organ and commercial dealings. So this basically case highlights that problems are not over immediately after retrieval. It can come back anytime. Me and Dr. Sushma are part of authorization committee. A single case which goes wrong will dig out the entire file related to any case. So any case can go wrong at any stage. Fortunately, with the help of Dr. Agarwal, we could successfully defend the case. And this case also highlights the importance of documentation. This documentation is very important for any retrieval which is happening, whether it is brainstem death, whether it is consent. So things has to be very well taken care of as far as documentation is concerned. Second, which I wanted to highlight before I hand over the mic to Dr. Anil, a humanitarian and respectful dealing of the mortal remains, which we have again encountered recently. Most of the time when surgeons are coming for retrieval, they basically think that it is only retrieval which is their responsibility. But at the end, when everybody is moving out with organs in a rush to transplant it to the recipient, they leave everything in a mess in operation theatre itself, and that is something which is of concern. It is something somebody has given, and then in the last we are not paying any respect to the mortal remains of the same. So we have to take care of that particular part based on our experience that somebody who has donated organs and tissues and given life to so many people, their mortal remains are to be respected. So with these two important things, certain things I will skip.
Documentation, again, we have to keep everything in our record, whether it is consent, brainstem, the certification, NOC from the police, autopsy report, and allocation of the organs is also important. Where you have given the organ, which organization has used it, and in which patient it has been used. So that at any stage of medical legal complications subsequently, you can defend your case appropriately. And another thing which we have learned from past, from Tamil Nadu itself, that autopsy is one of the concern. And in past, when we had a program almost 10 years back, Dr. Anil was also part in auditorium where a lot of experts were there. One of the speaker made a presentation that some of the doctor who has conducted the autopsy mentioned that organs are missing without realizing that it has been donated. And then he also mentioned the organs are missing, register FIR. So things has to be appropriately taken care of as far as medical legal practices are concerned. Documentation is again important, and then that's why we have changes in the law that now forensic experts are also on the board as far as medical legal cases are concerned. Autopsy remains the issue. Nowadays we have practice to do it in OT itself. We are now having circular from Government of India that it should be done in night hours as well, particularly in cases of organ donation. We have now more techniques available. Our forensic expert can be present at the time of retrieval, and the rest of the formalities regarding head can be taken care of by virtual autopsy, by doing CT scan, and we also have option of getting the postmortem waived off by the concerned authority. So things have been eased out, but yes, autopsy report must mention specifically that these have been donated under which law, and all documents are available in police records as well. A body is to be handed over, again dignified manner, humanitarian sensitive approach is required. What we have seen in video, I think that was remarkable, that due respect is to be shown to the mortal remains. We also do the same. We also provide ambulance support to the family to whatever possible extent it is possible. And again, we have to give thanks to the family by writing a letter subsequently and remain in touch with them for any sort of the support which is required. So these are something which are important, and again, addressing complaints subsequently, this is important. Complaints are regarding inappropriate allocations, retrieval without consent, what we have seen, because these concerns at times is given by one family member, and they may not be having discussion with other family members. So subsequently problems may come. Sometimes we also receive complaint that in hospital, when somebody was declared brain dead, there was undue pressure on the family to give consent for donation as well. And that we have to take care of. That's why appropriate documentation is the savior. Respecting the choices and wishes of the family is important. Documentation is also important. NOC from the police, involvement of forensic expert, and again, most importantly, records of allocation, so that we can take care of any medical legal complications subsequently. Thank you very much.
Thank you, Dr. Sanjeev. Just a small clarification I need from your donors who belong to SAARC nations. So is there any clarification on that?
Like as far as foreign nationals are concerned, we basically don't touch in medical legal situations. But yes, with the involvement of embassy, we can proceed further. Yes.
Very quickly, I want to make a comment. In allocation of organs, when there is a donation in a private hospital, one organ, yes, Anil Kumar is changing his slides. One organ going to a government hospital is very good, because that way is all diffused when there is a commercial. So when there is a donation in private hospital, one organ coming to a government hospital is always good.
Yes, allocation is, that's why it's safe.
Absolutely. And you know, we have also had situation where we've taken out the spleen for cross-match and so on, you know. And we had mentioned everything, but the forensic guy said spleen missing. So you have to really document well when you send your report to the forensic people. Thank you.
Dr. Anil Kumar, yes.
I can mention about this very important issue which has been highlighted by you. UK practice is that we would phone at the slightest doubt when there is something funny there, phone the coroner. Coroner would say, doctor, whatever are the findings, you write it and we'll believe it. And if there's any remote possibility of, let's say, just some poisoning, then they'll send their colleague there for collecting the viscera material or not. But I've never seen that being required. But just writing whatever we write in the notes, they will take it as an autopsy finding. Yeah.
Maybe you can speak.
I'll just want to show one small video before why was there a need of this law. This is a case
which had come to us at appeal level. So this is a case of a lady, I think I can't hear the voice sound. She is 72-year-old. The family is Indian origin family based in Dubai. One of the son is a renowned doctor in Dubai, and this lady is 72-year-old and she needs a liver transplant, and she नहीं आ रही आवाज, so साउंड नहीं आ रही इसमें मेरे ख्याल से.
कितनी उम्र हो गई आपकी? 66 ईयर. कब से हुआ है? हम तो हमारा गोल्ड ब्लडर का ऑपरेशन हुआ था. अच्छा. आज से 16 साल पहले. अच्छा. तो उसमें रिलीज किया.
I'm just saying this is the interview of by the authorization committee of the recipient. This is the interview of the recipient. So now I just want to highlight this is the donor they presented. This is the donor, 19-year-old. Check.
सर चावल को छोड़ के सब दाल चना मटर सब होते हैं.
अब इनका जो रिलेशन था वो मैं
हमारे दादा नहीं सर, पापा के जो हमारे पापा हैं उनके जो हमारे दादा के सर पापा की बचपन में मैंने पापा के 7 या 6 साल के उनकी डेथ हो गई.
I'll just explain. हाँ.
जो हमारे दल्लू दादा सखावत खान दादा जिन्होंने पाला हम लोगों को, वो उनके दोस्त हैं. हमारे जो फादर के चाचा उन्होंने हमारे पापा लोगों को पाला, अपने पढ़ाया लिखाया उन लोगों ने कट उनके फ्रेंड को हमारे सर.
ये कह रहे हैं कि जो फादर के चाचा है, द अंकल ऑफ द फादर, we can just close it, है ना मेरे ख्याल से.
सर तो हम लोग पूरा कंबाइंड फैमिली है ना सर, हम लोग पूरा एक ही फैमिली में हमारे पापा को नहीं पाला.
Yeah, he is trying to I'm just projecting ki how the people they try to exploit and the poor people, and there is this 19-year-old person, he had no relationship with this lady, and just because the family is very rich, based in Dubai, one of the son is a renowned doctor, they brought this 19-year-old and the relationship that even this person was trying to explain कि जो मेरे the uncle of my father's friend, his father's uncle's friend is the husband of this lady, and they were living in their area for some time long back, and that's why they had there was a friendship. Now he wants to donate, and his father was also very vehemently agreeing कि we have no objection, we want to help others. So this is how, because this person was promised something, a job in Dubai by the family, you will be given a job. So this case was rejected at the appeal level. So to tackle such cases, actually this has dropped. This law was brought in. So I'll just highlight that because most of the things you are aware, brainstem death, etc. There is a provision of payment under the law, that payment cannot be made for organ donation, but payments can be made for certain things. Payment can be made for cost of removing, transporting or preserving the organ, or for any expenses or loss of earnings which is incurred by a person so far as reasonably and directly attributable to his supplying any human organ from his body. So for loss of earnings you can pay to the donor, and who can pay for the cost of maintenance. So this loss it may be borne by the recipient or the institution or the government or an NGO also, or a society, and it may be decided by the respective state government or union administration. So this I'm just skipping because most of you are aware,
Under our law, we have an appropriate authority. At a state level, we have a state level appropriate authority. At the central level, we have DGHS is the appropriate authority for union territories except Delhi. So appropriate authority has all the powers of this act, granting licenses, doing inspections. It has got the power of a civil court. They can summon, they can issue notices to these hospitals. They can suspend and cancel licenses of these hospitals for any illegal activities. So these powers of civil courts are, they cannot order arrest, but they have powers of all other powers of the civil court. Then we have a provision of an authorization committee, which is a 7-member body that is to approve 3 types of cases. So one is the other than near relative cases where the person is not a near relative as defined in the law. The swap cases and near relative cases also where any foreigner is involved. So these 3 cases they have to be approved. Then under the law we have, I'll just skip these slides. So this is the organizational framework which is there. There is a role of central government which is defined, as we know that health is a state subject. Main role of the central government is defining the rules, policies and guidelines and establish a network, national as well as regional and state network, which is defined the responsibility which is given in the amendment to the law in 2011, and maintain a national registry. So these are the, and also as I told you, DGHS is the appropriate authority for all union territories except Delhi. Then institutional mechanism under this, with the central government we have DGHS, we have the networking organizations and a registry which is also we consider as a institutional mechanism. At the state level we have every state has a appropriate authority which is basically an officer who is authorized, and a state registry, and they have a SOTO level at the state. Then institutions which are working in this state health department, SOTO, various hospitals and tissues. So this is basically how the framework works. We have roughly more than 700 hospitals which are part of this network, 19 states where the SOTOs have been established, and 20th is in pipeline. So we will have now at 26 states because NOTO and ROTOs are also SOTOs for their respective states. So we will have 26 SOTOs, 25 are still there, and then patient registration is done at the hospital level. Patient registration cannot be done by, it is to be done by the particular hospital where the transplant is going to happen. That hospital will provide the data. They have been given the user ID and passwords. That data will be come to the NOTO registry, and NOTO issues a unique ID for every recipient. So that unique ID is valid all over the country, and patient has an option to change the hospital, but the ID will remain the same, which indicates its seniority as per the criteria which are there. Then whenever a donor is available in a particular donor hospital, the information has to go to the respective SOTO. So SOTO, the information will go, and the SOTO then allocates the organs first within the hospital, then within the state. If not utilized, then goes to the regional list, and then national list, then person of Indian origin, and then we also give it to the foreigner if not utilized anywhere in the country. So that is the system that we are working with. So registry has got 4 parts. Basically there is a transplant registry, which is a registry including right from the patient waiting list, then transplant details, follow-up and outcome registry. So 4 components of the transplant registry. Then we have organ donor registry, which is living as well as deceased donor registry, then tissue registry and pledge registry. So these are the pledge form which you all know. There are certain duties which are assigned to the doctor, which we all should know. Doctor has to inform, like whenever there is a potential donor, they have to find out whether there is this donor had any time pledged for organ donation or not. If not, then they have to request for organ donation, and also has to ensure that no removal of organ is done unless brainstem death has been certified and signed. Then another is that consent has been given by the family in the consent form. So who can give consent? Any person who is authorized by law to be in the legal possession of the body can give consent. So that is there. So near relative, the closest relative, this recently to facilitate the organ donation, ministry had issued just 1 minute, I'll finish. Then post-mortem for organ donation should be taken on priority and be conducted even after sunset if adequate infrastructure is available. We have provision of removing in the unclaimed body also after 48 hours, but this is usually has not been used. Then another recent guidelines have come from Supreme Court on 24th January, where they have given the guidelines for withdrawal of the life support also. We hope to apply them for the withdrawal of life support in cases of organ donation also, but the guidelines are little quite cumbersome, that we have a primary board and a secondary board. So then we are working on a one nation, one policy. We have now asked the state governments to remove the condition of domicile requirement, and any patient should go to any state of the country and register themselves for organ donation. And then earlier we had a cap of 65 years of age for registering the recipient. Now that cap has been removed in the NOTO guideline, and states have also been asked to not charge for any fee for registration. So now every state has been asked not to charge for any fee for registration of potential recipients. Then these are the three indicators that we want every ICU to practice, that as has been like given by the Spanish Society, because this is basically to audit your brainstem death certification. Most of the forms which we send out, those reports which we receive are very poorly, even if no certificate, not even one brain death has been certified, the subsequent steps, they come after brainstem death only. So at least out of the total deaths which are happening in the ICU, at least 5 to 30% of the deaths should be brain death should be there, and they should be certified. Then all these diagnosed brain death donors, they should be monitored very correctly. Then out of the brain deaths, how many donations should be happening? So we can have a like 60%, up to 60% as is in practice in Spain. So thank you. So these are all. So then we can have like during the panel discussion we can take more questions. Thank you.
No, I just want to thank the chairpersons, I mean, for being so patient and conducting the session so well. Just 20 minutes quick break, 2 o'clock we come back sharp, and just grab your food and come back here, and Dr. Sanjay Agarwal will be moderating a very important session. The idea of doing this very focused group, lesser number of people are here, but most of the people are the policy makers for the country and for AIIMS. And we should be able to take some concrete decisions to help in change in the practice. Thank you. Good afternoon, everybody. Post lunch, we begin with a very interesting panel discussion on the deemed death or the brain death cases and what are the intricacies and problems involved. And I will request Dr. Sanjay Agarwal to take over from here and do the needful. It's brain death, panel discussion on brain death, right? Or deemed death is afterwards? Correct, correct, okay.
Let me invite the members of the panel. Dr. Anil Kumar. Dr. Anil Kumar, I don't think anybody needs introduction, please. Many people who may not know, probably he's the senior most and most experienced person who has seen the organ donation grown in India from 2008 or 2009, after we organized World Organ Donation Day in Vigyan Bhavan in 2010. Next, I will invite Dr. Lalwani, please. Dr. Lalwani is also again doesn't need introduction. He is a professor of forensic medicine and involved in the organ donation, all legal aspects within the country, within the institute. And then Dr. Sumanna Arora, if she has come.
Just on the way, and then from Noto, Dr. Archana.
Then Dr. Archana. Dr. Archana is consultant in Noto. I mean, very important organization. Dr. Sumanna, please join the panel. Dr. Sumanna is, if I am correct, is consultant medical in Niti Aayog. Senior consultant. Okay. So what I thought that instead of asking the question which has got a straightforward answer, it's better to have a things which I feel I am not the organ procurement person, I am not the intensivist, I am the nephrologist. So my perception of the issues might be different as compared to the audience. So excuse me for that. So I thought in this way that it's a mixed panel with many of them are in an important position to take the decision, and many people are experienced and seen how the organ transplant has grown in the country. So I also asked Deepak that what he expects questions to be asked. So some of the question is what Deepak has given me. So first I will ask from Dr. Anil, being most experienced person, that Act is since 1994 and National Organ Transplant is from 2010 and we are running in 2023. What you see the main reason that our speed of number of increase in the disease donation in last 3 decades hasn't gone to as much as is expected by the public or the professional? Some key points which you feel is lacking, some of which has improved and some major still needs to be improved.
Thank you, sir, and thanks for the kind introduction. To my understanding, the major roadblock in organ transplantation in our country is the poor certification, poor number of certification of brainstem death in the hospitals. We have patients lying in the ICUs, and nobody bothers to identify whether they are brain dead. They just keep waiting till the cardiac death has happened, and they keep occupying the important resources of the ICU bed. Nobody checks for organ donation, for the brainstem death testing, and they wait till the heart has stopped. So that is the current status, even from the best of the institutions of the central government, because we have been now collecting data from them for in last 3 years how many brainstem deaths have been certified in their ICUs, and we are getting the reports which are like, I don't know how they sign the report, nil, nil, nil. Even not if you have not taken the first step also of certifying the brainstem death, where are you then? How are you going to go to the next step of approaching the family, looking for encouraging for organ donation? So that is the major roadblock at the hospital level. They are not certifying the brainstem death. That is the one big issue that I am facing, because in the private sector also, because they are mostly they are interested in doing the transplants, but very few private hospitals are interested in running donation programs, particularly North India, North and Northeastern. The PGI, hospitals like PGI is an exception, but generally it is the trend that all the new aims like institutions, they are not certifying. Then there is a problem of infrastructure also, especially in the government sector. In a country like Spain, the entire transplants programs are there in government sector, and major work is being done in the rather 90 to 95% of the transplant is in the government sector, which is well controlled. Third roadblock that I see, that our people are not trained to maintain the brain dead donors, because we don't have the kind of critical care courses that we have in the US, Australia or in Spain. Like our anesthetists are doubling up as a critical care specialist, and most of their time is in the OTs. They are by rotation they are posted to the ICUs, and they do not acquire the required skills for maintaining the highest standards of the intensive care practice that is required, like which you will not get before you work in the intensive care setting at least for 5 years as a resident, which most of these US hospitals, the other hospitals, so the infrastructure is a lack, particularly in government hospitals. So these are the major things. I do not consider awareness as the major stumbling block. We have, because I am running about the blood donation program also now, we have around, if we take 70% even as voluntary donors, so 80 lakh people donating blood in this country, so which is 8 million every year. So we have cornea which are coming on their own. So the cornea donation number is also very high. So because the organ donation has to happen in the ICU, so our ICU things have to be like very robust to all these procedures which have to be done within the ICU. So
Dr. Anil, we are in a neurosurgery conference, and you are saying two main stumbling block is a poor certification and poor maintenance of the donor in ICU. While by law every hospital has got a transplant coordinator, and which role of which is one of the role of which is approaching the family or so-called identifying the potential brain stem donor. So from that angle, how you are expecting that this component is going to benefit? I mean, we are now talking of 25 years already gone on this.
Definitely, somehow we need to be because our critical care experts, whether it is neurosurgeon, neurologist, or general physicians who are working as intensivist or anesthetists, if they get involved, they lead the program in the hospital, then we will definitely see a difference. And wherever they have led the program, so difference has been remarkable difference has occurred. So if they can lead the program in a hospital, so they will definitely, it will make a change, it will make a difference.
Another important issue which is being faced is so many times at the time of the complaint from the hospital, the professionals are arrested by the police on the act other than the Transplant Act, while the act clearly says that any professional involved in the transplant, if any complaint is, should be acted on under the THOA Act. But still police take non-THOA Act sections and go for the immediate action. So in spite of this being very common and being reported intermittently in the media and such incident, but still government hasn't taken any concrete step to avoid that the professional should not be acted on sections other than the THOA. Any comment, or you see any change in the position which will help the confidence of the professional in this?
Because if it is related to, if any offence is related to the Transplant Act, organ donation and transplantation, So, though we have a state level appropriate authority, the consent of the state level appropriate authorities is required for filing the case in the court. So, if
Dr. Anil, I
Yeah.
will say stop in the sense that situation doesn't actually arise.
Okay.
So the approach to the appropriate authority by the professional or the hospital is actually at a very later stage. By the time the police is already acted and the action has been taken, and you see how the police system in our country is. Once the action is taken and some section is put on the paper, then even the hospital or professional approach to appropriate authority, that cannot be reversed back. So what you are saying is, I mean, sorry to say, it looks more theoretical, but in reality things are totally different.
So definitely then police has to be sensitized, and some kind of a mechanism for protection of the professionals needs to be created.
So this has to come from the
from the government,
policy
yeah, definitely,
from-
and like for the yeah, it can come from this. Yeah, I agree that it can come from as a policy. We can, if there is a too much of a harassment of professionals, because few incidents have happened, but I think not too many. I think only, I think very.
No, intermittently probably every year or so, at least 2 or 3 or 4 incident of such type does come in various parts of the country, and maybe other professionals who are not affected by this actually put a fear in the mind of so many professionals, both physician and the surgeon, particularly more so on the surgeon, and that tomorrow such type of action, in spite of they being fair, can happen with them also. So you are in a position. Is such thought process hasn't gone into ministry that this is an important issue and should be discussed and sorted out?
Yeah.
Let him answer.
Yeah. Actually, in general, like we have a violence against doctors. That is one on which already, like during the epidemics, ministry has.
Dr. Anil, that is totally
different. Okay.
Totally
So basically, we because these things they happen at the state level, and we believe that the states must have taken some action to protect these professionals. Otherwise, if something is to be required at the central level, then definitely at the NOTO level we can have with discussions and deliberations we can formulate if it is required, then a policy can be framed for this.
Sorry, Dr. Anil, sorry. You are saying if it is required.
Yeah.
So it means you yourself are
basically
not
health
sure
is
that
a
it
state.
required.
Yeah, health is a state subject. Actually, we believe that's because wherever such incidents have happened, they have taken some action, and wherever such arrest had happened, like I think the professional, even the government of that state took some action, but like definitely even one day of arrest is should not be there. So that is
Anil, in the same breath now our honorable minister is saying one nation, one transplant. So then this issue of state health being a state subject,
yes,
at least related
so we'll definitely take up this issue as one of the policy for which we should be framing the policy on. Yeah, I agree.
Coming back to his question about various hospitals are not declaring deaths or brain deaths or whatever you call it. All Indian Institute of Medical Sciences, I think 2015, a notification came from Director AIMS that it is mandatory for the doctors to certify brain death. It is mandatory to explain the prognosis and other things. How many hospitals in our country, I'm talking about public hospitals, actually issue such notice? Why can't it be reinforced on a regular interval? The faculty who join later, they are not even aware of such notification. Unless and until you have somebody sitting on your head saying, no, you have to do it. You are in the ICU. It is a part of your duty to certify deaths. I mean, is there any accountability of the directors of the hospitals all over the country? How many deaths take place in the hospital? You showed me some forms that the forms come negative, nil, 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 nil. But what is the action? Why do you have to have some check on their quality?
Yeah, before he responds.
Kerala government also. Similar to the same effect.
Even
That,
Delhi government has
that,
issued a
brain
notification.
death has to be independent of the need to transport organ donation. All brain deaths have to be notified,
Okay.
diagnosed and notified.
Dr. Ash.
Only 1.5 minutes, sir. I wanted to address that point in the last, but I think since it has been already been alluded to, I should say it first. Health and maybe education,
Should be
precious is subject to be left to the
state,
governments.
yeah.
That is one. But you and me are not going to decide that. Number two, the organ donation bill is fraught with lots of cumbersome. It is so difficult. 1997, I was assistant professor there. I can only laugh at it now. There was this snake bite. Patient from Himachal Pradesh came, young man, agreed, and then we had to have 4 people to take their consent from. And MS locked his house. He locked inside his house. 2 o'clock. I had to jump, and then he was reluctantly agreed to it. And that's it. And Professor Diwan, very nice man, not honorary, he agreed immediately, he didn't take more than a minute. So it was very cumbersome. By the time the consent was there and patient was in theatre, this brain dead donor became DCD and we had to do things in hurry. Fortunately, things remained fine. Those 2 recipients survived. What I'm trying to say is that, as Deepak Gupta says, as there in many countries, we don't need to reinvent the accountability and the authority needs to be linked together. Not just in transplant, but certainly in this we are talking about. All those people who have got the authority, they are not accountable. What is happening to all these donors, potential donors? If the director or the principal or the MS of that hospital is put to sword or is asked, okay, every year you are going to demonstrate to us that you are making decent efforts as per the Human Organ Transfer Act. And then obviously this will get will be transmitted.
So actually it amounts to implementation of the thing which is already there.
Rule needs to be made easier.
No, rules are easy. I mean, rules are there. I have gone to.
You don't need 4 people to sign there. 4 is too much.
Short comment.
Just a short comment to share with you the lesson learned in Italy. In Italy, in 1994, was issued a law that makes mandatory the certification of death in any patient with those conditions, independently from the decision to donate. Following this law, we had a multiplied number of death certification in our country, and consequently, we had also a significant increase in organ donation. But the crucial point is to make mandatory death certification independently from organ donation, because that's the way to speak with the family and make them aware of the fact that their relative is dead, and we are telling that not for the purpose of donation, but because the patient is dead. The family can also decide not to donate, but this doesn't change anything about the death certification.
So, but the mandatory is there in our hospital also, but it does not translate to the actual practice what is happening. You know, so that is why I'm saying every yearly, let us say, it's been.
There are many such issues actually where I have a problem that things are there, but
you are not the law. You are not the national law.
Yes, I wonder if I might just come to that. Kumar Dittal, heart and lung transplant surgeon, and I've been in Italy setting up a program in Sicily many years ago, 2003. What he's described is absolutely right, and you were describing early on about men wanting to donate only their ladies and so on. Exactly the same thing was happening when I was in Sicily. Really low donation rate, and this law has made a huge difference. And I wanted to come back because one thing I'm not hearing this morning is the context in which doctors are meant to be doing the certification of death. The context has to be that this must be mandatory just for end-of-life care. Nothing else. Forget about donation, everything else. But as routine practice in your intensive care units, when you come to these criteria that meet, then you have to mandatorily do it just for end-of-life care.
So then I must praise you that in India, as far as my perception goes, end of life care is practically non-existent. It's a minuscule of the hospitals who are practicing end of life care. So you can't extrapolate things what is happening in other part of the world to India. So end of life care is practically nil.
I'm simply suggesting without bringing that on board to our colleagues and having a mandatory legal framework, we'll never achieve what we want.
I would like to come to Dr. Sumaina because she is from an institution from where we expect significant changes. Dr. Sumaina, I understand that Niti Aayog, correct me if I am wrong, Niti Aayog some time back was not involved in organ transplantation. It is for last few months or maybe year and a half, Niti Aayog is getting involved in the organ transplantation. Share with us what is the thought process in the Niti Aayog and which area of organ transplant this organization as such highest government body is planning or actively doing.
Thank you for your question and thank you for having me. Good afternoon. It's for the last 8 months that Niti Aayog has started looking at National Organ Transplant Program. A few things that we are currently working in partnership with the Ministry, in partnership with the board. First and foremost, like I've heard your brainstem death declaration is not happening. So we are nudging the Ministry to see how best we can do it. The question that came up then was that what if after brainstem death certification the family declines donation? Then what do the doctors do? So there was a concern around that and we requested that we work on that. Withdrawal of life support post brainstem death declaration. Another thing that came to notice was that of course it's very important to utilize deceased organs locally. However, in case there's not a suitable recipient in the same city for whatever reason, for lack of infrastructure, for lack of blood group matching, etc., then the organ needs to be transported either to another hospital within the same city or to another city. Now, as of today, this happens in a very ad hoc manner and it's a very time-sensitive activity and there's multiple agencies involved. So, of course, in partnership with the ministry, we called for an inter-ministerial meeting of 7 ministries, right from MOCA, Ministry of Civil Aviation, to Railways, to Ports and Shipping, to Road Transport, in an effort to look at streamlining intra-city and intercity organ transport. So that is another thing we are looking at, just to give you a flavor of what's happening. Thank you.
Can you highlight that in this thing, at what stage Niti Aayog is and what is the, say, potential timeline of these major, because these are very major activities.
Yes. And I heard somebody say earlier that health is a state subject, and India, unlike Italy or unlike certain states in Europe or maybe Singapore, is a very vast country. And in fact, it's multiple countries in one. So to move things takes time, but we are definitely at it. And Dr. Anil will tell you that we've been bothering them quite a lot, but we are at it and hopefully you will see effect on the ground soon.
May I just make a very short comment? I found a little contradiction in your word. In that sense, you said that the question is, once death is certificated with cerebral criteria, what can we do if the family denies consent? That's not a problem. Because no, because if death is certificated, that means that that patient has death.
So let me give you a little bit of context. In the Indian definition of death, in the Births and Deaths Registration Act, brain death is not mentioned. So that was another thing that we are looking at. So it's not that
Yes,
simple.
but
So we need to amend that definition. of
yes,
death.
you have to set up a
Then
new
we
rule,
know-
a new law.
Yeah,
Yeah.
exactly. So I hope that clarifies.
With the same context, can I ask Dr. Anil, you showed a slide where there is a High Court judgment that the Supreme Court judgment that the life support can be taken off in certain condition. Is that acceptable, or sorry to say acceptable? Is this accepted now?
Yeah, it is.
Yeah. Yeah. I'll just stop it. One is regarding this registration of birth and death act definition. We have given to the Ministry of Home Affairs for changing the definition in the registration of birth and death act, so that brainstem death is also included for registration purpose. So that the new definition and the letter from the ministry side has gone to the Ministry of Home Affairs to do it. So like they will be putting up the bill in the parliament, so whenever it comes up, so it will be, we hope that it will be done. Then second is the Supreme Court.
That the brain death situation, then the person will be accepted as a death and the life support can be taken off.
Yeah, because that he can be issued a death certificate on the basis of the brainstem death basically, and his death can be registered. Then second part is the withdrawal of life support guidelines, which has come from the Honorable Supreme Court. This judgment has come on 24th January. It was a constitutional bench of 5 judges led by Mr. K. Joseph. So this judgment has gone, basically this was withdrawal of life support in the end of life care situation. So it is not specifically for brainstem death situation. Where they say that whenever a physician informs that it is futile to continue treatment in this particular patient, then this patient and the treatment should be stopped. He advises stoppage of the treatment. Then a primary board is constituted by the hospital. The hospital where the physician, the treating physician informs the hospital. Hospital will constitute a primary board, including that physician and 2 more experts, and they will examine the case, and then they will discuss the case with the relative of the patient as well as with the any physician of the known physician of the patient. They will discuss it with, and then they will decide that the withdrawal can be done or not. After this, a secondary board also will be constituted, in which a district CMO representative is included, and 2 other physicians which are not part of the primary board. They will examine the case, and then they will endorse or reject the decision taken by the primary board. So whether they can withdraw the life support or not. So after the withdrawal of life support, the patient will be like, and this is also linked to the advance directive if it was there, or advance directive it was not there, and they can then transfer the patient to the end of life care type of a treatment, or because once you are withdrawing the support, at least the end of life care support has to be given till the patient is surviving. And because in these situations where the person is brain dead, he is already dead, and so they are taking use of these 2 boards, we can withdraw support. But I think for a brain dead situation, we would like the quick withdrawal, not going through these 2 boards as the Supreme Court has laid down. But this judgment has come and it is valid. So it is
I think that they are 2 very different situations, because on one side you have a problem of end of life, so withdrawing, futile treatment and so on. In the second set, you have certificated death, because brain death is death. So in that case, you cannot even speak of life-sustaining treatment, because there's no life. So under a legal point of view, if you have a mandatory law to certificate brain death, and brain death is death,
so hopefully after that,
there is no possibility to go elsewhere with that patient.
Yes, absolutely, but that's not the case in India as of today. So once it is, then this question will not arise.
So that means that brain death certification is unofficial.
No, it is official, but it's not defined as death in the legal context.
it is only defined in the organ donation law. It is not mentioned in the other law where we are doing the
Yeah.
We have 2 laws contradicting each other then.
There is no contradiction as such. The only thing is it is to be elaborated. It is just an omission.
So you can you can understand that the policy or the way the other part of the world professional handle the organ transplant program, many of the things cannot be extrapolated directly in that way to our country. I'm not saying, that is why there are many times the experts from other part of the world were came here for training the people or various other issues. So we should keep the Indian context into mind before accepting the activity or the process the other part of the world is. I will come to from Noto. You see, we started Noto registry somewhere in 2013 or 14. It was first presented in Indian Organ Donation Day in 2015. All data, number of transplant from NCR region. Almost every hospital was directly contacted by me and the data was retrieved, and that is still on the website in the section of the public view. But still, as of 2023, my understanding is still we are completing the data from asking the paper record from the different state of the number of the transplant. Then there is a monthly pro forma and then there is a yearly pro forma. So we still don't have an online entry of the patient from almost most of the hospital across the country. Can you throw some light what is the fact as of today?
Sir, patient registration we can do, it is digitalized and everyone can do from all the hospitals across the country. But yes, filling up the data, that means the transplant data, that how many transplant they have done, was it live or was it disease. For that we are asking a monthly pro forma because we don't have a software or they are not filling up the post follow-up.
No, I must clarify, there is a software is there. So don't, at least for kidney, I am 100% sure that there is a complete software not only of the transplant demography, but the basic detail pre-transplant, operative details, post-transplant follow-up.
That I was about to complete,
and
sir.
that everything is there as far as kidney is concerned.
But only the recipient registration part is filled up by all the hospitals, not the pre and not the post. So it is halfway done.
So it's only basically demography is being filled, which gives idea of gender, age and address and emergency
So that they can
contact
generate the
detail.
recipient ID. That's it. Yeah.
Kind of format in the software where as it enters, everything is updated.
Yes.
No. Yes.
If you enter, it will be updated.
I mean,
But provided you enter.
in a collated form,
Yeah.
For kidney it is already there, sir. But for all other organs we have to.
So that I will come to the related to one nation, one transplant. You see, liver transplant team has already made their own registry and they are having some more than 5,000 patients, including post-transplant follow-up. I understand that Niti Aayog is initiating a new model of registry, or Noto is Niti Aayog helping for new registry as compared to what is the existing registry. Under
So let me clarify
yeah.
that it's not new or old, it is just a nudge to digitize the registry.
No, madam, the registry is already digitized as far as the.
No, that is only not all organs, not in a way that the state data can be also uploaded from the back end. So the only thing we are nudging is that we digitize registries organ-wise, also that the data from the states can be uploaded on this electronic platform. So they are working on that with the authority concerned.
Most of the state who are having registry, as far as I have seen for kidney, has got different columns and different headings, and
so there's no
this is not-
interoperability.
So
There's something called interoperability.
Yeah.
So which is what the tech team is trying to figure out under the guidance of Noto, because two systems have to, when
Talk to
they
each other.
have to talk to each other, they have to be interoperable. When they are not, what is it that they do? So and that is the complex problem also, which is one of the things that they're working on.
I will come to Dr. Lalwani, although he has already highlighted the issues faced by the forensic team. Can you give, with your vast experience, that what major problem you were facing before, which with time has been corrected, which are now easy to handle?
Yeah, one issue was which was discussed in earlier discussions as well regarding the time of death. That whether it is by mean of cardiorespiratory arrest after retrieval, or so we have clarified this through various processes that when we declare the brainstem death, second apnea test or second time of certification, that is considered as time of death. So that is basically considered as far as our practice is concerned, and the same has been followed in other institutes as well. That second apnea test or second certification time is basically the time of death. That is one. Second is still autopsy practices, because most of the potential donor are medical legal cases, and when we contact the police, there are certain issues. Because most of the time police believe that their main role is controlling the law and order situation, not related to this, and many times we have to have some personal approach, personal contact to be used for facilitating organ and tissue donation in brain dead cases. And another issue which we have, that we are also working on training of the police officers on regular basis, but they are getting transferred from one place to another in very short period of time. So you train a group of the people from one area, then again they are getting transferred to other station, new lot is there. And every time there is new person, because it's a huge number of police officers who are posted in one police station. So it is not possible to train everybody at one go. So we keep on getting people for training, we keep on interacting with them, but again because of their frequent transfers, so every time there is new challenge. Somebody may be receptive, somebody may not be receptive as well. We have to go a little bit on higher side. Maybe a SHO we can contact that he can facilitate, and most of the time they may also be having their own confusions and different ideas on the same. We still go a little bit higher to ACP or DCP, or at times beyond that. Somehow we are able to get support as far as the institute is concerned, but yes, this is one of the area which is to be focused upon as far as potential donors which are in medical legal cases, to facilitate the organ and tissue donation, because police NOC is also one of the concern in many situations. So this is some area which is difficult, and third important thing is autopsies. Okay, many times relations want body immediately. Even they may ask, okay, we'll take the body in the morning. Even when we retrieve, we hand over the body, they may think, okay, we'll keep it for some time more, and then some of the relations are to be there before we take the dead body. So sometimes there is this sort of, but we facilitate the things as far as possible. Earliest autopsy as per directions given by ministry as well, that is basically safeguard for everyone, that even you can do it in night hours. So we have technology available in institute, so we need not to open skull, subsequently taking the body into mortuary as well. We can do skull opening within OT, or maybe we can use mobile CT to note down the findings of brain itself without giving any incision. Our residents are also available in sufficient numbers, so we can post them in OT itself, so that they can observe the entire retrieval process. So time is taken care of accordingly. But one of the major concern is still the police. Seeking NOC is definitely a challenging task as of now. Recently, just 5 minutes back, I have just received a call of potential donor. Somebody has agreed as far as trauma center is concerned. So I have just given a message to the police officer. Fortunately, it is within our own police station, which is related to Safdarjung enclave. So it will not be difficult. But in case it is somewhere else in other part of Delhi, it is sometimes it's a challenging task. Somebody may agree, somebody may not agree. Then you have to find your ways to convince them and ask them to come to hospital and talk to the family members.
Yeah, but that only most of the, or say 80 to 90% organ donation is a road traffic accident or medical legal case. And if this is the basic problem of taking NOC, which means that in majority of potential donor, this issue is there.
Yes.
So this needs to be sorted out smoothly at much faster level,
Yes.
because this is seen then
So,
every day you will-
that's why we keep our local police stations sensitive for the same, and they coordinate it. Most of the time they facilitate, but in 5 to 10% of the cases there are issues.
Doctor, he was
In the last 20 years, we've all managed somehow from the police, right? But especially if there's a murder happening in Agra and the patient is shifted to Delhi, even then we managed to donate the organ. But the issue is that there should be a nodal officer in the office of the Commissioner of Police who should be contacted whenever there is something, so that he can take care that we don't have to keep escalating at our own personal levels.
So,
that was one comment. Second was about this time of death. A lot of us, I remember at least 3 families which agreed to donation 5 days after the second apnea test, right? So sometimes it becomes very difficult to fill the paperwork when the date of death is 10th actually, but we've had the donation done on 15th. So again we need to just have a relook at it, because sometimes these difficult situations create a lot of trouble.
Yeah, I agree that this is one issue. But regarding first that police officers should also have some designated nodal officer for this. We have been trying this since last 20 years. And when we talk to the police commissioner, one nodal officer is appointed always that you can contact him. But again, they keep on changing their position again and again subsequently.
Yeah, recently, sir, we got appointed one person as a nodal, and the past 2-3 donations they were helping. So we do have a nodal person in place for Delhi now.
And you have got a nodal person in place in police.
Police.
What rank?
He is DCP. DCP also. Yeah, definitely, sir. Actually, before that lady was there, but then she changed, and now after Holi they have sent a new person name. So we will also again go and meet. But yes, on telephonically he is helping in that.
I
So
mean,
he-
see, the basic issues are being sorted out after so many years or maybe decade after the organ transplant is being. While this is just a so basic issue, so you can understand that still on day-to-day basis, I do not want to comment on experience in All-India shoot because it may not be appropriate. Dr. Sunil.
have a nodal officer in police, high rank. You know, for the last many years, we have less problems with police, especially, for, interstate kind of coordinations, and also within the state. Now, having one person in police who is sensitized to a nodal officer rank or organization really helps as students to process. This problem is there throughout the country. And I think if Nodo and the ministry can give this direction, only the really will be the key. And you've already done it. The whole NOCP is available with Geo. It's very thought through. Look at it.
So, if I could add to that, sir, we at NITI have studied that geo. We've also shared it with the concerned ministry. So hopefully we should see action like we are seeing action in Delhi. So hopefully we should see action in the other states also. And Tamil Nadu, of course, is a fantastic model. And like Sir was mentioning about challenges for doctors, I can tell you from personal experience, I have seen cases where the surgeon is carrying a heart in a box, the flight is to take off in 10 minutes, and he's stopped and not allowed to board in a tier 2 city, and the next flight is 24 hours later. So there are challenges like that, and hopefully, like you said, sir, after such a long time, things are moving. Hopefully, we should be able to nudge them to move a slightly faster.
We are finishing a lot of time. I will just last comment to Dr. Sarana. Last time when we did panel discussion, you make a statement that it is a system which is important and
Absolutely.
not the person. But
Absolutely.
You see, the problem-
Absolutely.
there are so many areas where still system is to be made.
Absolutely. It
Even
has to
as
be
of today
process
also.
dependent, not person dependent. Like sir was mentioning, people get transferred. They are meant to get transferred. It's the position which should kind of take it forward and not the person. Yes.
You have been talking about police that can be part of the problem. Actually, I believe that once the law will be done, police should be on the side of the law usually, so that could be fixed. But the other problem is that traumatic brain injury, car accident where forensic people are involved represents 1/3, if not less, of the people who die because of brain death. So the other 2/3 are cerebral hemorrhage, which does not have anything to do with forensic medicine. So I think that we should not only think about traumatic brain injury because it's not the case.
Actually, in India, most of the donations are...
I know, but it's not true. I know that you started with traumatic brain injury patients, but you are forgetting the other 2/3. I think.
One comment, Dr. Sumana Arora. Just a request that since we know about public education is the most crucial part, not just investment in next 5 years, we are talking about many decades. Why it should not be very difficult for Niti Aayog to really liaise with education department to introduce science and ethics, its discussion at high school level.
So if I may, and Dr. Anil will be able to give you more details, they are including organ donation in the school syllabus shortly.
Check.
I think that in the United States, this is the role that the general pediatrician plays, because children have annual checkups, or should have annual checkups, just like we should. But each year that goes by, parents and children are reminded of anticipatory guidance. So, for instance, if you're 2 and 3 months old, you're reminded that you sleep on your back, not on your stomach, because of the risk of sudden infant death syndrome. As you get older, you're worried about submersion injuries, so you talk about wearing life jackets when you're around the pool, and as you're an adolescent, you're learning about sexuality, you're learning about tobacco, you're learning about alcohol, and you're learning about getting a driver's license. And in the United States, that's when you make a determination if you want to be a donor. Now, you can donate any time after that, but as you apply for your driver's license, you make a determination at that time. Do you want to be a donor? Do you not want to be a donor? And it's going to either be on your driver's license as a little heart or it's not. So I think that it goes beyond what we're seeing in the schools. I think that we as physicians, you as specialists, when you're seeing children, have an obligation to sit and talk with families about anticipatory guidance. And as pediatricians, that's part of our job. So I would encourage you to talk with your local pediatric groups, because I think that this is another way to disseminate that information. And I will tell you that when you bring that subject up and the child comes home and begins to talk about it, it opens up a discussion at the dinner table. Because there's no parent that's going to sit at the dinner table and ask their child if they want to be an organ donor. If they are, hopefully the kid's smart enough to ask, maybe you know something that I don't know, right? So.
Thank you, distinguished panelists, and Dr. Sanjay Agarwal for sparing your valuable time to come for this important discussion. Hopefully, we will reach to a stage now when we cross the first stage, that is the mandatory declaration of brain death in each and every hospital of the country. We have to take baby steps, and then only we can go further. I mean, That's why we say dera hai durust hai. Probably we could not take right decisions at those times, but now we are geared up. Everybody has joined hands together, and we got a group of experts here sharing their experience. And I hope we will see some better numbers. And my vision is to cross a magical figure of 1,000 in 2023. Let's see. Thank you so much. Thank you so much, everybody. Special thanks to Dr. Sumna Arora for coming all the way and spending your valuable time. Thank you so much. There is a slight change in the schedule because two of our faculties they have to catch their flight. I will begin this session just the lectures first. The workshop part will do later. Discussion will do later on the donation after circulating death. So first of all, I'll call upon Dr. Sunil Shroff. He will be talking about the Maastricht criteria for DCD and donations after cardiac death. May I request Dr. Ajay Sharma and Dr. R. Raghavendran to chair the session. Panel, if you want, I mean, no, at least we could, because you have to take a flight, so this thing we can start with. Are you comfortable to short lectures and then start this? Bring Dr. Abhishek. I don't think. Dr. Arkemani, maybe you could just start moderating the session then, like a panel discussion we had just now, and then you could ask the questions, hand over the stage to you. And Dr. Sunil Shroff, I think would come over. Thank you. We have it in the panel discussion format. Amish, please come. Who else are there? Dr. Kumud is there. Not from the panel. He's joining. I hope, this very delighted to be here and see so many neurosurgeons supporting this novel cause. And I hope this meeting will be a game changer for them. It's never been possible in the past that so it's never been possible in the past to have not working. Is working? I was saying that I hope that this meeting will be a game changer for our country. I've never seen so many neurosurgeons supporting this noble cause. I'm very grateful to many of you who are here and who have talked so passionately about this cause. We've had many presentations and so on, and I think DCD is a subject which is not new. And most of you are senior clinicians, so I don't want to go through the slides and bore you with that. The idea of having a DCD, of course, as you know, is that it's a step forward, and the critical donation pathway, whether it's DBD or DCD, we should not really differentiate as such. When a family wants to donate, whether it's going to be a DBD or DCD, that pathway should go forward. And the Transplantation of Human Organ Act itself provides for DCD in India. In two places, it has the clause for DCD. One is the death definition itself, there's a very clear cut by brain death or cardiopulmonary death. So a couple of places, the law itself allows you to do that. But what we don't have is the rules. And the rules need to be created. And for rules, we don't have to amend the law. That's the best thing. So if we can create the rules, Dr. Anil Kumar, I don't know whether he's gone or here, he can help us. And about 2 years back, we started writing some kind of a position paper with help of 8 societies which are involved in, declaration of death. The neurologists, the Neurocritical Society, the Indian Society of Transplantation, and Pediatric Society and so on, the Intensive Care Society. We all sat together, and it took us 1 year to come up with some kind of a position paper as a starting point. I'm not saying that it's a perfect paper, and Dr. Abhish Seth, who is here,
helped us in initiating that, and Dr. Ravi Mohanka, he wrote a lot of it as well, and Dr. R.K. Bani was part of it. And Dr. R.K. Bani has been involved with end-of-life care in our country, and he has been looking at the various aspects of end-of-life care, withdrawal of care, and it is due to his efforts and his group's effort of end-of-life. They have a group called EOLC, End-of-Life Care, a small group, and we have a law firm in, which Vidhi law firm, and there is Dhani Mehta who has been helping us in taking this forward. So one thing which I want to say is that DCD can definitely improve the donation rate in our country. And many families in India are more comfortable with natural death and donation, as it is happening with eye donation. So I think DCD will be acceptable to the common public more easily. So I think we should start thinking of how to put rules together. Having said that, we also should, I would like to say that PGI Chandigarh has already done about 20 odd DCD donations. IKRDC also has done donations. So it's already happening in small pockets in our country. So I think it's time that we put a rules together, a framework. Not every institution will want to do DCD. Some institutions would want to go forward with it. So for that reason alone, we should put the guidelines together. And I think, as I said, if you want to present some things which you have brought, Dr. Seth, then, do it. But I think if you keep it brief, we could have better panel discussion since, we have, a crowd which is thinning very fast. Yeah. Yeah.
What I can do is I'll just project 2 slides which can just help in initiating the. Can just present first. Thank you. Yeah. Thank you. So. This is the position paper which everyone can access. It's available on 2 journals published simultaneously, and these are the 9 societies that we took about a year and a half to put this act together. And basically these are the 2 that we want to focus on in our country, especially DCD3, and this is where I think Dr. Mani's work has been exceptional, and now we have the new Supreme Court rule. So this is what we hope to do now, that we somehow establish futility of care. It will take some time for our people to get used to that. We can discuss that, how we do that. So Dr. Shroff, one point could be how to establish futility of care. Number 2, how to withdraw support. Dr. Mani can tell us in our current scenario how we are supposed to do it, and whether we need to change anything. And also we'll need a lot of training in how to start the organ preservation, etc., etc. So starting from the first step downwards. And Dr. Mani, you could use this. This is actually borrowed from your slide. Why don't you just step in here, because you may not have time to see your.
No, I have a couple of
You
slides.
may not have time for that. Just present on this. This is exactly what you presented.
All right. So.
No, I'm okay.
So the first step is as everybody's agreed on, we must use end-of-life care principles that we have approached futility or inappropriateness of treatment. Then you focus on foregoing of life, appropriate foregoing of life support, and that you de-link from the decision to donate organs. Obviously, that's what you pointed out. So that's the first step. So consider the futility of treatment, WLST, once that is agreed upon through conversation. The intervention is conversations with the family, and when that is established, then you can broach the subject through another party, like a coordinator. Coordinator steps in and talks to the family about the option of organ donation. Now I will actually, okay, you got this everything, and even the legal side here. Now, Supreme Court judgment, where do we come in? See, the Indian Society of Critical Care Medicine and Indian Association of Palliative Care already have the ethical position statement for end-of-life care decisions, foregoing of life support decisions.
withdrawal, withholding, DNAR and all that. And the ICMR has also stepped in and given us a guideline on DNAR. So we have a statutory body already given us a guideline. AIMS also has an institutional, policy on foregoing of life support. But everybody had a doubt as to what is the legal position. So we worked on the legal position since 2010. See, there was this intervention by the ISCCM on the common cause versus the Union of India. What is that case about? That the Indian citizen has a right to execute an advance will and has a right to refuse treatment. Okay. Now, it came out for hearing in 2018. So constitutionally it's valid to refuse treatment and for withdrawal, withholding, and to execute a valid advance will directive. But we gained in principle, we lost in procedure, because the Supreme Court gave us a very complicated 3-tier process involving the bureaucracy and the magistrate. So that was untenable, unworkable. So we appealed again for clarification, simplification. That was by the ISCCM, represented by me. I appealed to the court to simplify this procedure. That was accepted, and in 2023 January, the procedure was simplified. It's no longer a complicated process of 3 tiers involving, and without specifying the time frame, right, involving the bureaucracy and the magistrate, does not involve either of them anymore. So the first step is a primary medical board involving the treating physician and 2 subject experts of at least 5 years experience. So anybody with a consultant rank can participate. Then once there is consensus within this group, they take it to the family, engage them in a conversation. Then we want to take an end-of-life option, foregoing of life support option. Then a secondary medical board is also constituted by the hospital. We don't have to go outside. The crucial point is there has to be an empaneled doctor from the chief medical officer of the district. Now, empaneled doctor, it doesn't have to be from outside the hospital. Doctor can be empaneled within the hospital as well, as we have for a brain death committee, as we have for an organ transplant committee. You can have empaneled doctors along with 2 other subject experts outside of that first panel. So this is very doable. And all this has to be concluded in 48 hours. Okay, the Supreme Court has given us a time frame. If they are not able to come back within 48 hours, they are supposed to, then you can go ahead, all right, with whatever you've thought about. Then we go ahead with the withdrawal decision. Yeah.
So within 48 hours, the board doesn't meet or something.
Yeah, you can go ahead.
So you don't have to necessarily wait for the board.
Exactly, because 48 hours is the time frame. Within 48 hours, it can be within a few hours or up to 48 hours. So that has been specified by the court because we have clarified the time sensitivity in this whole process. So that has been accepted, that we need to have this expeditiously taken this. And what we need to do is to just inform the magistrate, all right, as we do with an MLC. No, not tricky, because it's only intimation. It is not waiting for decision. So this is not involving the magistrate for decision, it is only as a custodian of this information. Right, it's not an NOC. So these are the ways in which it has got simplified. So I would say it's simplified maybe 75%. Ideally we should have only 1 step. Okay, that's what we had appealed for. But there was a problem from the Ministry of Health. Ministry of Health wanted a second oversight. Yeah.
You say convey, that means that at least the magistrate should have a documentation that he received it and read it.
No, not necessary. You just send it to his office, an email.
From the past experience, from whatever we've gone through, the reason why I'm asking this question at this stage, that the meaning conveyed obviously is, the meaning conveyed is just informed them.
Yes.
Whether he received it or not, it doesn't matter.
This was clarified in court by the judges, that you need to only intimate. This question was gone into. He said you need to intimate. And nowadays it's very easy. Digitally you just send the information, there is no registered letter, all those sort of things like the past. So Intimation is as a custodian of this information, repository.
That's what I was thinking.
You see, we do intimate in MLC cases, and we go ahead with decisions. We do because as a repository of information, it is not exactly as an approval from the magistrate. So this was clarified in court, sir, because this is not approval anymore. It is only as for record keeping. You need some custodian. It may be also, it can also be either panchayat, municipality or panchayat.
Will it be by
Yeah.
email or will it be by?
Email. It's not been mentioned, but we clarified verbally, that it can be through any digital process as well.
So we just send a mail and that's it.
Exactly.
It's again a perception. It is not when they say convey, again it's a perception which has not been defined how it is to be conveyed, and it's been left open.
It's been left open, but I think,
That can
yeah.
become a gray area and problematic.
Now we have got,
Closing a loop, that's all it is. As long as you've informed, it doesn't matter.
exactly, that was the understanding, because we went into it in court. You got the court proceedings all recorded now. So what I want to say is, this is doable. Now, if you, yeah.
When you say court proceedings are recorded, the recording is available?
Yes,
It's available
it's
somewhere?
available on YouTube, I guess, or in, yeah,
Then we have
or
to
on,
make sure-
or in the public domain. It's available in public domain.
Yeah, we have to make sure that access is there.
Yeah.
So if something comes, then that
Yeah.
access is very important.
Because we went through all that. There is, in the public domain it exists. So I'll end here.
There's one more.
Yeah, there's one more small point I have to clarify. So you see, so WLST is doable. The first step we must take in our own settings is, we get some doctors empaneled by the local CMO. If you get it empaneled by the local CMO, then the whole process can be within the institution. And in any case, many doctors are involved in any patient care, right? It's not just a single person. So the court is against having a unilateral decision making. It wants to see a collegiate decision making, a group of people taking the decision. So that is followed, and then I agree, information that they have not specified anything more than that. You can see the court proceedings. It only says intimate the magistrate's office, right? That's all it says. It doesn't say you wait for any no objection or anything.
Just one more.
First board 48 hours and second board 48 hours. Yeah. So what I'm saying is, between the first board and the second board, 48 hours. No, if there is a dispute, the family or the medical team has the option of going to the High Court. Not magistrate, it says High Court. Right. Now this is, so what has happened is, this is a difference between the 2018 judgment and this. That the 3-tier has come to 2-tier, and the 2 tiers can all be within the hospital. And we need to only intimate the magistrate. We don't have to wait for the magistrate's visit to endorse what you're doing. Yeah.
There's just one more slide I want to run through all of you. That is about DCD4 pathway. When there is a brain death, second step is already done and is a cardiac arrest. This part is quite clear. The second pathway is where the cardiac arrest occurs after the first set of tests of brain death is completed. And the PGI team is here. This is what they do. They put an automated, yeah. So you put an automated machine, and why don't you come and talk to him? Just explain what you do. What we want to discuss is, very quickly before you get on to it, what we want to discuss is whether this 30-minute CPR in a brain dead person is warranted or not, because 4 people have already established that person to be brain dead, and if you do a 30-minute CPR, the quality of organs is going to go down. So the pathway 3 that we could consider is that if there is a cardiac arrest after the first set of tests, we have a do not resuscitate form signed by the family, and if we have that document ready in an unstable patient, we do not have to do the 30-minute CPR. So this is what we need a comment. You guys are doing pathway 2? Yes. At least your paper says that? So Do you think this is the way or this is the way?
Thank you.
Neither. I'd hope that we all go to Mastic 3. The thing is that we have to realize what's happening on ground. And Dr. Shroff has already mentioned in our previous meeting, you do have a significant fraction of proportion of brain dead donors who go into cardiac arrest while being maintained in the ICUs. The PGI ICU team is now gained quite a lot of experience in managing these patients. So our DCD rates have actually gone down. But as other hospitals take up DBDs, you will find that you have these patients come up. And I'll be very frank, this is not a PGI model of going ahead with DCDs. These are what I would say, in my slide I've mentioned them as targets of opportunity. You had the opportunity presented to you and you took it. But this is not how we want to go ahead. And I would say it's wrong to characterize that as CPR in the sense of resuscitation. It's more of maintaining organ perfusion. And the automated CPR machines allow you to have reasonably good. We have saturations about 85, 88% on the peripheral pulse ox. That's the kind of saturation that we sometimes get, most of the times what we've got. And we feel that there's a big difference in those who have external cardiac massage done to them versus donors who do not. And this is important to realize. The reason why we had to do this is the cardiac arrest did not happen with an OT on standby. If you have an OT on standby, I feel this is the way to go ahead.
Could I make a comment on
Sure,
that, please? So the issue here is you have a lot of ethical, professional, and legal issues by doing CPR. Because you're doing CPR on somebody who's already been declared brain dead, right? The whole purpose of withdrawal of life support is that you will not restart or attempt any resuscitative procedures. And if you were to monitor the cardiac physiology, you will find that you have restarted the heart, right? So the easiest thing for you to do, given that the kidneys are very resilient to ischemia, is just to put in the abdomen cold saline or anything that keeps it, like you can do for the lungs, without CPR. CPR will destroy all the other organs, and this sort of DCD pathway has to convert as many organs as possible.
Agreed. Totally agree with that. And again, my presentation addresses that part, because as per the original Maastricht treaties, Maastricht 4 was uncontrolled, because that's I believe these were the circumstances in which they started off, but allowing you to start organ cooling while in Maastricht 4 allows you to convert that from an uncontrolled to a controlled DCD, whereas your Maastricht 5 still remains uncontrolled, because you had the chance in those DBD patients to go ahead and prepare the organs for cooling. Was I able to make myself clear? No?
We got it.
Maastricht 4 was
I'll quickly introduce Dr. Kumud. He is the person who's done the first DCD heart transplant in the world. So I think wonderful to have you here. And his only contention is that so far whatever DCD we have done in India, we can at best retrieve the kidneys. So we need to have protocols with normothermic regional perfusion to go beyond kidney to the liver, lungs, and eventually the heart. And sir, can we have a comment from the professor at the back? Yes, thank you.
So there's 2 points here. If you have somebody who's been declared dead by neurologic criteria, then your do not resuscitate CPR is irrelevant, because that patient is dead. A do not resuscitate only refers to live patients. So that's the first thing.
Why we doing this is because in India you need 2 sets of tests.
Correct.
So the second one, the patient has not yet been certified brain dead.
Right. So just to clarify, because sometimes you will have a brain dead donor who arrests, it's okay to do CPR in the brain dead donor. Now, if you decide to convert the brain dead donor to a DCD donor, anything that you do to restart circulation in the DCD donor negates death. And this is the issue that we're getting into as far as the ethical issues in the United States, because abdominal regional perfusion, I don't think anybody has a problem with. Thorax, taking the heart, thoracoabdominal, we have a problem with, because even if you clamp the vessels, and people are saying, well, DCD, the final pathway is loss of circulation to the brain. Loss of circulation to the brain is the final pathway with anything. But that's not what our laws say in the United States. It says loss of circulation. It doesn't say loss of circulation to the brain. So if you restart the heart in somebody who is a DCD candidate in situ, then you've negated death. That's the issue that we get into, because now what you've done is restarted circulation. That's where ex vivo becomes more appealing, because you can take the heart out. Taking the heart out that is in mechanical asystole has nothing to do with the death of the patient. They've been declared. And if you put it on a machine and perfuse it, it has nothing to do with the donor, because it's ex vivo. Anything in situ that restores circulation or reanimates the heart negates death, at least in the United States. And that's the ethical issue that I think every country is going to grapple with. Australia said, no, we're not going to do that. Canada's kind of up in the air. UK says, yeah, we can do it.
So just to cover that, two important things throughout this meeting, two phrases that we need to change is, one is ex vivo. There's no such thing as ex vivo in a dead patient, all right? The only ex vivo is when living donated or domino hearts. The other one is cardiac death. We should not be referring to cardiac death anymore. It should be circulatory death, and in fact, it will be changed soon to donation after circulatory determination and neurological determination, to take away the onus on an individual organ to cause the death, i.e. you're respecting the death of the individual. Okay, now going back to here, we have to be cognizant, as was pointed out by the previous chair, of where we are in India. We need to find a solution that works in India. So whilst in Australia, the reason when I started, we did a direct procurement of the heart, asystolic heart, and reanimated on the machine, because the Australian law does not allow you to restart the circulation in the body of a person who's been determined death by cessation of circulation. That would mean I would actually be, theoretically, condemned with first-degree murder if I restarted and then took the started heart out of the body, right? So that was a no-go area, and that's why we had that protocol. In the UK, it is permissible to start ECMO in this patient to revive the heart in the donor, as it were, by clamping the head and neck vessels. Now, we met in Canada for a consensus meeting, and I raised the issue that by clamping the head and neck vessels, when you're perfusing the abdomen from the inferior epigastric connected to the mammary artery, could theoretically still create a problem. That created havoc in Canada, and Canada is still not convinced that the NRP is the way to go. However, if we can make sure there's no flow to the brain, then the NRP right now, taking a real leap in the United States and in parts of Europe, is actually the best way to go for India. Because you see, if we can just stick to MASTIC 3, all this 4 will just come into it without any issues. So let's stick to 3. We can protect your kidneys by just giving a cold flush in the abdomen. Stop doing the CPR. We can do that with the lungs. And the other one we can do is failed resuscitation in the hospital, right, of people who can also donate hearts and lungs and other organs by Wickensill and so-called saline and so on, and has been done. So let's not concentrate on 4 minuscule numbers. I know it's helped the kidneys, but we need to think about other organs. And then 4 will just immediately be adopted and become a very easy step without creating problem in the community. And the final thing I'd like to say on CPR is that we're sending the wrong message to the relatives, community, and families. They'll think, what the hell are you doing CPR on somebody who's dead? It's just not possible.
What is the solution that we found in Italy is in the definition of death. We have a unique definition of death. That is the failure of the brain function. We have 2 different ways to demonstrate this, direct neurologic criteria or cardiocirculatory criteria, but the definition is one. So in Italy we do not even speak of brain death. We speak only of death, two different ways of determining. And in this context, in Italy, there is no conflict in restoring the circulation in a DCD donor, because these do not contradict the definition, the principle of the definition of death. I think that probably can be a way to solve this. Yeah.
You did mention one thing, I'm sorry. It's important in the Italian context. In the Italian context, if you restart, you have no professional, ethical, anatomical, physiological problem, because you have to wait 20 minutes in your stand-off period. While elsewhere, it's 5 minutes, universally recognized, outside of a few countries, and 2 minutes with those states and jurisdictions that abide by the Pittsburgh Protocol. Yeah. Russia, it's 30 minutes.
5 plus 5 in UK, 5 minutes of no touch and another 5 minutes of no activity. So what about this ethical issue that I am projecting? The cannulation of the iliac vessels. In India, I think we should follow the post-mortem or the ante-mortem kind of situation. What do you suggest?
At least if you want to go in for type 4,
We are talking only of type 3. In a type 3, we're drawing support, and do you think we'll have to wait for the 5 minutes and then move in, or in India we'll be able to put the cannula before that?
After talking to the family, taking.
We could do before also?
But you have to explain.
So there are very few jurisdictions that actually allow you to put cannulas in.
Yes.
Spain, US.
I think Netherlands and one other place will allow you to locate and maybe put a guide wire or something in. So I don't think in India you're going to suddenly be able to put pipes and things into somebody who's not yet dead. They're not a donor yet. That only becomes a donor after 5 minutes or 20 minutes or whatever time of no touch.
I think so too, yeah. So why the time is right for DCD3 in India, I think all of us would agree here. We are short of organs, we have a shortage of ventilators, and if we keep people who are futile, there's no point in treating further on ventilators, we are reducing that further. And as one day, very nicely during our 1 year of discussions, Kumud only mentioned that Lama Dama is actually the left against medical advice is nothing but DCD3 without donation. And we do so much of that in our country. And with this new judgment now, I think 2023 looks promising, and I'll take this opportunity to invite you. We already planned the international meeting. This will be under the aegis of NATO. We'll have ISCCM and everybody on board. Kumud has kindly agreed to switch his travel dates to be with us. Marty will be joining from Spain, and please note the date, 5th of August, we'll be deliberating this. And we'll come out with a guidelines paper before the meeting, which will incorporate the new Supreme Court ruling. So we'll be working on this about 40, 50 of us, and then we meet again.
Just before, the thing is, yeah, we need DCD, and you might have all your protocols done. This situation has been there for DBD for the past 15, 16 years. And we're still lagging behind in DBD itself. We just heard them say it's mandatory. There's a mandate which says that you have to diagnose DBD. We're nowhere on that path. And you're going to have the same problem with DCD, and you'll find that these individual centers who have started off don't expect the system to fall into place. The system is already in place for DBD. We're still lagging behind. It's all individual work which matters.
Two short final comments. One is just on this. DCD is not the ideal. It gives far fewer conversion of safe and good outcome transplants than a normal neurologically determined death donor. It's controlled. And so I know DCD has become a very sexy thing and everybody wants to do it. But the question is, why do you want to do it and what you're trying to do? And it's not appropriate for everywhere. In a country where we have just heard that the donated organ is a national resource, because if I can't place it in this state, NATO will offer it around the country. But there's no money at all to transfer that organ, that resource anywhere else except for a relative of a patient who has a fat wallet to be able to move it, right? Notwithstanding some wonderful things that are happening like Gujarat Aeromedical Services and so on. And hopefully they will all be linked, as was anticipated. So in the absence of that, then you have to think with the DCD, how are you going to do the liver and the heart, very sensitive for ischemic time, and the lungs. The lungs, you don't need anything. DCD lungs work beautifully. Just take them normally, cold storage, take them out. I've done lots of them. Australia has been doing that for years. But the liver and heart, so far, unless you do NRP, you're going to need machine perfusion, which in India is just not going to be possible at all. The final thing I'd like to say is we have an international panel here, and I often see this happening at the conference in India, that you say things from outside, and as the gentleman previously said, yes, but this is a different thing, you might do that elsewhere, but not in the Indian context. Well, nobody's trying to force these things on India. We're just exemplifying and trying to highlight things that work well. And so not to reinvent the wheel. So all we're saying is consider these as options, not that anybody's trying to impose it. And that's why we have a lot to learn from Italy, because when I was there in 2003 to 5, what you're saying now was very much prevalent in a place like Sicily, where majority of families, when they have somebody dying in the hospital, they do the lama. They want their relative to die at home. I've given methylene blue to relatives to take home in the ambulance to keep their relative alive till they get home, and had my name in the newspaper thanking me for the care, right? While in North Italy, if you die in the hospital, it's a mandatory autopsy. So we have a lot to learn from the way it's evolved.
Another thing that we probably have to avoid is to mix together two separate aspects, that is end-of-life procedure and DCD donation. There are two different problems. It's very different, because if we talk about end-of-life procedure connected with DCD procedure, I think that there is confusion. So the first thing, if you want to implement a DCD program, is to set up protocol for end-of-life in the intensive care units. Then DCD donation will be a technical problem, but you have resolved the most important aspect.
And do you think in India, if we do DCD, our DBD numbers will come down? That fear which the whole world had and never actually was true. The DCD remains and the DBD also remains. But do you think if we try to indulge in a DCD-4 situation, it might just create trouble with our brain death programs? Are we okay with that?
There is a chance, yes.
Yes?
Because
especially if we do CPRs?
Definitely, but you see, the population isn't as well informed, and they would just default to what they see, want to accept, which is a flat line on the screen.
I can speak loud. The answer to the question is the reason why many of these DBDs got converted to DCDs. One is not all the signs of brainstem death were really positive in them, and many of them were getting unstable. So hence the organ donation team, the call to them was triggered. But as a result, I think there was no doubt it was overused. And also the pressure on the beds. Per capita beds in UK are much lesser than in Europe, and even in Europe actually. And there is constant pressure there. So therefore, once the futility of a treatment is decided, not in such a complex manner as it is being shown, and there are some good reasons for doing that. It is just a decision between two concerns. Once they meet together and they decide it is futile, they talk to the family and you withdraw it. What I'm trying to say is that just to shorten the stay in the, just to make better use of ICU, that is another reason why many of those DBDs got converted to DCDs. Per capita organs retrieved from DBD is something like 3.8, 3.9. In contrast, only 2.6, 2.7 for DCD. But yeah, your doubt is very, very valid, and we have to really take it with a lot of, you have to keep it on our mind, we have to really make ourselves aware. Yes, let us not really let a good organ donor get converted to not so good one.
Yeah, when you begin to think about this, we thought about this in the United States. If DCD increases, then the number of brain dead donors is going to decrease. That actually didn't occur at all. In fact, the number of brain dead donors continue to go up, and the number of DCD donors continue to go up. So that's not an issue. What you worry about as you roll this plan out, or this protocol, or whatever it's going to be, is what or how are you going to gain the trust of the public? And if you can't gain the trust of the public with brain death, you will clearly lose it with DCD. This goes back to how the public gets educated. If they read newspapers, which some people do, that relies on us reporting the news accurately. Most people don't. They go to their tablet, they go to their computer, they look at Dr. Google, and they look at all these stories about people killing people for organs. That's the bad doctor. That's the bad medical system. And it just fosters more mistrust. So we have to find a better way to educate the public on the good that donation does, to reinstill that faith in the public, to know that we're doing this ethically, it is ethically sound, we're not killing people to take their organs.
Thank you. So I think this is where the public hospitals need to take the lead rather than the private paying system. So I think we are short of time. Thank you, Deepak, for allowing this wonderful meeting. Thank you, everybody. Any last minute comment? Yes.
I'm not trying to be over smart here. I'm not in favor of, money is offered rather than incentive. But I think we are talking about families who are really struggling. Suppose they have taken their patient to the hospital, let's say private, or in government sector, there are some bills to be paid. If there is some agency in Tamil Nadu able to pay for some of their bills, it may be an incentive for them to donate. But we have to really be very cautious, because if we are on a slippery slope and we are really treading on a very thin rope, because it can easily be interpreted as if we are trying to bribe them.
Thank you so much. Thank you, Dr. Kumud, for coming all the way, Dr. Mani, Dr. Massimo Cardillo, and Dr. Avnish Seth for this initiative. And we look forward to August meeting, and I hope we'll have something more positive. So from one controversial topic, we move on to another controversial topic. That is, do we need to change our law from opt-in to opt-out? We have got two extreme speakers, and I've just flipped the role because it's okay, let him talk first. No, the reason is different, because let us first of all hear what is in practice.
No, let him do that. This is new. Let him speak first.
So you want to speak?
Yeah.
Okay.
No problem.
So
Otherwise I leave in the middle to catch my flight.
All right. I hope you did not make friends with each other in the last 1 week.
We are very good friends. Very good friends.
That's not nice for a debate. So let me call upon Dr. Anirban Home Chaudhary. He will be putting his views in about opt-out donation is the only choice for facilitating organ donation in India.
Thank you, Dr. Deepak. At the very onset, I wish to thank Dr. Deepak and all the organizing committee members of the annual Neurotrauma Conference for inviting me and giving me this opportunity. So this is an interesting debate. The motion here on the motion before the House is, in the opinion of the House, opt-out donation is the only choice available, is the only choice left to facilitate organ donation in India. So we don't have any moderators, so I believe the entire hall is jury to this, and my good friend and colleague Dr. Ishwar will be, I am defending this motion and he will be speaking against the motion. So before I start, respected jury members, I just want to ask you, how many times in a day when you open your mailbox and you see some newsletter with a small microscopic writing that if you want to deliver, just click on the link below, which almost you can't see. So every time, how many times when you go and order your favorite dish in KFC or any other joint, the waiter, the first thing that they ask you is, what's your mobile number? What is your contact number? So our life is actually encased or engaged, whatever way you may say, in opt-in and opt-out options, and for that we need to thank one gentleman called Larry Wall, who first brought this opt-in and opt-out option when he created one computer program called Perl, P-E-R-L, Perl, and this opportunity was immediately grabbed by the industry because they found it a very good and innovative way through which they could spread their messages. So opt-in and opt-out option was used by the industry when it started in a computer program called Perl, and that's how it gained its acceptance in our society and in our practice. When we talk about organ donation is something which was talked about even 5,000 years back according to the Vedic Hindi in Indian traditions, because we have seen that our Brihadaranyaka Upanishad has said Purnamidam Purnamidam Purnat Purnamudachyate Purnasya Purnamadaya Purnameva Vashishyate. That is, when a whole is entering into a whole, W-H-O-L-E, not H-O-L-E, then nothing is incomplete, everything is complete. And therefore we see the great sage Dadhichi, who donated his life, who gave up his life so that his bones could be used to build that weapon by which the gods fought against the Asuras or the demons. So the concept of donation is not new. It has been there before also, and if we look into the other religions of the world, we may not find that glaring or bold examples, but there was very clear-cut message as far as this phrase in the Bible in Matthew 10.8, that freely you have received, freely you should give, which supports or rather endorses the entire process of organ donation. And so does the Quran in this verse of 5:32, when it has been indirectly found to, I won't say it supports organ donation, but it says that saving one who has saved the life of a person as if he has saved the life of all mankind. So organ donation is something on which all major religions have a common standpoint, and that is to support, and we can always say that all the religions support organ donation as an act of compassion and generosity, because that compassion and generosity may not be evident directly, but it is evident indirectly. Now go straight into, I am going to the facts which I am sure my learned opposition member is going to see and take down for him to debate upon. If you see Indian organ transplant history, in the recent past, the second highest number of transplants are taking place in the country, but the majority of organs are donated by living. Take it there only. I am coming to the other slides also. But if you see that the number of living transplants between 2012 to 2018, there has been a marginal fall. I am not saying a steep fall, marginal fall, but there has been not much of rise in the disease transplants. That is also clearly evident from the data, whatever is available. Now, this diverging trend in organ donation, where the disease is donation actually coming down and the percentage of live donations is increasing, puts us in a catapult situation. Why? I am again coming into that. But before that, if you compare, this is the diseased organ donation rate. We have heard enough. Spanish models, US model. Spanish model is what? Opt-out. Why opt-out? US model is opt-in. So these questions have been answered many a times in different ways, because there are different ways of looking at a particular thing. But one thing, it is clear that the disease organ donation rate is low in India. It is falling further, and the wait-listed patients are increasing. And just in the city of Bombay, you can see, this is the Mumbai, the number of people on the wait list in the city of Mumbai for kidney transplant is 3325. This is 2022 figures. So there might be some variation now. What is important is that if we consider that the number of transplants are rising and the organ disease donation is reducing and only live transplants is rising, then definitely the number of kin to the relatives are not increasing that much. So what important thing that is occurring is there is organ trade is definitely working, which clearly comes out from the data which is available to us. When Thota was framed in 1994 and subsequently modified in 2014, it was attempted that it should not be there just to promote organ transplant, but also to reduce organ trade. Now, what might explain this difference? If you see the effective consent percentage, which is high in countries with the opt-out, which are in blue, against those in opt-in consent, you will find that this variation in the consent percentage which is coming out is actually by the power of defaults. What is this power of defaults? It has been clearly proven that if there are three core components of the consent policies, one lies with the family's preferences, which can be favorable, unfavorable, or unknown, and another is the disease preference, which can be consent, refusal, or unknown. If you look into this side, the third column on the right and the third row applies to default, which means that disease preference is unknown, family's preference is also unknown. Now, this study has shown that if we can just convert this section alone, the total number of possible donors increased from 55% to 69.5%, and that was in 2020 data. This can vary and more, and where in a country where the awareness is less, this can increase manifold. That is, from 55 it can go up to 75 or 80, because that proportion of default applies, that third 3 versus 3, the third row, third column, that will increase. It has also been reported in the study in Australia that absence of significant dissent should be sufficient for disease donor organ procurement in New Zealand. So I take this note of my learned opposition member that he has to ponder upon before he debates on this opt-out option. Jury, please, you have to note that this opt-in and opt-out option has other glaring examples which have proven this fact. Now take this simple case where it was in the Walt Disney themed restaurant. They once discovered that a lot of children, they were into all those foods containing this Coke, etc., which were unhealthy choices, having a lot of calories. So by default, they changed this option from soda to juice and from French fries to fruits and vegetables. That if you wanted to have French fries instead of fruits and vegetables, you have to change and purposefully go and click on that, because when you enter these 3 parts, you get a coupon, and in this coupon your food, etc., is free. Now when they changed it by default to fruits and vegetables and juices instead of soda and French fries, they found that the kids consume 21% fewer calories and 40% less fat and sodium. So that was something which was not possible by mere education, or just by educating the parents that that this is a good option. So this default can clearly nudge people and influence their choices, and these choices can be streamed towards betterment. There was another study, if you can note it, that in these questionnaires were given to people from both countries which had an opt-in policy, like Netherlands versus Belgium, which had an opt-out policies, into deciding which of those acts were considered not so big, or yeah, it's very big deal, not so big deal. So you can say that voting for mayor, not a big deal, paying for your taxes, not a big deal, letting other people go ahead of you in queue, not a big deal. So like that, volunteering for a dangerous military assignment, oh my God, that's a big deal. So that was the range, this was the spectrum. Donating your organs when you die, where you see where it fits in the opt-out country, the donating organs is viewed as not a big deal. Whereas in countries which have opt-out policies, donating your organs when you die is not a big deal. But in countries which follow opt-in policies, there it is a very big deal. It is almost like giving away half of your wealth to charity. So this so much of difference, wide gulf of variation, my learned friend may please note that, exists in between 2 countries when they practice 2 different paths. So this has a greater bearing on organ donation, and this is organ retrieval. Now also it has been seen that opt-out donations have lower costs, and there has been figures shown that even a conservative 20% increment in organ donation rate, they used it for soft opt-out organ allocation system. This was not the hard opt-out where the family's consent is not taken at all. So in this system they have found that even that resulted in a significant cost saving, again in the quality adjusted life, and a significant of lives being saved. I also request my learned friend to take note of this data, which has been clearly showing that opt-out donations can give cost benefit, which is also very important in the context of our country. Now this was another systematic review of opt-out versus opt-in consent on diseased organ dotation and transplantation between the period 2006 to 16. And clearly it has been seen in this study, if you go by the pure numbers, it has been said that the opt-out consent increased transplantation rate by 38 to 83%, and both opt-out consent increases the donor as well as the transplantation rate, the donor rate, which may be useful in decreasing deaths on the waiting list in US and other countries. These were done because most of the studies were from US, so there were some 51 trials which were included in this systematic review, and they came up with this conclusion. Another important thing, if you notice the difference between England and the Netherlands, if you notice that where there was a change from opt-in to opt-out system, also with a strong support where opt-out was introduced without vote in the parliament, and registration of all donors is voluntary beyond 18 years, against Netherlands where it is not so, where it was passed by smallest margin. In both the cases, you can see that the change to opt-out provides powerful opportunities for engagement, and those are not possible when it is the opt-in system. This is one more study which has been said that most of the emergency patients who do not have a donor card, not registered, this is in Switzerland, 1 minute more, and they had no information on the topic. Even in those patients, organs could be retrieved and the donation could be facilitated. Respected jury, informed consent is a gold standard in Western medicine, but there cannot be a silver lining of presumed dissent. And therefore, the value of life is always measured by how much of it is given away. Thank you very much for your patience. Now,
so we have got whatever the number of audience we have in this hall. Before I call upon Ishwar, can I have a raise of hands? How many of you are convinced with this, or rather in support of opt-out for India? We are in India and we are talking about India.
Aren't we meant to vote first after both debates?
No, we will see the change in the practice later. That's the reason I'm asking you. As of now, how many in this hall feel that opt-out is the way to go for India?
Forgive me, is this as an ideal or for India?
For India. 1, 2. Raise your hand.
I have raised.
So till the time I ask you to lower it down, keep it raised.
I can raise both.
So, I mean, he talked about it brings down the cost. You don't need a legislature.
But I have got some objections to it because it is...
No, we'll talk about it later. We'll talk about it. So as of now, just 3 persons are in favor of opt-out. Speaker, including the speaker. Okay. Let's hear from Dr. Ishwar, who will be speaking in his in favor of opt-in.
Those who have will not raise by default, they will be opt-out for this. Let's keep it scientific.
Respected members of the jury and esteemed members of this audience, I have a flight to catch, but I am not in the mood to concede to my honorable adversary of the day. I'm not heard.
You're heard.
Heard? Okay. Dr. Anirban Chowdhury. Now, the human species is very unique because it has the ability to change its fate. It does everything to preserve and extend its lifespan. No other species has the kind of technology and science that is required for this. As doctors, we are very important facilitators for this human quest for protracting lives. And in this context, that organ donation and related events need to be seen. Now, let me come to certain hard facts of life. One is there are few unfortunate people who end up being brain dead. On the other side, there are very many people who need organs, especially kidneys, liver, and etc. etc. Now, how do we match these people? That is exactly the point of this debate. In India, the tragedy is we have close to 1.5 to 2 lakh people requiring dialysis every day. We have close to 80,000 people at end-stage liver disease, and only 8,000 people get their livers, and most of them from their relatives or unrelated donors at a very big cost. we have about 1.5 to 2 lakhs of people dying every day due to road traffic accidents every year. We have about, according to Dr. Padma Srivastava of All India Institute of Medical Sciences, the renowned neurologist, 185,000 people developing strokes. And a person dies of a stroke every 4th minute. A person develops a stroke every 40 seconds. And there are 766 districts in this vast and diverse country. If one person were to have a brain death and is declared, this can satisfy at least 8 people waiting for an organ. So this is the relevance of our study. Now let me come to what is stopping us from happening. Why is it that we are always debating about an opt-out system here today? Can I have my slides? This is my old one. One more is there. एक और है. Absolutely. No, not this one. One more. एक और है. I gave it to him. He loaded it also. You saw it there. ये नहीं, दूसरा. Can I present my laptop then?
लैपटॉप से प्रेजेंट कर सकते हैं क्या बेटा?
हाँ जी सर. Come. Okay, I go to. Okay. Now, why is it that there is a mismatch between the number of people who are suffering from brain deaths and the number of people receiving organs from these unfortunate people who are brain dead? So there are two sets of unfortunates here. One, the people who are waiting to receive an organ who are not getting it, and the other who are dying without giving up their organs. The fault, dear Brutus, is not in our stars, but in ourselves. We are underlings. If you look at who is the biggest stumbling block to organ donation from deceased donors, we do not have to see far. it is us doctors. We refuse to acknowledge the fact that our patient lying in the ICU hooked to the ventilator without any brainstem reflexes is having something known as a brain death. We refuse to tell the relatives that this is a point of no return. You just say that your patient is critical and we are doing all that is possible to revive him. Many of them are ignorant of the fact that there is something called as brain death, and the relatives are not informed in time of what is happening. The public too are at fault because they are just as ignorant as anyone else about the fact that there is something called brain death. Now, instead of correcting this, we are bringing in a legislation. My honorable adversary would say, vouch for a legislation which makes it mandatory for everyone to donate their organs, whether they like it or not. The presumed consent definitely flies in the face of the informed choice that everyone is entitled to get. Now let me come back to what happens when you enact a law which says that opt-out is possible. Everybody is deemed as a donor. In a country like ours, where compliance with rules and regulations are very poor, the rich and the powerful will get away with everything that is possible to ensure that their relatives don't end up donating their organs. And what happens is the poor will get exploited. The doctors in this country, I wouldn't say, are paragons of virtue. Many of them would indulge in harvesting these organs from very poor people who are ignorant of their rights and end up giving it to them, quoting the law. And the poor relatives of these people will not be able to get anything possible. And by opting for deemed donorship, the greatest fear of every human being is that he will get suboptimal treatment, which is possible in a country where accountability is not very high. How do you see India? And India is a country of diverse communities. There are many religious denominations in our country which does not believe in organ donation or even cutting up the body after death has happened. So when we try to enact a law, we are bringing in something called as a one size fits everybody. We just can't have a law which negates the rights of minorities and other individuals who may be opposed to the idea of cutting up and donating. We may have to respect them. This is a heterogeneous society, and we need to respect everything. Now supposing we bring in an opt-out law by which the 766 districts of India end up donating one cadaver, one brain dead person, giving rise to this thing. Do we have the infrastructure to harvest all these organs and transplant? India, some people say, are islands of excellence. In other words, sea of mediocrity. India are islands of excellence in another way, sea of mediocrity. What happens is many of the brain deaths and certification and transplant takes place in bigger cities. The poor rural folk who are far away from great big institutions, including All India Institute of Medical Sciences and the corporate hospitals, will stand to get deprived of any form of such benefits that can accrue out of an opt-out legislation. We need to take all that into account when we do that. Often law is seen as, and here is seen as a backdoor to ensure that the population is kept in place, in check. Now, in a country like ours, where the public sector and government institutions are not kind of very good in their efficiency, the law is not going to be very effective. There is an interesting quote which I heard many years ago: to make crime unprofitable, you make it a government enterprise. So similarly, this law too would remain a tiger on paper and would not be enacted. Now again, if this law were to be introduced, this would only be seen as a theft rather than a gift. So when I have the opt-in option, I have the right to gift. But when I go into the opt-out option, I have something stolen. This is not morally right. I'm sure my honorary opponent will agree on that. Now, what happens when we have an opt-out. George Orwell in his book called The Animal Farm said, all animals are equal, but some animals are more equal. So people who want to twist to or evade this law will definitely go to any lengths to ensure that they don't have to comply with it. So which means that some of the holy elephants, holy animals will get away with it, while the poor end up paying for it. Now, I'm sure Anirban has quoted several statistics from countries like Spain and other Wales, England, etc., where the number of deceased donor transplantations have increased after a law was enacted. And what happens in Spain, Portugal, and other countries cannot be reenacted because there is a huge cultural gap between the two. Civilizational gap. Now, let's see the difference between our society and the societies of the West. In most countries in the West, in my limited experience, I won't say I have lived long enough to know everything about it. People who are old are left in the care of themselves or in the care of the state. Whereas in a country like ours, the state does not take the burden of this old. So what happens is, our parents and grandparents live with us and die with us. And we are all attached more than any other, anything else to our parents. And hence, when it comes to donating organs, unlike a Western civilization where the state takes a decision for people, this cannot be possible now. So an opt-out option would be unrealistic in a country like ours. Now, let's bring in the soft opt-out option, that is, the consent of the relative is taken before an organ is harvested from a brain that could. Now, when you have a soft opt-out option, if the relative protests against it, you are not going to harvest any organs. How is that different from an opt-in option, where the relative has the right to say yes or no to procurement of organs from a deceased donor? So a soft opt-out option, which has been bandied out as a replacement of opt-in option, is not exactly a replacement, but just in a different shape. Now, let me come to the way forward. Let there be a strong opt-in system. There has to be a donor registry, and every brain death needs to be placed. We have a registry for people receiving organs. We have a registry for everything. But where are the donors registered? Except for a driving license card which says that I am a potential donor. There is nothing that the state knows about. The moment an individual gets admitted into an intensive care, the registry gets a notice to the Aadhaar number saying that here is a potential donor who has been admitted in our ICU. And if he is brain dead, let the family be informed that he has already given consent for organ donation. So this will be a good system whereby there is a gentle nudge by the system to promote organ donation from deceased donors. Now, what we lack in our country is not the ICU beds. ICU beds are definitely in this number post-COVID. What we lack is grief counselors. The number of supporting systems that a doctor needs to promote organ donation from deceased donors simply does not exist in many parts of the world. As I said before, there are a few islands of excellence, but don't see that as a pan Indian. Probably numbers-wise, we are vast. So even those small numbers of people who are doing excellent work will be better than many centers in Europe and North America. But the truth is, vast swaths of this country does not have the resources that the West has. Now, let us first of all appoint grief counselors into the registry. Let us appoint transplant coordinators into the registry. Let us have more infrastructure for transplant. Considering the public health importance of this, we need to have more hospitals that cater to transplantation, not just regional centers. If you look at the numbers of disease donation and transplantation, you will find that it is localized to Tamil Nadu, Maharashtra, New Delhi. Why is it that the North is simply not represented? Why is it that states like Andhra Pradesh and Telangana are not represented? Why is it that a state like Kerala, which is well educated, struggling to find donors from deceased personalities? The the truth is, we don't have the infrastructure for it. We don't have the field counselors. We don't have the transplant coordinators. And more importantly, we don't have the transplant centers for people. Now, how do we negate all this? There should be a national campaign for promoting organ donation. Celebrities should come forward and endorse. Government should make it a policy. And I was very happy when the CBI said that they are going to start course in schools for promoting, for sensitizing children about brain death and organ donation. The Prime Minister and other people can definitely use the show. In recent times, we have had two huge successes in our society. One is, of course, promoting the girl child campaign launched by the Prime Minister. And second was the more humbler one called the toilet campaign, which was also launched by the Prime Minister. This made deep impact. If you see the girl children today, they're more confident of themselves than before because of these two things. Similar such intervention in organ donation can result in majestic and huge transformation of the numbers, and therefore definitely help all those who are suffering and waiting the wait list for an organ. I conclude my arguments with this quote: "Let there be delight in death, and that delight is to help everyone." Thank you very much.
Before we ask for rebuttal from the first opponent, can I have a raise of hands, any change in opinion post second count? How many are in favor of opt-in for India? How many are in favor of opt-in for India? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. How many? 11. How many are in favor of opt-out for India? 2, 3. So 3%. So yeah, the number remains same, including the person who gave the talk. I think both the speakers spoke very well. I mean, before I call you, just still you have your own time. You also can vote. Okay, I'm in favor. I'm in favor of opt-in. So both the speakers spoke very well, and I think both the speakers, both of them want increase in the organ donation rate for the country. Opt-out, again, speaker one thinks that the numbers are going to increase for the country. Even the person who spoke about opt-in, he gave the what should be done to increase the numbers. Let's have a rebuttal, one after the other, and then I'll take a public vote. Thank you, Dr. Deepak. I had presented my case, now I am presenting my rebuttal also against my learned speaker who has presented his case. And it is very clear from whatever my learned opponent has suggested, that like if I talk in evidence-based, if I promote it in a study, his null hypothesis reads there is no difference in opt-in and opt-out policy. Observation is that there will be doctors can be doctored, there will be corruption, there will be theft, we don't have infrastructure, so null hypothesis is not rejected, and therefore there is opt-in and opt-out is same. So I strongly object that, because my learned opponent has showed it in his slide. He has showed it in his slide that the girl child and everything, we never had imagined that all those things would have been possible, but he only said that those things were possible. And when such a thing can be made possible, why not opt-out policy, when such a thing which has been proven solidly with lot of evidences as a successful means where donors can be increased and where the numbers can actually increase without a rise in the cost. So as my opponent has said, is worried about the law, and it is an infringement on the individual's right, I think that law should be one which should be not based on the basis of authority but on the basis of wisdom. I rest my case.
My learned friend Anirban has displayed a lot of statistics to claim that opt-out scheme is good. Unfortunately, the biggest lie among all the sciences is statistics. If I say that ICU is the most dangerous place in the world because most people die in it, statistically correct, but is that factually correct? We need to seek the truth from the statistics. Statistics does not matter in in a something or in an issue like this, because it is a matter of emotion. Donating somebody's organs when, you know, when the kith and kin are going through a crisis is a decision which is taken at emotional distress. No amount of statistics will definitely help in doing that. So the opt-out system is not an idea whose time has come for our country. Let us wait, because you know what the West has achieved, we will also achieve probably in the years to come. We are just seeing economic progress, and now next thing what that will happen is a lot of social progress. Literacy and other things will improve. Connectivity has improved. The digital information now world is dawning before us, and once that comes, then definitely an opt-out system can be exercised in our country too. But then, as of now, as the situation stands, the opt-in system is the best thing that is suited for a country as diverse and as complex as ours. May wisdom prevail.
Yeah, no. I think it's a, let's keep it as a healthy debate without any fist fights or bullfights outside the room. No, you never know, okay, let's have the public opinion. Dr. Avnish said.
Our current system is very good, but we should have an opt-out system for cornea. We need to start with an opt-out cornea and see how it goes from there. Number two, I feel
that's a very good suggestion. That's a very, very good suggestion.
Number two, what we have right now is all of us pledging, but then we have very few people pledging organs. We need to do what Israel does. If you have pledged your own organs, only then you will get somebody else's organs. So we need to promote, we need to get some power into our donor card.
Very good. Dr. Kumud? Okay, Dr. Jay.
My comment is going to be very short. First, I'll say opt-out sounds undemocratic, especially in our country where people are very fiercely independent in expressing their views. But I must really say that when I was just talking to, thinking about what Anirban said, that on 31st March, the income tax department doesn't say, oh, Mr. Sharma, would you like to pay tax or not? It is compulsory. And when he quotes, I must not don't take it personally, George Orwell, that all animals are equal and some are more equal, it applies more to more against opt-in system, because it's going to create inequalities. There's no doubt opt-out system has got its own issues there, but I still think that is the best. And moreover, in many countries, when I would say, I think I should not speak anymore. I better give it
Dr.
to
Kumud?
Personally, I'm a real opt-out person, but I believe in horses and horses. And I wouldn't ride the opt-out horse in India. And in the UK, the fiercest of independence and your own personal right got transformed to an opt-out because of a campaign by a 9-year-old called Max. So he changed the entire UK system. It's called the Max and Kira law after the donor, 9-year-old girl. So it is possible. But it's not possible in the Indian context. What we need to do is increase deceased organ donation first through an opt-in system, because you will get a huge number of donors you won't know what to do with. And I'll give you just demographics of India. When I was in Italy, in Palermo, the donation rate in 2003 was 5 per million population, considered to be almost, should we even bother to start the program? Here we're below 1. If in India you can get up to 4 or 5, you'll be doing thousands of transplants, more than any of your major centers can cope with. You will end up with such a lot of government-owned organs that you won't know what to do with, because it assumes, again in India, that one doctor is the same as another, that one individual can be replaced by another, and that every hospital can do everything. But that's not the case. And so I think the opt-in system is the way to go. And the last comment is, how do you make it work better? The greatest loss in the opt-in system is a relative who says, despite the driving card, as in the US, says, actually, no, we don't want to donate. Or he intimated last night that, he didn't want to donate. Well, you can have, in India it would work beautifully, which is you have a hard opt-in. So you're also used to OTPs in India. I want to donate my organs. I ask my best friend to say, you'll be getting a OTP. Will you please confirm that we've had the discussion, and I do that with my sister. So now I have a family member and my best friend or an advocate who have also countersigned my directive as being a hard one. Unless I revoke it, at the time of our death, it goes ahead.
Thank you
You'll
so
get
much.
lots more.
I think this debate is unending in a country wherein we still deciding how the death should be defined, whether it should be brainstem death should be equated to the death, and we are waiting for the verdict to come from the high authorities. To start the DCT and the opt-out is maybe a few years ahead. That's the ideal way to go. Spain, I think now they are aiming to increase the DCT from 10 to 50% to reach a target of self-sufficiency. So I think on the paper we all probably agree that yes, the best way is to have DCT program, the best way to have the opt-out consent. But I think we need to have something which is suiting to our local needs without affecting the sentiments of the people. We need to be slow. Organ donation, transplantation is one such thing wherein you need to be really very, very slow in your decisions. But you need to be consistent. You need to be consistent. I think consistency will pay and help each other. And this was one such meeting where we came together. We said for last 3 days we have been sitting in this hall. Now the number has thinned out, but the number of focused people have remained exactly the same. So I'm so happy that we all met and we deliberated. Dr. Jogi, I will not stop you, but you can speak, say last word before I say thank you. You wanted to say something.
Coming from afar, I'm not in a position to tell what's best for India. But I do have a question for our friends here. How many in this group have a donor card already signed? How many in this group? So there is an opt-in already working. Therefore, we're in a position to ask. What I was going to say, our esteemed colleague already said, if India goes from 0.01% to 3 to 4 to 5%, and you're still not happy with what you've got, then you may need to consider coming in with opt-in for certain eye is a good one or something else to come.
Having the donor card signed by me does not amount to my organs being given after my death. My family may still say no. So there's so many kind of ifs and buts to the system. So I think the cultural change, the sense of understanding where the society has to come. We need to keep on talking to the public and keep on telling them that brainstem death is death till the time the verdict comes, and the public has to understand the importance of the need of the organ donation. It's a soft opt-in. Spain is actually doing the soft version. They still take consent from the patient family. They still do.
Dr. Deepak, if I may.
Yeah. Yeah.
Dr. Deepak, I just wanted to point that fact out, because when we went to Spain and for the TTS conference, the Spaniards were at pains to point out that their opt-out took years and years of preparation. So, and it is more like an opt-in at a national level. It's like the whole country went ahead and said, let's opt-in to donate.
There are cultural sensitivities which needs to be addressed in India.
Dr. Nakagawa, please.
Who are your two biggest per million countries with donors?
Say it again, come out again.
Who are your two biggest countries with a per million capita with donors?
Spain and USA.
Exactly.
Actually,
Which was
USA
an
is on the higher
opt-out?
side now.
Spain's an opt-out, US is an opt-in.
Yes.
Is there a big difference between the numbers? There is a difference.
But then the system is different. There you have the very dedicated OPUs, or so-called the organ procurement management system out there, and which is managing the entire system. So you cannot just opt in and opt out with just one component of organ donation program.
Exactly. But if you're trying to build trust in the system, forcing people into the system isn't the way to go.
Absolutely.
And the thing that I have heard throughout this entire conference is
Can
the
I have both
mistrust in the
the
medical
proponents
system.
and the opponents on the stage?
I have another example to share with you. Italy is one country. Italy is one country with a unique law, one law. We have regions with 50% use donors, and we have region with 10%, 5 times less. So with the same law, we have so much degree. So I think that probably the law is not the crucial issue.
Thank you so much. So I've got 2 people and the winner.
There is no winner here.
No.
Only that there's an opt-out definitely is going to come.
Thank you so much. Both of them? No. Thank you so much. I want, on behalf of Department of Neurosurgery and our entire team, I really wish to thank everybody out here with my heart and with some of my brain. Thank you so much, and I hope to see you soon. Thank you so much. We have a validity function at the conference hall. Anybody who still has got some energy can join us there, or wish you good luck and goodbye. Thank you.